our opening sessions, I would please like to invite Ms. Karen, Ms. Arijit, and Ms. Ratna. They'll give us a warm welcome and a start, and then we'll start with our sessions, please. Please, a round of applause for the ladies, the backbones and the hard work they have put in and given us a platform today and brought us all together here. Please, ma'am.
I hope you can hear me. And so welcome to the first International Patient Summit. This has been my dream for the last 5 years. And I'd like to thank my colleague here, Karen, who put the dream in me. She was the one who, when I was the chair of IPO, said, we must do something for this region. And that's how the whole journey started. And I've always wanted to do something in India. And here we are putting the whole thing together. And the summit is meant to bring together patient voices from the region. So we have many countries represented here today. It'll talk about several topics that are close to our heart and are often not talked about in this part of the world. We've always been told wherever I was invited as a speaker that this is an extremely diverse, complex region, and to get patient alliances together would be a difficult task. But if we are together and we are working together, nothing is difficult. As we can see today, we are all gathered here and we are working together to make this dream a reality. I would like to thank Karen and Arijit, who have helped me put this whole agenda together and the event together for today. And also thank all of you who have traveled from far to be present here today and to share your insights with us. I would like to thank our sponsors, MSD, Viatris, BSV, as well as Bayer, whose contributions have made it possible for us to gather here today from so many countries and from different parts of India. We have different topics, and I hope you will enjoy the conference. Welcome once again. A small note for the logistics. The washrooms are on the second floor, so you have to go one level down, or you can take the pool side. These are the two places. We have a photo booth, so I encourage you to go and take your picture there, and that is for your social media. The hashtag is International Patient Summit. And you can also, there is a pledge wall, so you can use that pledge wall to sign up saying you are someone who is supporting patient safety. So we are all saying we work for patient safety. And this year, the theme for patient safety was patient and family engagement. So I encourage all of you to go sign there and write a little note on why you feel patient safety is important to you. I'd like to now hand over to Karen to give her opening.
Thank you very much, Dr. Ratna, and advance congratulations for this summit. And to my fellow patient advocates, welcome and thank you for being here. Also to our online audience, I know that there are a lot more patient advocates out there. So we just celebrated Patient Solidarity Day last December 8th, and it talks about the expert patient, the indispensable voice. And truly, we are in an indispensable voice. So with this summit, we hope to be able to amplify and share our learnings with one another. So welcome to the first International Patient Summit. It's my pleasure to be here. Good morning.
Good morning, everyone. On behalf of Heart to Heart Foundation, and also myself, I'm very glad and it's my pleasure to be here and can be co-host to organize the International Patient Summit this time. I'm also very appreciate Rana also. She's very strong and she fight for it until we have this International Patient Summit. And I think even though it's a first summit, but it can be next one, continuing later, and we can have more and more patient organization and other stakeholders to join, make it stronger and bigger, and hopefully we can have fruitful results, especially from the summit this time. And thank you so much to allow me to join, and also everyone that joined this summit. Thank you.
Thank you, ladies. Namaskar and good morning. Thank you, PAIR, Patient Academy for Innovation and Research, Philippine Alliance of Patient Organization, Heart to Heart Foundation, and Dakshama Health and Education for providing us all this platform today for our first International Patient Summit 2023. Please, a hand of applause for ladies and for every one of us here. Ladies and gentlemen, as customary, we begin any auspicious occasion by lighting a ceremonial lamp, by invoking blessings from God and goddesses. So kindly, I would like to invite Dr. S. Vasticharan, I guess he's joining us online, Dr. Sajeev Kumar, Dr. Amita Banerjee, and Dr. J.N. Srivastav, along with our committee members here, to please do the honors, kindly come and mark the start and beginning of this journey that we look forward the future. Please, sir. Our team members, can we have please. Yes, they're coming. Can we have, please join in, ma'am. Beginning of our session and a wonderful day ahead. A warm welcome everyone once again to our summit titled Equitable Healthcare, Co-Planning, Co-Designing, and Co-Delivery. Thank you, ladies and gentlemen. Please, you can take a seat. Please. I have proud privilege to invite our first speaker on stage. I guess Dr. Soumya is joining us virtually? Yes. Dr. Soumya Swaminathan is joining us virtually here, is the chairperson of MS Swaminathan Research Foundation, formerly the chief scientist of World Health Organization, WHO. She is an economist and professor at the Indian Statistical Institute, Bengaluru. A pediatrician from India and a globally recognized researcher on tuberculosis and HIV, she brings with her 30 years of experience in clinical care and research. Dr. Swaminathan was Secretary to the Government of India for Health Research and Director General of the Indian Council Medical Research from 2015 to 2017. Is ma'am online with us? We are honored to have her here. It'll be very good to have her insights and expertise on this topic. Is the connection through? No? Kindly allow us a few minutes. We are looking forward to a very informative and interactive sessions. You can note down or make a note of some queries or some important points if you have. We will have question answer rounds in between the sessions. Thank you for being patient, my audience. We are just trying the connection through.
Hello, good morning. I've connected. Can you hear me? Are you able to see me and hear me?
As much as this online culture is a boon, but there are some bans at times. Ma'am, if we have our next speaker with us, shall we proceed? We can align this online session next. Okay, no problem, no problem. Please. We are trying the connection through. Please give us some time. In our opening, keynote speakers would be covering some important topics here. The topics are inlined as Asia Pacific region as the growing economy of the world. Investments in healthcare are urgent if the benefits of this growth have to be reaped and sustained. How is India leading the way in this scenario? These are some topics on which Dr. Soumya and Dr. L. Swasthicharan will be putting there some light. Dr. Soumya Swaminathan, ma'am, can you hear us?
Yes, I can hear you. Can you hear me?
Yes, ma'am. We cannot see your video. We'll be glad if you all can witness that, but we are happy that you could connect. So I please welcome Dr. Soumya Swaminathan, Chairperson of MS Swaminathan Research Foundation, ex-Chief Scientist, WHO, to please address the audience. Thank you so much. Handing it over to you, Soumya, ma'am.
Middle of my breakfast. Thank you very much. Good morning. I hope I'm audible. Just give me 1 second.
Yes, ma'am, you are very much audible and visible. You may proceed.
Okay. So thank you so much for this opportunity, and gives me great pleasure actually to be with you today, though virtually, not able to come in person. Just give me 1 second. Yeah, sorry about that. I guess there's a lot of online people watching. This is the new normal now. Hybrid meetings. So it's a little bit different for speakers as well as the audience, I think, to be able to accommodate both a physical as well as an online audience and do justice to all. But I'm so happy that this International Patient Summit is being organized. I think it's really, really very, very important and very timely. And the theme is also really excellent. I mean, looking at healthcare provision, particularly in Asia, and at how both all different sectors can take more responsibility and accountability for health. Now, I have, through the years, begun to think about health in a much more holistic way. As a physician, I was used to seeing health in a very biomedical way, looking at patients who get sick, they come to the hospital, and then you look after them, you try and get them as back to normal health as possible. And so it's about sickness, really. And the more I think about it, our ministries of health are really ministries of sickness, because they are focused on the provision of health care. Now, of course, that's extremely important. And universal health coverage encompasses the healthcare aspect of it. But we have to remember that it also encompasses the other aspects of health, which is preventive, promotive, rehabilitative, palliative. So, and in the middle, you have the clinical care, which is the diagnosis, the treatment, the management. So we need to start thinking really about how to maintain good health. What are the upstream determinants and risk factors of health? And we're speaking today in a world which is really undergoing a lot of changes because of global warming and climate change. And things have become unpredictable, not just in terms of infectious disease outbreaks. We've just come out of a pandemic. We don't know when the next pandemic will happen. We know that it will happen at some point, but it's a question of when, not if. So we know that zoonotic infections are on the rise, and that human to animal, the interactions have changed so much because of urbanization, because of deforestation, loss of biodiversity loss, all of the, also because of the warming, the changing patterns of vectors, etc. And all of this means that there's more unpredictability in what is going to happen. At the same time, we also see increasing number of natural disasters. I'm in Chennai, where we have just barely recovered from the cyclone Michong, which really caused a lot of devastation within the 24 to 48 hours that it was active on the eastern coast. And this, again, we're seeing all over the world, all over the country, not just in a couple of places, whether it is prolonged heat stress, whether it is cyclones, floods, droughts. Climate change is having both direct and indirect impacts on our health. And so it's really also important to start thinking about our environment and how our health depends a lot on the environment, and how what we do, our actions, also make a big difference to environmental health. So it's all interlinked. And just to take one example of air pollution is responsible for causing about 7 million deaths a year, according to the WHO. And most places in the world today, people are not breathing air which is of the WHO air quality standards. And certainly across Asia, most countries and especially cities have very poor air quality indices. Now, this impacts not only the lungs, but it also impacts the cardiovascular system, the neurological system, it impacts growth, both physical and cognitive growth of the fetus. And of course, it has very severe impacts on the elderly. So it's, I would say, a public health emergency of international concern. As you know, the WHO has a definition of public health emergencies, which have been so far only infectious diseases. We've had Ebola, we've had Zika, we've had polio, we've had SARS-1, SARS-2 as public health emergencies. We've never had a threat like global warming or air pollution as a public health emergency. And yet it actually is, because if you look at the burden of diseases today, globally, but also in India, then you find that non-communicable diseases are in the number one spot, and they are the ones that are growing. This is, of course, because of increasing lifespan, and we all want to have people living longer for sure, but we also want them to live healthy, not to have the last 10 years of their life plagued by a lot of combination of chronic diseases, which is what is happening today. So the burden of non-communicable diseases is increasing, firstly because of increasing lifespan, but also because of the risk factors. Like I mentioned, air pollution is one of the major top 3 risk factors globally. This includes both indoor, that is household, as well as outdoor or ambient air pollution. Dietary risks, so that is poor diet and diets which are nutritionally inadequate, leading to both undernutrition, overnutrition, and anemia. And then, of course, the risks, again, of high blood pressure, high blood sugar, physical inactivity. These are all risk factors that people can do something about. Of course, governments have a big role to play, but so do individuals. And so I think when we are talking about a patient summit, we should think about the healthcare system for sure. How can patients, consumers, civil society, local bodies, self-help groups, advocacy groups, what role can they all play in improving the quality of healthcare services? I've been traveling a little bit in India, but I've also been traveling in other countries to see the primary healthcare system and how it operates. Of course, there's a wide variability from country to country, but also between states or even between districts. And even though, you know, the policies are formulated centrally, the implementation is always, you know, by state, by district, and so on. And therefore, there are different challenges in places which impact, you know, it's not a uniform sort of quality of services that's provided everywhere. But what I've seen is encouraging in that the investment in infrastructure, investment especially in primary health care, the investments in human resources have increased significantly. I think, again, thanks to the pandemic, where everyone woke up, and governments realized that without investing in healthcare, but particularly in public health services and in primary health care, we would not be able to achieve health and well-being for all, which is the SDG Goal 3. Now, we're very far away from attaining the indicators in SDG 3, as we are for most of the SDGs. So the recent update showed that we are off track. The world is off track for 75% of the SDG indicators, and SDG 1, 2, and 3 included. So poverty has increased, undernutrition has increased, partly because of the pandemic and its impact on livelihoods, partly also because of the different conflicts that are occurring, and partly because of climate change, which is impacting the ability to grow crops in areas where previously people could do agriculture. Today, they're not able to do agriculture, and therefore they become climate migrants. So all of these reasons are pushing people to become migrants, affecting their livelihoods, increasing poverty and undernutrition. So the SDGs are at risk, and I think we all need to think about how we're going to address the combined threats posed by climate change, by conflict, and by the increasing burden of both infectious and non-communicable diseases. So as far as the healthcare delivery system is concerned, I've seen in some countries that there is a lot of involvement of the community. And I think that makes a lot of difference, because once people get engaged genuinely, and there is a dialogue between those who are actually providing healthcare and those who are, let us say, the recipients or the users of consumers of healthcare, where there is increased involvement, also leading to increased accountability, responsibility, feedback mechanisms, better communication. All of this actually helps to improve the quality of services. And we've seen examples of where empowered communities, whether they are panchayats or whether they are self-help groups or other groups, they actually decide to take action. They protest if they find that their local primary health care center or sub-center is not performing as well as it should, or the doctor is absent, or there are no medications. And that kind of thing usually has good immediate results. But I think more important than that kind of protest, which can happen once in a while, is a much broader engagement of people, of civil society. And I hope that during this patient summit that you would discuss really how to address the broader determinants of health. Because I think unless the public really gets involved, there's a big movement in terms of how do we go back to eating more nutritious food. We're all now eating far too much ultra-processed food, which is high in salt, high in sugar, high in fat, and does not have enough of the micronutrients and the fiber, protein that we need. Unfortunately, today, even people who are in the lower socioeconomic groups, people who you would think do not have the capacity to consume ultra-processed foods, unfortunately, they are the ones who are most at risk, both because of the marketing of the companies that are actually selling these products, whether they are beverages or foods, but also because they are available to them in affordable, smaller portions or packets or bottles, and therefore they find it more convenient, more affordable, and easier to access than nutritious food, which of course means you have to put in some efforts. You have to purchase the healthy food items, and you have to cook them, prepare them, etc. So we need to think about how do we make nutritious food more available, accessible, and affordable. We have to act, of course, on water and sanitation and housing. These are very, very important determinants, socioeconomic determinants of health. And as I mentioned earlier, things like air pollution will require a concerted effort by citizens of all countries working with their local bodies, whether it's a city corporation or whether it's a state government or a district administration, and the central governments to address this overwhelming issue of air pollution, which again is multi-sectoral. So I mentioned at the beginning of my talk that ministries of health today should be called ministries of sickness, because they're addressing the downstream elements of health and healthcare delivery. If we really want to be looking for health for all, we need the ministries of health need to become champions and stewards of policies that impact health, whether these are around roads and road safety, whether it's around, the air and the water safety and the food safety, whether it's around agriculture, what is being grown is what is going to be consumed, all handled by different departments, different ministries. The policies that are made across these different ministries actually have a big impact on our health. And so I think what we want to see is both groups like yourselves as well as the ministries themselves becoming champions and stewards for health, not just for healthcare. Now, within the system, one sees again a lot of potential now for example, the use of digital tools, telemedicine as again a tool that's now become available to us to improve access to healthcare and also improve access to health information and improve health literacy in the population. So I think leveraging the kind of absolutely amazing advances that we have today in the digital ecosystem, and India, of course, has been a leader in this digital ecosystem, and it's been appreciated around the world, including at the G20. What we've been able to do in terms of putting in place a public digital infrastructure that is open source and that's available for anyone to use, to build on, to develop applications. And we've seen how the financial system has been completely transformed by the use of, the apps today that we all use to make our payments. And this has democratized the access to these tools. You don't need, to be somebody with a big bank account and then be able to apply for a credit card. No, anyone can have this on their phones and use it to transact. Now, that's the kind of infrastructure we should be leveraging for health, for healthcare delivery, using telemedicine like we have now, the eSanjeevani program that was widely used during the pandemic. We have Telemanas for mental health. So there are initiatives that are trying to use the backbone that we have, the digital backbone, to deliver healthcare services. And I have seen the telemedicine initiatives making a difference actually in remote rural areas. But we can do much more. We can do much more with both delivery of healthcare services, improving the quality of healthcare services, improving compliance of patients, especially to chronic diseases, mentoring, mentorship, training and capacity building of especially our healthcare workers who are right out in the community, our ASHAs, the community health officers, the ANMs. They need, constant mentoring and capacity building and feedback. That's when they can start also performing better. But as I mentioned, we should also be using the digital infrastructure to empower patients. Patients need to have access to their health records. And this is, gradually happening in India through the Aadhaar cards and the electronic health records. So once people are able to see their own and have control on their own electronic health records, they will be able to share it with anyone that they want to, medical professionals, etc. And they will also be able to improve their own understanding of their disease, its control, how they're doing, etc. So again, it's all about health literacy, but I think having the access is going to be important. But again, communication with the healthcare providers is going to be important. So it has to be a shared responsibility. I think that health is a shared responsibility between the providers and the patients, and it has to be joint decision making. There has to be good communication. It has to be, two ways. It has to be transparent, and ultimately, it needs to demonstrate that the health outcomes are improving. So, with those words, I do wish this conference all the best. I hope that you have really good deliberations, and I'd be delighted to hear back from you some of the recommendations that have come out of this meeting. And thank you very much again. Apologies for not being there in person, but thank you so much for giving me this opportunity.
For those inspiring words. You have, taken us through climate change, through ultra-processed food, to digital, to health literacy. So you've covered the entire gamut of why the patient and public should be a part of any healthcare delivery, and why they should be, jointly making decisions and not in siloed verticals. So thank you so much for those inspiring words, and we will certainly get back to you with a report, and we look forward to your guidance to take this whole initiative forward, not only within the country, but also the region. Thank you for those inspiring words.
Thank you, ma'am, for joining us. We are honored to have you here, and you took given us a plethora of gamut of information for our future endeavors as well. Now, I would please like to invite our next speaker here, Dr. L. Swasticharan. Our guest of honor here is the Additional Deputy Director General of Health Services and Director, Emergency Medical Relief at Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India. He currently leads 3 national-level non-communicable disease programs in the Directorate General of Health Services, Ministry of Health, Government of India, the National Tobacco Control Program, the National Oral Health Program, and the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, and Stroke. We are honored to have you here, sir. Please, the mic and the stage is yours. The audience is waiting to hear you and your expertise. Thank you.
Thank you very much. And Dr. Soumya, we have been growing up, and we have been following her with all the discourses and the wisdom that she has given us through the years. Good morning, ma'am, and also the audience who are the doyens of patient safety in this country. Thank you, Ratna, for inviting me into this workshop. Unfortunately, I happen to be on duty travel in Tripura for some of the schemes of the government, and I could not join you physically. But I'm happy to share that patient safety issue has now become a good part of the ministry's effort, and we know that there had been sporadic efforts in terms of quality index and in terms of efforts which are made in different components in terms of capacity building, etc. But under the whole umbrella of patient safety, we are now working towards that direction in the last few months only, and with the directions of the DGHS and we have already identified one of our central government institute in Delhi, which is the Safdarjung Hospital, as the National Center of Excellence for Patient Safety, and we have also we are also in the process of identifying some more regional centers of excellence for patient safety. So this institutional arrangement is a step against towards the direction of institutionalizing patient safety movement in the country. We all know that even though patient safety issues may be understood in bits and bits by each one of us, we need to have this as a culture in all our healthcare facilities. In the recent past, few days, I had been to Jodhpur, and AIIMS Jodhpur had demonstrated as a safe medication demonstration site for the visiting WHO team in India, and we were very happy to be part of that process along with the Safdarjung Hospital. So I had the opportunity to visit AIIMS Jodhpur, and I realized that we can now embark on identifying many regional centers so that we can all work together in that directions. So this is the institutional arrangement that we are doing from the government of India. Apart from that, we are also in the process of making a portal for patient safety, and we have also finalized some of the technical series on the pillars of the patient safety, and we will soon be launching them along with the portal. And with that, I think we have a very bright future for patient safety. And as I go from one health facility to another in the small state of Tripura, people have started talking about the quality index, the NQAS, etc. And I also talk about the arrival of the possible arrival of patient safety culture in all the health facilities of the country. So this is what I wanted to share with each one of you there, and I wish the workshop a success. Thank you very much.
Thank you, sir. It was a privilege to hear your words of wisdom here. Do we have sir and ma'am online? Then we can really have a photograph. I would please invite, they are online? Okay. I would please invite the OC members to please kindly come and acknowledge and privilege the photograph with please Soumya ma'am and Swasicharan sir. Yes, they can be online and we can have this. As the first session marks today the beginning of this session. You can come on the stage, ma'am. Yeah, we can cover it. Yeah, please come on the stage. Stage. Yeah, here down or anywhere you can come. Dr. Ratna, can we have you on the stage, please? Kindly honor us. Can we have Soumya ma'am and Swasicharan sir online? Yes. No, that we can do. With. Yes, with guest of honor and our inaugural address. Yes, he wants us to move to the side so that we can have Soumya ma'am in the frame with us. Thank you, Soumya ma'am.
You're welcome.
We're obliged and honored to share that space with you. Thank you, ladies.
Thank you.
Moving forward for our next session, universal health coverage as a driver of equity, inclusive growth, and regional prosperity from the lens of healthcare financing. I would like to invite Dr. Sanjeev Kumar, our chair and moderator for today, chairperson and managing trustee, 3 Domain Health Leadership Foundation Chair, India Alliance of Patient Groups. Dr.
Am
Sanjeev
I audible? Do you hear me?
Yes, sir.
Okay.
Dr. Sanjeev is joining us online.
Yeah, do you hear me?
Yes, sir. We can very much hear you.
All right.
Just give
Thank
us
you.
1 minute. Dr. Sanjeev Kumar is the chairperson and managing trustee, 3 Domain Health Leadership Foundation. Dr. Sanjeev has 47 years of experience from PHC to international level, including senior advisor, regional advisor, chief, child survival and development in UNICEF. We are glad to have you here, sir. The stage is all yours and audience is keenly waiting to hear you. Thank you.
Thank you for that introduction, and I really admire what work the Academy is doing to bring issues related to patient care. And thanks, Ratna, for organizing this meeting. I know a lot of effort goes into organizing such meetings with all the stalwarts from not just India, from all over the world. Thank you for giving me opportunity. I will start with where Dr. Soumya Swaminathan left. Ministry of Health. But if you visit any Ministry of Health, including the Ministry of Health in India, which I have been visiting very often, you find somebody looking after non-communicable diseases. You find a section looking after vector-borne diseases. So if you go around the ministry, you will only find the divisions or sections looking after various diseases. And I fully agree with Dr. Soumya Swaminathan. The name of the Ministry of Health actually should be Ministry of Diseases, because they look after diseases. And where does it start? It starts with how do we define health? And all of us are familiar with how WHO defines health, a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. But when you look at it, physical, mental, yes, to some extent we are doing, but social well-being, we neither have definition nor interventions. How do we keep people socially healthy? And the last part is not merely absence of disease and infirmity, but we are practically looking after disease and infirmity in the Ministry of Health. The second reason why this is happening is the WHO health system framework. If you look at the health system framework, from top to bottom, the 6 building blocks are related to medical care system. I won't call it healthcare system, medical care system, the manpower, the supplies. There is no mention of the community. And once or twice when I raised this issue, I was told that community and patients are implied. You know, the whole system is for patients and community, and then you say it is implied. You need to put it up front, right in the center of what health system is doing. And coming to universal health coverage, when you look at health insurance schemes, whether social insurance or even private insurance, all the schemes cover only when you fall sick. So it is called health insurance, but they don't look after health. They look after only when health breaks down. And we have been emphasizing right from the days of Alma-Ata Conference in 1978 that primary health care should be the means of achieving health for all, and now universal health coverage. But in reality, when you have insurance to look after the sick, it only goes to the secondary and tertiary level care system. Primary healthcare system will get ignored if you look at universal health coverage only as medical insurance for people who fall sick. And then you look at they should not incur expenditures so that they fall below poverty line, and catastrophic expenditure on health should be prevented. But that again is looking at only when you fall sick, you should not incur that expenditure. But what about health? To emphasize this point, World Health Organization has a program called Health in All Policies, which looks at health in a more comprehensive manner. 80 to 90% of health comes from outside the Ministry of Health, Department of Health, hospitals and dispensaries. So are we looking at those 80 to 90% sectors which contribute to improving health rather than taking care of only when people have their health breaking down and they need to take care, to be taken care of in a hospital or in a dispensary? When you look around the world, and we will have speakers from Sri Lanka, Thailand, And within India, you have states like Kerala and Goa. They have very good health indicators. Why? Because there has been a lot of investment in the sectors which account for health, not just Ministry of Health. And if you want to make universal health coverage sustainable, you have to address the sectors which determine health, not just confine yourself to those who fall sick. And I'm very happy Dr. Swasti Charan raised this point that when you talk of healthcare delivery, it has to be quality healthcare. Otherwise, you may be doing more damage to the people who come to seek treatment. And very often you see a person who is admitted in a hospital does not die of the condition for which he or she is admitted, may die of a condition which he acquires in the hospital. For example, hospital acquired infection, which are resistant to most of the antibiotics. So we have to make sure that we have quality health care which is safe, and no patient who comes to seek health care in a hospital dies of the conditions which can be acquired in the hospital. The next point I want to highlight is 1978 Alma Ata Declaration talked about health for all by 2000 AD through investment in primary health care. And here we are, 45 years later, 2023, saying that health for all, time for action. What has happened in last 45 years, these slogans are good, but we need to be serious in implementing what is committed. We had high-level meeting organized by United Nations on universal health coverage, which looked at various aspects of health care. And one of the aspects it looked at is providing enough finances so that people can get quality of services when they need, where they need. Sustainable development goals are an opportunity for us to address determinants of health. If you look at the goals, there is one goal related to health, but if you look at all other goals, they all contribute to improving environment, improving air, improving water supply, and so on. So we have to look at how other SDGs are contributing to achieving the health goals. If you confine only to the health goal, then you may not be able to address the health needs of a population in a comprehensive manner. Another point I want to emphasize, it is not how much you spend on health. It is where you spend on health. For example, my figures may be a bit outdated, but it'll give you an idea. In Cuba, average expenditure per capita is around $700. In United States of America, it's close to $20,000 per capita. And if you look at the health indicators, they are better in Cuba as compared to United States of America. If you continue to invest only in secondary and tertiary care, you will be ignoring primary health care. And we have been emphasizing for last 45 years that we need to invest in primary health care. But when you have insurance schemes, where does the money go? Because the money will go when the people fall sick and the insurance pays for it. It goes only to hospitals or secondary care institutions or tertiary care institutions. You will be spending money in taking care of the sick and not really strengthening primary health care. For achieving sustainable health care, it is very important that we invest in primary health care. When we were working on National Health Policy 2017 in India, the policy committed to spend 2/3 of health expenditure on primary health care. We are nowhere close to it. It's only close to 50% as of now, 6 years after the policy was put in place. So very important that when you have these slogans, policies, and documents coming out, we look at implementation framework. And with the implementation framework, you will identify who's responsible for implementation of those activities. And if you identify who's responsible, then you will also have accountability along with it. Then you can hold somebody accountable for doing or not doing what should have been done. So my last suggestion is that when you have activities like universal health coverage, we need to look at what is being planned. What is being planned? Who is responsible for implementing at international level, at national level, at state level, and also at grassroots level, so that you can identify what needs to be done, why it is not being done, and you can take corrective action, and where required, hold people accountable for that. In this panel discussion, we will get a very good insight on what is happening in India and also in the countries which are often talked about when it comes to good example in universal health coverage. We have Thailand, we have Sri Lanka, and we will also have non-governmental organizations who will be telling us what will be done. So I'm very grateful to the speakers in this panel who have found time to join us for this panel discussion. And thanks to Ratna and team for getting these people to come to this panel. Thank you so much. Over to you for introducing the panelists, and then we will start the panel discussion.
Valuable experience and his expertise with us. We greatly value our time, sir. I take the honors to please invite Mr. Rehan A. Khan is the Managing Director, MSD. Sir, can we have you on the stage, please? Managing Director, MSD, India region, serving patients and their families in India, Pakistan, Bangladesh, Sri Lanka, and Nepal. Rehan, sir, has 25 years plus experience in the developed US, Europe, and emerging markets, Middle East, Africa, Greater China, India, Southeast Asia, across the healthcare sector, pharmaceuticals, consumer health providers, leading private and public listed firms as a management consultant and as an investor. Please, a big round of applause for sir. We humbly welcome you here, sir. All ears, the stage is yours. Please.
Good morning, a very warm welcome to all of you. Let me welcome you today to the very first International Patient Summit in Delhi. And a big thank you to Dr. Ratna Devi and her team for organizing this very important event. Pulling together a cross-section of partners from patient groups, patients, healthcare professionals, policymakers, and leaders from not just in the country. I can look around. I think we have many people from other countries as well. So, you know, speeches like this, let me just adjust this. Speeches like this begin normally talking about NCD. They usually mention the work, you know, governments and other partners are doing to alleviate the burden, and then there's a call to action. So I'm not going to disappoint you. These are some of the areas I'll cover as well, but let me just segue just for a few minutes and take you on a more personal journey. You know, I say this journey, as any patient will tell us, when we are diagnosed, we get on a journey. And like any journey, it has its ups and downs. It has many moments of despair, some moments of hope. So let me tell you a little story. 20 years ago, I used to live in the UK at the time. I woke up one morning and my left eye was shut. And no matter how hard I tried, I couldn't open my left eye. over the course of the next 12 months, I went from a reasonably healthy 30-year-old to being unable to walk, unable to lift even a glass of water, hospitalized for many months, first in the NHS and then in the private system. And finally, let me use the right word, was saved by a physician who diagnosed me with a rare disease called Church-Strauss syndrome. It's a disorder marked by blood vessel inflammation, and only 3 people in a million have it. Now, the interesting part is nobody in my family ever had this. Nobody I knew had ever heard of this disease. How I got it, no idea. It's idiopathic. But the biggest challenge that many of us as patients face is this black box around diagnosis and affordability. Dozens of invasive tests, hospital visits, doctor consultations, and months later, it wasn't clear what I was even suffering from. Also, the first and the last thought often that crosses one's mind every morning and night isn't always restoration of good health. It is more financial. How will I be able to afford this? Will I be able to work, follow some of my ambitions? Will I continue to have a job because I was gone from work for 3 or 4 months? If a treatment is found, then the 100-pound gorilla in the room is, how will I survive? So I'm sharing this this little personal anecdote with you, and Ratna Devi asked me, and Arshia asked me to come speak here. I thought, let me share this anecdote with you, because as all of us have gathered in this room, you know, we're trying to make a difference in the lives of NCD patients in diagnosis, affordability, and accessibility. And one crucial step in enhancing access to advanced therapies and curbing this silent crisis of NCDs is therefore investing in healthcare and in the economy. So let me take a couple of data points with you that will shed light on the silent NCD epidemic and the significant burden of NCDs on citizens. You may know some of this data, you may not, but let me tell you just a few data points. NCDs kill over 40 million people around the world, which is equivalent to about 74% of all related deaths by disease. Globally, every 2 seconds, one person under the age of 70 dies of NCD. In India, 60% of our deaths are due to NCDs. And according to ICMR, this has actually increased by nearly 25% over the last 20 years. Right? So massive increase over the last 25 years. By the way, I'm not telling you any secrets. If you look around urbanization that's happening around our country, you know, sedentary lifestyles, massive movement from, you know, rural to urban, this is changing rapidly as we speak every month. What is also interesting, that up to 80% of NCDs can be prevented or delayed into old age through actions that are affordable for many markets, including this one. So the top 5 NCDs, cardiovascular disease, cancer, chronic respiratory disease, diabetes, and mental health conditions, are estimated to cost the world about $2 trillion every year. $2 trillion. That is equivalent to the GDP of Italy and greater than the GDPs of countries like Brazil, Canada, and South Korea. Massive, massive impact on each of the countries. NCDs are also expected to cost our country here in India about 3.6 trillion in lost economic output between 2012 and 2030. Now, if we look at the ambition of where our country is heading, certainly this is a massive impact as a result of disease that can be prevented, or at least some part of it can be prevented. Over the coming decades, the demands on the healthcare system will continue to steadily rise due to a growing non-NCD burden, aging population, and continuing threat of emerging infectious diseases. So there's a significant need for sustained investment in health financing and NCDs. There are 2 important areas. One, the cost of underinvestment in NCDs is substantial. Number 2, sustainable financing is not just an Indian challenge, but it's a challenge all over the world. So for example, when we look at sustainable financing in even the upper middle and high income countries, all of these countries, or most of these countries, are facing an aging population, rapidly rising burden of chronic and NCDs, cancer, healthcare worker shortages, and also growing inequities in access and health outcomes. So that's most people across most geographies need to find a creative, sustainable way to ensure resilient healthcare systems that can deliver on patients' need today as well as tomorrow. Now, just for a moment, let me shift focus and talk about the excellent work the Indian government is doing and our health ministry is doing in making a significant difference in NCDs in India. Let me just take one example. The premature mortality rate for our 4 major non-communicable diseases is projected to decrease by about 14% from 2010 to 2025 in India. I think most people will hear that number and say, well, okay, that's not a massive number. But when you look at the size of our population, size of our patient pool in NCDs, this is a significant shift. Number 2, the government's effort has led to about a 20% reduction in prevalence of tobacco use, which, as you know, has multiple other impacts in health conditions across the board, including lung cancer, etc. Under Ayushman Bharat, persons above 30 years of age are targeted for their screening of common NCDs like diabetes, hypertension, and some common cancers. And also, last but not the least, we have now or will have an HPV vaccine and IP. The government has recently announced it. This is a significant step towards the elimination of cervical cancer, the second most common cancer amongst women in India. Now, while Indian government and other countries around the world are making a significant difference in improving health financing to enable greater access to prevention, screening, detection, this alone can't do the job. All of our partners, whether it's the pharmaceutical industry, medical devices, insurance, we need to partner with the government and health systems to make a sustainable impact. As a global biopharma company, MSD, we have been developing and delivering innovative medicines and vaccines for over 130 years, and we understand the importance of robust, resilient healthcare systems to ensure access and outcomes. This includes the necessary infrastructure, supply chain, very important, health system capacity, and health sector financing. We've been working with governments and partners around the world, including in India, for many years now to identify and diagnose health sector financing challenges and jointly create both traditional and innovative financing solutions. So in the pharma and med devices industry, what can we do to play our part? Let me give you a few examples. We can improve access to best-in-class treatments and therapies through innovative patient access programs that can relieve some of the financial burden on patients, especially in a country like ours where most people pay out of pocket. Work closely with financial institutions to enable innovative financing products to help pay for treatments for NCDs. I'm not telling you anything new here. There are a number of organizations, some that work with us as well, that provide programs where patients can pay on a monthly basis, etc. And finally, invest in building health economic data to support policy and advocacy efforts to enable better access to treatments for NCDs. Now, I know in our country that's somewhat nascent, but in many countries in Europe and other parts of Southeast Asia, this is already well established in using health economic data to drive support for policy and advocacy. In MSD, let me share you an example that we're doing in partnerships with the governments of Tamil Nadu, in Assam, with Navya to strengthen cancer care delivery. Navya is a cancer informatics and patient services company that leverages technology to provide personalized and evidence-based cancer plans. Navya's technology reduces the time oncologists spend on processing a case and increases the ease of mapping treatments to National Cancer Grid guidelines. We're implementing this program in TN in Tamil Nadu, and we recently partnered with Assam Cancer Care Hospital to introduce this program. Now, most importantly, I believe there are 3 important ways the government and public health system can partner with us in the private sector. Number 1, we can prioritize investment in health in national policies and ensure health system readiness and resilience. We don't have to do this, in a country as large as India in every state, but certainly I think it'll be a good start for us to start in 1 or 2 or 3 states as we're doing in TN and in Assam to take this forward. Number 2, secure sustainable and diversified financing, invest more and invest better towards achieving universal healthcare. This is much easier said than done. I think this is a massive subject by itself, but innovative funding streams, including vertically oriented funding mechanisms and new domestic financing models are required. And let me give you an example. We work with a third-party funding body to support patients in one of our therapy areas where we basically pay the interest. Yeah. 2 minutes. I'm very done. I'm done literally in like 2 minutes. So I just want to tell you about this program because this program basically supports patients directly. We pay the interest on this program, and this is essentially supports and funds patients directly and their families directly. And last but not the least, leverage private sector innovation, contributions, and partnerships. So with that, I just want to leave you with a quote from our founder, George Merck. He said, "We try never to forget that medicine is for the people. It is not for the profits. The profits follow. And if we have remembered that, they have never failed to reappear." Thank you again. Thank you for giving me the opportunity to speak to you. Thank you again.
Thank you. Thank you, Dr. Rehan Khan, for giving us a very lucid description of the health issues through your personal story, talking about black box of diagnosis and treatment, and highlighting the importance of dealing with non-communicable diseases. The non-communicable diseases are increasing by the day. What we need to do is invest in these, and he has highlighted, but I'll maybe repeat that again. Physical activity, dietary intake, tobacco, 40% of cancers are caused by tobacco. There are many other diseases. Alcohol, no alcohol intake. So these are the 4 universal precautions you can take against non-communicable diseases. The last point, he highlighted the importance of partnership. Not just in pharma and medical devices, but even in medical care, 70 to 80% of medical care is provided by private sector. And we know from the data that it is increasing by the day. So private sector in service delivery and also in providing pharmaceutical agents and medical devices, etc., has emerged as a very important partner. And he rightly highlighted that we need to work in partnership with all those who are involved in healthcare. So with that, we move to the next speaker.
Yes, sir. Thank you so
you
much.
can
Kindly
introduce
allow
us.
me to
Yeah.
invite our next panelists here. Thank you, sir, for your personal experience will really help a lot to society. Thank you. I would please like to invite our panelist member here, Ms. Aurajit, is a committee member and Assistant Secretary General of the Heart to Heart Foundation, Thailand. She is also a board member of the International Alliance of Patients Organizations, IAPO. She brings over 45 years of working experience in policy and plan analysis and community and civil society development. She has previously worked in the National Economic and Social Development Council for 19 years. She has also worked as a senior director in the National Health Security Office on civil society and patient advocacy, support, and network development for the patient-centered healthcare and patient. We are honored to have you, ma'am, here. Please, a big round of applause. I would appreciate if patients can really be humble and welcome our guests and panelists here. Next, please allow me to invite Ms. Dhanya Vijayasurya, is the Honorable Vice President, Diabetes Association of Sri Lanka, Honorary Secretary, Board of Trustees, Diabetes Association of Sri Lanka, Honor Director, Administration, National Diabetes Center, Sri Lanka, and Honor Director, Administration, NCD Alliance Lanka. We are honored to have you here, ma'am. Please, I would like if you could come and join us on the dais. Next, I would like to invite Ms. Karen, President, Philippine Alliance of Patient Organization, has over 30 years of experience in communication and policy work in various industry, consumer, insurance, travel, and pharmaceuticals, the latter of which she spent of last 20 years. We'll be glad to have your experience and expertise, ma'am. We welcome you here. Ms. Smita Sadashi would be joining us online, a self-advocate for cross-disability rights in India, works for the advancement of the human rights of all persons and disabilities at the national level for the past 19 years. We are all ears, ma'am. I would leave it to the chair. Please, ma'am, The stage is all yours. You can please head the session. Thank you.
Okay. Good morning again, and thank you, everyone, to allow me to speak about Thailand health security insurance today. Can I have my slide, please? The National Health Thailand, talk about Thailand Universal Health Coverage. Okay, that one. Can you make it full slide, full screen, please? Yes. There. Yeah, okay. And next, please. For Thailand, we have 69 million population, 77 provinces that include Bangkok. Next, please. Because I have a very short time, I have to go faster. And the health insurance scheme, we have 3 schemes right now. When I present in Mongolia, they says, amazing, Thailand have 3 schemes. The first one is about civil servants and dependent, about 9 million population. The financing are from the tax. The second one is about social security scheme, about 11 population, that's for the employee. The financing is from Thai, the employer, employee, and the government. And the rest is the universal health coverage scheme for the rest of the Thai population, about 49 million. And the financing is all from the tax. That's all for safety net for every Thai people. Next, please. And there are people movement in support of National Health Security Bill in 2001. 12 civil society organizations, their campaign and success and collect 52,700 about that for Thai signatures in support of National Health Security Bill to the Parliament. And later 5 civil society representatives can sit in the parliamentary commission to consider and rectify the bill. And next, please. And in 2002, next, please, there are enactment of the Health Security Act on 11 November. Under the Act, there are participation of various stakeholder groups, both public, patient, NGO, government, private organization, and local government. There are representatives from NGO, patient, local government, sit in the 2 boards because we have National Health Security Board and the Health System Standard and Quality Control Board together, 2 boards. And also sit in the regional and provincial Health Security Subcommittee. And interesting is about Community Independent Complaint Center. This is organized or run by the people organization itself. Is independent. And according to the Act number 52, right now there are 144 centers nationwide. Next, please. For the objectives of the universal health coverage is to improve health of all Thai people, for equal access to quality of care and accordance with their health needs. And also equitable basis. Right now, sorry, some smoke. Right now, there are 99.4% coverage in this year for the Thai people. And to prevent Thai households from being in catastrophic situation when facing with high cost care. Next, please. And you can see that the catastrophic health expenditure is decreasing. When we have the first establishment of universal health coverage in year 2002, there are 4.6 4.6% of Thai household, and it's decreased to 1.93 in year 2022, about only 400 household. And next, please. Next, please. And the health impoverishment are also decreased from 1.32 in the year 2002 when we have universal health coverage, and decreased to 0.021 in year 2022. Next, please. So when talk about the system design of the universal health coverage in Thailand, first is governance system. We have purchaser provider split. And the purchaser is the National Health Security Office, and provider is the Ministry of Public Health, and including those private sector. And the multi-stakeholder governance system, as I told you earlier, in the board, we have many stakeholders sit together, and empowering and right protection that I will talk next. And there are benefit package comprehensive. This also I will elaborate more next in the next slides. And the service delivery right now, 17,247 public and private healthcare units providing service nationwide, both public and private. And the district health system main contractor, there are about 880 districts in Thailand. And they are ensuring good quality of care. We have hospital accreditation and hospital profile and pay for performance system. The payment is closed-end system as main payment. We have capitation for outpatient and inpatient and prevention and promotion with global budget. For this year, it is $111.5 per capita. Next, please. Yeah, this is benefit package. It's including medical treatment, rehabilitation, and telehealth, telemedicine. They use a lot during the COVID-19 situation. And also high-cost medical treatment and medicine, prevention, promotion service that is a cover 3 scheme. Emergency medical care, they are harmonized. We have 1600 for emergency call. And preliminary assistance for customer and service provider, no fault compensation, that is according to the Act. Next, please. And people and patient participation can sit in every level, both national level, into board and the subcommittee, regional level in 13 regions, because we divide into 13 regions, subcommittee and provincial level, and also local level for the community health fund committee that I will talk later. In the right side, you can see the community independent complaint center that I told you at the before. Is not in the system, in the line command, but they coordinate in every level and every stakeholder. Next, please. And in the Act also include 9 people patient network. You can see in every target group, and also community independent complaint center and patient support center. Next, please. You can see the activity, and in the right hand, that is the independent complaint center is in the community, and people can go and talk about when they have a problem in the service in their case, and they can coordinate and solve the case. And also other activity are in many target groups. Next, please. Next one for the renal patient network. You can see the, can you press further? You can see the many high cost patient network, both heart disease, diabetes, cancer, renal, people with disability, and HIV/AIDS patient network. They are working together and also working with National Health Security Office and also other stakeholders. Next, please. Make them stronger. And also in the hospital or in the healthcare unit, they are volunteer and patient support group. In order to collaborate, they can communicate with the patient and collaborate with the provider. This is in order to make the system more efficient and also peer support, make the patient, they are more comfortable and they can, like someone needs surgery, they will have more comfortable and confident in the surgeon, especially those heart disease. Next, please. And the voice of people and patient can be heard through one is general opinion, because in the Act Section 18, parenthesis 13, they will have the annual meeting of the board. The board will sit and listen to the provider and beneficiary and the patient every year. The second one is Consumer Protection Channel, call center 130. You can see Kun Jin Suk today come together. She used to handle the director of this call center 130. And the 3 is Community Independent Complaint Center, as I told you. And it's helped a lot. It's a coordinate both the provider, both the patient, and coordinate to solve their problem from the access of service. 4 is preliminary assistance for patient. This is according to Section 41. When they have problem and the Community Independent Complaint Center help them, they can have compensates about 400,000 baht. That is about $100. If they in the case if they die or if they have permanent disability, they can get compensated. 5 is Patient Support Center. They are in the hospital, both district level, secondary, tertiary level, and they work together with the provider and communicate with the patient. 6 is Health Intervention and Technology Assessment Program. Work closely with HITAP. This is in order to inform policy decision, to make a decision for the benefit to the patient. Next, please. I have to go faster. It's something is jumping. The talk about initiative. This is important because it is the local and community health fund. The system is they are matching fund with the local government. It's voluntary basis, and right now we have 7,741 fund this year to join for the fund. They are matching in 30, 40, 50, and for the Bangkok Metropolitan, it's 60% matching. And this is according to the revenue and site. The purpose is for community-based prevention and promotion service, and for every group in the community, in order to solve their solve their problem in the community, especially for the NCD, and also later they expand to the long-term care and intermediate care and dementia, and run by the community committee in the committee, and the local head of the local government is the chairperson, and including the health service, health sector, the NGO, and the patient will sit in the committee in order to manage the fund. Next, please. And the other initiative recently exhibited in the 2016 is about long-term care. Both fund, I am the one who involved for the initiative, so I can say it's quite clear. The policy was pilot in year 2016, pilot for 1,000 aging people in the sub-district. In every sub-district, both municipal and the sub-district organization. First, we focus in 100,000 older people with the ADL under 11 score. That means bedridden or homebound aging people. The main concept is the local government will responsible. Time out. Can I have 2 minutes for the challenge from the challenge, future challenge? That is important. I will go faster. Okay, thank you. And the fund is strategic, and the local health fund, that is former fund, is a strategic mechanism. But this long-term care, no matching. There are 6,000 baht from the National Health Security Office go to the local government, and it will top up with that local matching fund. So you can imagine. And they also have another committee to handle this fund as well. Right now, it's almost every sub-district, organization, and municipality have undertake this fund. Next, please. I will go faster. No, sorry. This I will skip, but I will talk in the next slide. This is about the lesson learned from the COVID-19. It changed service from hospital care to home community care or self-care, and curative care to prevention and promotion, especially for screening and vaccine, and technology for the new normal service. You can see they use telehealth, telemedicine, much more, and one-day surgery, and home chemo, home ward, the delivery, the service to their home, and self-test, maybe the same like your country, and digital health. Next, please. I think 2 more slides. Best value of money, we'll talk about health promotion and disease prevention, that is priority, and also extensive use of economic evaluation for the benefit package and price negotiation. It should be central, and bargaining and procurement, and fixed fee schedule. Next, please. This I would like to mention because it's voice from the people and civil society when we have a workshop recently, and they said what needs to be done is 1, improve access to appropriate service for vulnerable group. 2, increase the national healthcare budget, prioritizing expanding coverage. 3 is expand the national drug list that do not require co-payment. And 4, expand civil society role in healthcare planning delivery. I can see it. The five, please. You can see it later. 5 is simplify and improve effectiveness and initiative. 6 is merge the 3 health insurance scheme into 1, as I told you earlier, that amazing, there are 3 schemes. And 7, electronic medical record need to be strengthened. I think everyone understand because you also think that it's important. And 6 is improve women's representative in the national health security. This is important because we are all women. A lesson learned from the USC implementation. First is the crisis creates an opportunity to drive the universal health coverage policy. And that is obvious. We can see obviously. 2 is the pandemic is, sorry. This is last slide. Can I explain a little bit? The pandemic is likely to enable many countries to achieve universal health coverage. 3 is primary care needs, strengthening to ensure easy access to low cost and good service and IT driven. 4 is universal health coverage is the foundation against crisis. And this you can see also. The last slide, please. Future challenge and solution. 1 is preparedness for economic bust because the universal health coverage, this rely on tax only. So we need more and more other source of finance. And importance of sustaining institution capacity to generate evidence for policy formulation. And human capacity, you can see, is the most critical asset in overcome any future difficulty. Demographic transition and long-term care policy, financing and care provision. I think there are another one, but it's okay. So thank you for your attention. If you have any question, please come later. Thank you.
Thank you, ma'am. I'll take a moment to
Thanks.
apologize for the smoke and the discomfort caused. There has been a little fire incident, but it all is under control. Thank you for audience for tolerance. And I'll request
Yeah,
to adhere to
yeah,
the-
let me just highlight the few points from
Thank you.
Orajit. It is always a pleasure to listen to you. I have listened to you in the past, and there are so many things we can learn from Thailand. But I'll highlight only three which you mentioned. One is engaging people and the patients, and it is mandated by law and the policies in Thailand. We need to move in that direction. Second is universal health coverage. You have really gone universal. And the figure you said is 99.4%. I don't know any other country, including developed countries, have such a good coverage. And the third point I would like to highlight is equal emphasis on health promotion and prevention activities. Over to you, please, to invite the next speaker.
Do I just start speaking?
Yes, ma'am. Ms.
Oh.
Dhanya Vijayasurya.
Okay, thank you. I'm waiting for my slide.
Can we have ma'am's slide, please?
Can it be bigger, please? Okay, thank you. I'm going to give you the Sri Lankan perspective of equity, growth, and prosperity to achieve universal healthcare. Next, please. Everyone's dream, or in any country, we dream of health, wealth, and happiness. A strong healthcare system is critical to ensure a healthy workforce. And how do we achieve it? It is through universal healthcare. There are three dimensions of UHC that we have to focus on. Total population coverage to ensure equity and access to all citizens, rich and poor. Quality service needed. It needs to be efficient and effective, and financial protection so that people don't get into a catastrophic situation when they fall ill. Next, please. Sri Lanka is an island nation, low to middle income country as per WHO criteria. It's multi-ethnic, multi-religious population of 21.8 million. Next, please. Next, please. Sri Lanka's public health system is a public and private partnership. We have achieved 66% UHC. The public system is funded and administered by the government. MOH since 1991. HC coverage is prevention, health promotion, investigation, medicine, treatment, rehabilitation, and palliation. It is free to all. Patients can choose their healthcare facility. And there is also a new grievance redressal mechanism, which is web-based on WhatsApp, email. It's digitalized, and we are very happy about it. Next, please. Okay, right, thank you. I'm ever so sorry. Sri Lankan public health system, it's an extensive public health system. We have approximately 1,500 hospitals island-wide, over 90,000 beds and 4 ICU beds per 1,000. Service coverage is 100% prevention, 90 to 95% inpatient in the public health system, and 50% OPD. Primary health care, 2 parallel systems there are. The community health care health services, which the midwives see to, with a focus of maternal and child health. NCD prevention is through risk assessment and health promotion. We have over 1,000 healthy lifestyle units all over the island. Next, please. The next area that I would like to just touch upon is the Ayurvedic hospitals, the indigenous. It's again government funded, free hospital service, 24 hospitals and 4,000 beds. Private is for the people who can afford it. Private health system is regulated by an act and supervised by the government. We have 4,686 beds, and it's concentrated mainly in and around the Western province and the capital. Next, please. We have an impressive track record, unlike not as good as Philippines, but nevertheless, Thailand. We have an increased life expectancy of 77.3, lowest maternity mortality in the region, 29 per 100,000, decreased infant mortality, 2023, 6.4 per 1,000 live births. Doctor to patient ratio is 1.2, whereas WHO recommendation is 1, 20,000 doctors and 2,800 specialists. Nurses, 212, community health service, PHIs and midwives is 27 per 100,000. We have eliminated communicable diseases like polio, malaria, filaria, smallpox, neonatal tetanus and measles, and it has been replaced by NCDs, like in any other country. Next, please. Strength of the public health system. Impressive health outcomes. They spend only 4% of the GDP on healthcare, which is tax revenue, mainly from the government. They have decided that they are not going for an insurance scheme. Due to how have we achieved this? It is because we have mandatory free education and our high literacy rate, which is 92%. And they have been improving the health system fairly frequently. We have good road network, transportation, communication, and quick access to any healthcare hospital or facility. 50% out-of-pocket expenditure is mainly private sector. And I think we have spoken of the grievance redressal mechanism. Next, please. Next, please. Gaps hindering the UHC is we have a policy where we want to strengthen healthcare provision and especially the essential services. However, because of the global situation as well as the Sri Lankan economic crisis, there is a decline in the affordability and funding. We have to also change the mindset of the from healthcare professional-centric to make it patient-centric. This we have to encourage and to make it happen, but maybe it might take a little longer. Healthcare needs to be digitalized, and the digital literacy and culture of innovation, thank you, must be encouraged. Another problem is lack of sustained political will, frequent reversal of health policy when the governments change and the ministers change. Next, please. Knowledge, capacity, and policy gaps. We should improve our the R&D is low, inadequate evidence-based data, poor knowledge dissemination. Lack of clear referral systems, that is, the hospitals that are there, they don't have a demarcated area. We need regular audits on morbidity, mortality as a preventive modality, not for to get redress. Next, please. Measures to make healthcare more patient-centric. We have been inspired by Patient for Patient Safety Network Asia Pacific, and we have to thank Dr. Ratna for this. We have inaugurated a Patient for Patient Safety Network in Sri Lanka in August 2023. It's a collection of government and a huge array of patient organizations. The NGOs like the Diabetes Association and the NCDs, we train young people as voices of change, patient advocates, so that they will be able to someday lobby policymakers by sharing their lived experiences. Patients' Charter for Rights and Responsibilities is also in Parliament at the moment, and it's with the Oversight Committee for Health and Patient Safety, and we hope that it will be, legislation will come in mid-2024. Next, please. Challenges to in addressing the gaps. NCD epidemic, we have 85% mortality rate, 85% are NCDs. It's due to modern lifestyles. I don't have to say what it is about. And the worst thing was our economic collapse in January 2022. That brought on a health crisis, shortage of basic drugs, medical, surgical consumables, and an increase in out-of-pocket expenditure, which people can't afford because of the hyperinflation, high food inflation, and there is less money for OOP, sorry. The biggest loss for us is the brain drain. 1,500 doctors have migrated and 125 specialists from January 22 to August 23. It affects the quality and safety. Already 40 hospitals have shut down and 100 are maybe closed very soon. Worsening health affects disability adjusted life years. I don't have to say these are accepted things, and it will retard growth and prosperity. Next, please. Lastly, we don't have to be negative, and let's replace it with positivity. Hope is a waking dream, said Aristotle. Without dreams, you can't achieve anything. Thank you.
In the interest of the time, I'll come with my concluding remarks after all the panelists have completed. We are already behind time. So we can invite the next speaker.
Hi, good morning, everyone. I'm Karen Villanueva from the Philippine Alliance of Patient Organizations. So allow me to share the role of patient groups in the universal healthcare law. So that's the beauty really of the International Summit, because I'm also learning from my colleagues and fellow speakers. And I can already tell that the Philippines is closer to Sri Lanka in terms of the implementation of the universal healthcare law. And Thailand is many, many thousands of miles away. So I'll focus more about how the patient groups participated in the law and how we're continuing to participate as we implement universal healthcare. But before that, allow me to just talk briefly about who we are, what the patient groups have done, and also what we've been doing to build the capacity of patient leaders. As you know, we celebrated Patient Solidarity Day, talking about the patient experts, the voice that is indispensable. So who we are, we're actually a coalition of 50 patient groups, and Ratna used to be our chair for AYAPO. We're also a member of the Duke NUS Center for Regulatory Excellence and the Capacity for Patient Engagement. And nationally, we sit in various councils and technical working groups helping shape policy. So our vision is very clear. We want to be the unifying body of all patient groups. We don't look at specific disease concerns, but we look at cross-cutting issues. And part of our mission is really to focus on 3 areas: respect for patient rights, universal health coverage, and of course, patient group participation in health policy making. So essentially, these are our areas of concern, and we're very much into empowering patients, partnerships, inclusivity, support, policy making, and access. And this is the PAPO board. So I'd like to just recognize the members of the PAPO board with me today. So Ains Rojas, Nelia Medina, Melam Sin, and Ara Lanorio.
Very welcome, ma'am.
The Universal Healthcare Law was passed in 2019, and like many of the laws around the region, it's essentially to provide financial risk protection and ensure coverage for everyone. Really, the overarching objective is really to reduce financial barriers, allow equity, allow access, improve health outcomes at the end of the day. And we follow a presidential system where there are 2 branches in Congress, the Congress and the Senate. And essentially, the committees, especially specifically the Health Committee and the Trade and Industry Committee, accepts laws and proposals from their constituents, and it goes through a bicameral process until the president approves the law. So here, there's a lot of collaboration with policymakers, as many of you would probably have experienced. It's really a lot of advocacy work, educating our policymakers, working with medical societies, working with various patient groups, really to come up with these proposals. And there were a lot of stakeholder consultations, a lot of back and forth, working with policymakers. And essentially, the patient groups played a pivotal role in supporting the Universal Healthcare Law by essentially participating in the legislative process, ensuring that there's inclusiveness in the policies, and the continuing dialogue with policymakers. So it's constantly collaborating and working with stakeholders. And of course, the critical bit that the patient groups bring to the table is the awareness and, of course, supportive initiatives. So in terms of how do we know that the law is working, it's essentially about impact assessment and looking at the increased health coverage, as mentioned by Dania, as well as Orajit, reduction of the out-of-pocket expenses, which for the Philippines is somewhere between 47 to as much as 90%, especially for catastrophic cases. Of course, infrastructure and health facilities upgrades, reduction in health disparities. We talk about health equity, which is important. A lot of focus on preventive and health promotion. Very important, financial risk protection. Health services utilization, ensuring that there's no overutilization or underutilization. And of course, very important is quality of care. So challenges faced during the implementation of the law, obviously public awareness is a key challenge. So even if there's universal health care, not many Filipinos know that they're already covered. So for some reason, there's a lack of awareness about their entitlements, and that does not augur well for the law. There are challenges in terms of data management and integration. Not all health facilities have electronic medical records. Similar to Sri Lanka and India, we also have challenges in terms of access of patients to their medical records. And of course, policy implementation bottlenecks. So there's still a lot of resistance from the provider networks. In the Philippines, 60% of healthcare is provided by the private sector. So there's a challenge in terms of the costing. There's a challenge in terms of the integration. Also, of course, resource allocation. It will always be a challenge on how to prioritize. Infrastructure, there's still challenges in terms of the availability and accessibility and affordability of healthcare facilities. And similar to many parts of the world, there's health force capacity issues. So essentially, the future steps are ensuring that there's a lot of oversight in terms of the policy, and it's always good to review and look at policy refinements. When we pass a law, it's not cut and dried. There will be implementation issues, and already they're talking about amendments to the law when the law was only passed barely 5 years ago, and implementation has been slow and really challenging. So in terms of the patient advocacy groups, what are our challenges? I think key to that is really the capacity of patient leaders. Globally, WHO already announced the creation of the Civil Society Commission, and that only shows that there's an increasing inclusion of patient perspective in policy development. And so there's a need to step up to build the capacity of patient leaders. Even in PAPO, we face that similar challenge because obviously many of our leaders are patients themselves. So there is also not just a psychological or even there's a physical barrier to building the capacity of patients. But already we see the signs in terms of clinical practice guidelines development. The patient leaders in the Philippines are increasingly involved. And the challenge here is we can't just send anybody. We need to send someone who has knowledge, right, and experience. So that's really where our challenges come in. We're working also with our national health insurance in terms of looking at not just educating patients about social health insurance, but also sitting in benefits development and even participating in quality and accreditation standards. Our health technology assessment is lodged in our Department of Science and Technology. And even in that department, there's a dearth of health economics and health technology assessment experts. What more on the patient side? And then in the local government units, and I was quite impressed with the Thailand model where it's very clear where the patients are participating. So in our law, we have a citizen representative in the local health boards, but that representative could very well be someone doing climate change or gender and equity, and it's not very specific for patient leaders. So we're also seeing the need to have more patient experts that are equipped to look at design thinking, futures thinking, and innovation. We're dealing mostly with the private sector, with business. So we need to be able to speak their language as well, and understand where they're coming from so that we can better collaborate with the private sector. And so how are we building the capacity of our patient leaders? We're doing policy workshops. We have a partnership with the Asian Institute of Management, and we're continuing to educate our leaders. So for example, in 2019-2000, we did a series of policy workshops. We invited speakers to talk about a range of topics to sensitize our patient leaders on these topics. And we did. This year, we finally accomplished a We work with the Asian Institute of Management for capacity building on healthcare leadership and management. And thanks to MSD, Boehringer, Roche, we were able to graduate 25 patient leaders and 5 government leaders. Essentially, it was a module run for 12 Saturday sessions, full day sessions, face-to-face, because we realized the interaction is so much more robust when you see your classmates and you're working on your cases and your analysis. The output is not just to attend the classes, but to come up with action learning projects. We had 5 of these action learning projects, and we presented them during a donors forum where we asked for supporters for these projects. And they range anywhere from medical records to improving financial assistance models. We also did other capacity building workshops, particularly in the area of health technology assessment, which is pretty new in the Philippines. It was introduced the same time that the law was passed. And because of working with them, we have actually one board member who sits in the Health Technology Assessment Council, and we had a workshop where patient leaders tried to fill up the forms. They're actually simplified forms, but still they were a challenge. We did a series of vaccination webinars and workshops. Like many, we're focused also on patient safety and the importance of clinical trials. So essentially, we're advocating that patients not just be passive recipients of care, but really active participants. And going beyond managing their health conditions is looking also at cross-cutting issues and really providing their perspective so that the policies are really centered towards the patients. So nothing about us without us. So connect with Papa. Thank you very much for your attention, and I'll be happy to answer your questions later on. Good morning to everyone.
Thank you so much, Karen, for giving us good insight into what can be done and what we can learn from your experience in Philippines. May I request an equally impressive speaker, Smita Sadasivan, Civil Society representative for the Global South on the UHC 2030 Steering Committee. Over to you, Smita.
Thank you, Dr. Sanjeev. Am I audible?
Yes.
Thank you so much. So, can we make it into a presentation mode? The slides? Yeah, thanks. Next slide, please. So, yeah, we heard a lot from Dr. Sanjeev and other speakers also about the UHC global movement. So I'm not going more into it, but I would like to touch upon the global monitoring report, which is launched by the WHO recently, which is actually talking about the minimal improvements towards health equity, and in the recent past it has come to a complete halt. So it is really alarming, and the state of UHC commitment review is also pointing it out, and it is also showing that while the countries are having a UHC goal and commitment towards UHC, concrete steps to implement is actually there is a setback in that, and there is also no data, a disaggregated data, even with the global monitoring report, where we can't find out like what kind of health inequity prevails, and who is lagging behind. So disaggregated data is all the more important in UHC policies and programs. And the entire UHC global movement is working towards that, whether it is UHC 2030 or the civil society engagement mechanism, or other actors, the multilateral agencies, the UN agencies. But we are lagging behind is what we are seeing in the report, and that is what has been pushed through the 2023 political declaration on UHC also. And a specific emphasis has been put on primary health care and also patient safety and more on health financing. So these should be the factors which we need to focus at the country level as well, because ultimately the implementation is getting done at the country level or at the grassroots level. Next slide, please. With regard to UHC programs and policies in India, we have really a good deal of programs and policies. We have the Ayushman Bharat health insurance program, where it is covering the entire country, and giving a list of hospitals and the kind of treatments and all that. Whereas I should also give the gaps side by side. With Ayushman Bharat, what people at the grassroots level are finding it difficult is to figure out the specific hospital which would give the specific treatment that they would like to have, whereas it is far away from their community. So, when UHC is talking about the kind of quality healthcare to be made available in our own communities, this kind of searching for the place and for the hospital and going distances is an issue for people at the grassroots level. So that is why PHC is all the more important, and every health document or every health instrument and policy is stressing on UHC, on PHC, primary healthcare at the international level, which we need to actually look into. And yes, at the community level, we have the health and wellness clinics, centers, where we also have the Anganwadi workers and the Ashas who are delivering a lot of services at the community level for all people, vulnerable people. What is also lacking in this system is the information, health information is not reaching to people of different vulnerable groups, and it is not made in accessible formats. Like people who are deaf need it in sign language, or people who are visually impaired, they need it in accessible formats where they can listen in audio formats, or it is available in their mobiles. So these kind of accessibility standards need to be built within the health system. Or if you look at the health and wellness centers, many centers are not accessible for wheelchair users to enter. So these are certain gaps which need to be addressed. And other than that, there is a context like it is only the insurance coverage which is looked at as UHC, whereas it is not, which Dr. Soumya also clarified. So we have other programs in the country like the National Health Mission, which is looking at the women and child health and other disease control, the communicable diseases and the non-communicable diseases, the immunization program, and we also have the e-health and the telemedicine programs like the e-Sanjeevani or the Telemanas, which are catering to the communities and on an easy approach for people at the community. And there are also other traditional medicines and care which has been fostered by the government of India, like the Ayush. When we are looking at these aspects, how are they responsive to the vulnerable communities is something which we need to constantly monitor. And we also have a good policy, the National Rare Disease Policy for all rare diseases, whereas the gap there is, though there is a mention of Center of Excellence, which would be providing support for people with rare diseases. The policy is also talking about 50 lakh rupees for the healthcare of a person with rare disease. who all come into the list of rare disease is still, many people with rare diseases are not into the list. And people with rare diseases have a lot of expenses. The medicines are too expensive. Even the diagnosis is very expensive. One time 50 lakh, the funding may not be helpful for all people. So we need to constantly have, leverage the funding, and so that people don't have catastrophic out of pocket expenses. Then we also have the data system, like we have the National Family Health Survey, which is giving a whole lot of data on the health status of people in the country. And Niti Aayog is also working on the SDG framework, and UHC is within the SDG framework. So we also have the National Public Health Observatory. It is a huge data mechanism where you can actually track at the district level, and even below the district at the block level, what services are providing what at what time. And it is an instant connect, whereas there are still gaps with these data mechanisms, because the National Family Health Survey is not looking at the disaggregated data of vulnerable populations, like the persons with disabilities, LGBTQ, and other rare diseases and other NCDs. Yes, certain NCDs are covered, whereas not many. So and also the SDG framework need to be streamlined and need to be improvised, where we need people from the civil society to work on it. So that the SDG framework is rights-based, and it provides the holistic gamut of addressing health inequities. And at the state levels, we already saw a few speakers talking about the Kerala model. Yes, we have a very good model of palliative care at the community level in Kerala, and in Tamil Nadu we have the Makkalai Thedi Maruthuvam, which is doorstep medication and treatment for people, for everyone in Tamil Nadu. And in Andhra Pradesh, there is a specific social security coverage for specific health conditions. And apart from this, we also have the disability insurance coverage, which is being currently in discussion, and the disability department is working on it. And the IRDA, the Indian Insurance Regulatory Authority, has given circulars towards that. So things are moving very well, whereas what is lacking is kind of streamlining it, so that it addresses the all the healthcare requirements of persons, especially the vulnerable communities at the grassroots level, where so what is needed is engagement of civil society actors in decision makings, in all the key roles in implementation and also in the monitoring aspect. Next slide, please. So when we look at the civil society engagement, like there are many patient advocacy groups in India who are looking at specific services for their members. Like I am from Multiple Sclerosis Society of India, and I can talk for an hour on all the services provided by MSSI, starting from the diagnosis, treatment, and rehabilitation, assistive technology, whether it is a wheelchair or whether it is a walker or any other assistive device, or the person-centered care, where by providing a caregiver to in-home, so that the person can stabilize over a period of time. And our civil societies are also engaged very intensely in surveys, in research and publication, and we are collaborating with the government. We are promoting other support aspects like nutrition, SRHR, wash, water, sanitation and hygiene, and especially mental health. We have peer counselors. We ourselves take up the peer counseling aspects, and we support our fellow members. And apart from this, we give professional counseling, we facilitate socialization, we also support during crisis. I would just like to give an example, during COVID, people could not travel from districts to the hospital for their weekly infusions, and we kind of managed to set up an infusion facility within the house by sending nurses and volunteers, and that is how they could get their infusions done. And similarly, a person in a wheelchair living alone in 5th floor in an apartment, her caregiver could not reach her during the lockdown, and she called to the MSSI Chennai chapter, and MSSI Chennai chapter, with the government permission, sent a couple of volunteers to her area, to her house, and they managed to get her bread and milk from the next store. So the civil societies act not only as supporting the medical aspect, whereas we are looking at the holistic development. That is what we mean by health, right? So this should be the angle at which the government should look at, where civil society engagement is a must. Next slide, please. Finally, coming to the recommendations, even at the global level, what we see is, 5% of GDP has been the constant appeal by the UHC movement for every country, and a few countries have done it, but not many countries. So most of the countries are ranging between 1% and 3%, and so we need to have we need to invest more. So this is an urgent requirement, and we need to have UHC equity policies, and disaggregated data is a must in UHC, so that we can track the health inequity, and we can also track the progress. And all the health information should be in accessible formats, so that people can understand and can make use of it. And we should be, of course, part of decision making and implementing and monitoring. And capacity building is very, very crucial, because there are many staff, like at the community level also, like NGOs do that. We train the community workers on certain aspects of disability or certain aspects of non-communicable diseases, how they can work towards that. We have the TB champions who are working on TB patients at the community, whereas this needs to be instilled in every hospital and in the entire health setup, because at the grassroots level, when a woman with disability is approaching a hospital, a healthcare facility for SRHR service, the attitude is, you are a person with disability, why do you need SRHR service? So this kind of stigma is available within the healthcare workers. So we definitely need capacity building, not only on the conditions, on the rare diseases, on the NCDs, or on the disability, but also on treating them, handling them, and also towards human rights of for health for all persons with persons belonging to vulnerable groups. And primary health care is the only way, and where we also should also look at the person-centered care, and there should be a clear understanding of primary health care, and we need to reorient the health systems to primary health care, and we should also know what is needed, what can be done at the country context. And only when this understanding is there, then UHC would be effective in all communities, and especially community licensing support should be there. Brilliant programs are there under UHC, whereas if there is no licensing point or support person at the community to support the communities, then the person is not able to access these services. So licensing support is very, very crucial, and inter coordination between different departments, and especially with the disaster management authority. So these are specific aspects which if we can look at, then we would definitely have a great improvement and remarkable UHC programs. Next slide, please. So I would just finish with the one example where a community-based organization, Vidyasagar, have been working towards at the community and figured out 3 children with Usher syndrome living in a rural area of Tamil Nadu. And apart from taking care of the medical support, facilitating the community medical support and other things, there the children's education was supported. It was facilitated. Home-based environment education was also supported, and the parents, because of 3 children having this syndrome, they were not having a good livelihood. So their father was supported to have a cart, a vendor cart, where he started his business, food cart. So now they have a steady income and they are socialized within the community. The children are going to school. So so this is the holistic model which the all civil societies are working towards. And this approach should be taken by the health system of any government, and not just see the disease treatment alone. And with this, I thank you very much for the opportunity. I'm really sorry that I could not be there in person because of I got sick due to the cyclone after effects. And thank you very much for this opportunity.
Thank you, Samita. Take care yourself. Get well soon. My concluding remark is only one. You don't have to wait till 2030 to achieve universal health coverage. We have seen examples from Thailand, Philippines, Sri Lanka. We can do it, provided you engage the people and the patients, preferably mandated by law, and their voice should be heard. Focus on primary health care is a must. Otherwise, if you only have medical insurance, it will be at the cost of primary health care. And my apologies, the session spilled over. But each one of the speakers had so much of information and knowledge for us to learn. We could have listened to them for hours together. With that, I thank all the panelists for excellent information sharing, and we can learn from each other. Thank you so much.
Very rightly said, sir. I extend my heartfelt gratitude to eminent speakers, our distinguished panelists, respected chair and moderator for their valuable time and insight, and covering the equation of present and future scenario on the designated topics here from Sri Lanka, Thailand, Philippines, and India, and bringing us together under one umbrella. Thank you. We are highly honored with your time. Please, I would like if you can have a group photograph, please. We can have the moderator and everybody on line also. Yes, ma'am. Dr. Ratna, ma'am wants you to come and join us, please. If you can have our chair and moderator online for the picture, and Dr. Smita. Yeah, that's perfect. Maybe closer to the screen. Can the hotel staff please remove the lamp? Thank you, Chitran sir. You can keep it there, sir. We are all glad to share this space and making memories for the first international summit here. A beautiful first session held with dignitaries and excellent discussions on topics. Thank you, ma'am. Thank you. With this, we break for a short coffee break, and we would resume in 10 minutes. Kindly be on time so that we can start with our next sessions timely. Thank you. A big round of applause. Ladies and gentlemen, we'll resume with our forthcoming session, please. Kindly be seated, all mobile phones to be on silent. I'll request all the dignitaries and delegates to join back. Thank you. My heartfelt welcome to everybody here, all dignitaries, our delegates, our esteemed guests, our honored chairs and moderators to our first International Patient Summit 2023. Here we move forward for our next session on health literacy in the digital world, patient empowerment with the right tools and knowledge. I take the opportunity to please invite our chair and moderator, Mr. Einstein Rogers, up on the stage, please. Board member, Philippine Alliance of Patient Organization, Certified Innovation Professional, GIMI, Innovation Venture Architect and Foresight Consultant, Web3 Marketing Consultant. Is a board member of the Philippine Alliance of Patient Organizations and Innovation, consultant for startups and large companies, building systems through a globally renowned methodology. He is a certified innovation professional by the Global Innovation Management Institute, Cambridge, Massachusetts. Please, sir, we are highly obliged you to have here. Please, sir, can we have you on the stage, please, sir? A heartiest warm welcome, please. A round of applause. Yes, sir. I now take the opportunity to please invite Dr. Usha Rani, is an associate professor and coordinator for Manipal Health Literacy Unit. She is also the country office head for Asian Health Literacy Association. She has done extensive research in patient care activities, quality of healthcare delivery, and health literacy in India with 13+ years of experience in healthcare industry. Ma'am, can we please have you on the stage? We're honored to have you here and all ears to hear your expertise. Please, a big round of applause for the lady. Next, I take the opportunity to please invite Prue Echeverry, has worked for over 20 years in patient advocacy, both in New Zealand and internationally. She believes effective patient and citizen engagement is essential to improving healthcare and patient outcomes. We're glad to have their expertise with us in this session. They will be joining us virtual. Next, please allow me to invite Professor Peter Chang, is the International Director of the Sichuan Healthcare System and Director of the Occupational Medicine Department in the Lukang Sichuan Hospital. He is also the Senior Advisor of the Phang Nong Tang University of Medicine. Thank you, sir. We'll be highly obliged to have you. Our next panelist here would be the Asha Zahir, is the Regional Patient Engagement Lead, Japan, China, Asia Pacific MSD. She has over 20 years of experience, 6 years in clinical practice, followed by 14 years in industry. We are greatly honored to have you here, ma'am. Please, a round of applause and welcome, ma'am, here. Please, I leave the chair, table dais to the chair and the moderator here. Welcome, sir. And thank you, ladies and gentlemen, to honoring our. Sorry? Okay, sir. I would please take the opportunity to also invite our panelist here, Ursula Lanoria. Please, sir, can we have you on stage here? Ma'am is known to be many dedicated patient leaders of Neurofibromatosis Friends Philippines, and also serving as a board member of Philippine Alliance of Patient Organizations. Thank you, ma'am. Apology, and please welcome. A round of applause for the panelists, please. Thank you, sir.
Good morning, everyone. I hope you had a good coffee, a much awaited coffee, and it's very delicious as well, I might say. So we are here today for this session to talk about the best practices of health literacy, anchored for patient-centered healthcare. You must be wondering, who am I? I'm Einstein, and that is my real name, just in case you're wondering. I can show you my birth certificate. Thank you for laughing. I thought you were not listening at all. So the reason why I'm here is because my father survived a stage 4 laryngeal cancer. And I'm here, and that happened 13 years ago. I don't want everyone or anyone else to experience the emotional, financial, or physical burden that could have been handled better. And this is what we need for the future generation. Now, we believe the value of being literate is valuable in all aspects. What is mind-boggling is we are unsure on what is happening to our own body. Another mind-boggling fact is patients who has low literacy, health literacy, cost 4 times more as much as a health literate person. So here in this session, we like to understand where patient leaders has exerted their efforts in empowering patients through digital tools. Second is we are here to observe and collaborate where we can converge ideas as a united front from patient leaders, academicians, healthcare providers, and industry towards quality healthcare for digital healthcare. We would like to inspire to talk about the future, where we are heading, and what is the roadmap, and what makes you an empowered patient using digital healthcare tools. Let us listen to our prestigious speakers as we increase our meaningful and active participation through digital health literacy.
Good morning. So first of all, I would like to say thanks to Dr. Soumya Swaminathan, because she really highlighted the importance of health literacy and bring this platform open for the discussion. So slide, yeah. So today here I am standing in front of you to discuss on addressing health information or misinformation. What, who, why, and how. Now, when we see the definition of misinformation, it says health-related claims that is based on anecdotal evidence, false or misleading, owing to the lack of existing scientific evidence. I'm sure all of us are very concerned about our health, and we would have definitely used any of the search engines to find out what is good for us to eat. And very rare that we try to find out who is the one who is the feeder of this information on digital platform. Is it a non-profit organization or industry? Is it an unidentified blogger who is either being paid? Or is it the government health body or a similar agency or maybe an academic institution? Is it an individual who is a certified healthcare practitioner? Or is it a group of healthcare practitioners who are knowledgeable enough? Who is posting that information? Very, very difficult. We are taking a call for our own health. So if some information we believe, which is good, we just believe. And you see the spikes. So I'll tell you, if a US president is quoting something, for example, taking a disinfectant as an IV to combat COVID-19, you see the spike. Oh my goodness. The way it moves from one cell phone to another, one person to another, and not one country. It reaches globe. Why? Do we trust? We don't know. But we are concerned about the health of our people, our loved ones, and that's where we actually become a part of this, where we circulate misinformation, not only to our, to ourselves, our knowledge, but also to our loved ones. Now, what are the factors that contributes? One is the ease access of social media. It doesn't charge us when we post any misinformation. Rather, people get paid if they put some YouTube videos or some blog or something. So why not? Everybody is a doctor sitting over here. Everybody is a certified healthcare professional. They can actually post it. That's what is happening. And lack of health literacy among an individual, we don't know how to judge it. So this is our lacunae. And then the cognitive biases. Yes, I believe this is true because my belief is superior to the medical knowledge. And anecdotal evidence. What is anecdotal evidence? My family so-and-so had experienced this. So this drug is better and that doctor is better than that medicine, which is certified. Okay. And then, wow, another, topping on the cake. Influencing people will come and they will post a YouTube video or they like it without reading the information. And that's enough. That is the information we have to believe because somebody has endorsed it. And then lack of regulation. Many countries don't have regulations to overcome this issue. And fear and uncertainty. If you don't eat this or if you don't do this, you are going to die. Or you will land up in so-and-so. So fear of unknown is very, very influential over there. And then selecting, reporting, and cherry picking data. Here, I would like to tell you, I read somewhere you should eat 400 grams of fruits every day to live healthy, quoted by WHO. I went to the website and checked myself and I found what they say, you should eat 400 grams of fruits and vegetables. It's not only fruits, but look at the people, if they start eating 400 grams of fruit per day, what's going to happen? And they are going to miss many other micronutrients, which is also written in the WHO site. That's nothing but lack of health literacy. And then look at our daily livelihood. What we do, we go to buy a shopping to, get our oil for our vegetable oil for our cooking. And we see what are the top 15 brands which are healthy. Oh yeah, this one is good. Let's buy it. And then, somewhere we show our, intellect and literacy level. We say, okay, how much calorie does it contain? It contains 120 calorie. I think I can just avoid this. I will go for 100 calories, but little do we know that it also contains trans fat. So are we health literate or are we health illiterate? Where are we standing? And then comes the false, why we do this. What happens, why we have to stop misinformation? Because it's a false or inaccurate information, which are either deliberately, intendedly, it has been posted or somebody has manipulated. But what it creates fear. It creates distrust in the healthcare profession and it costs you life. It is a waste of resources. It definitely causes a lot of mental health issues. And definitely during COVID-19, we have seen its impact on public health as well as the community well-being. We all have witnessed. So here I propose you, this is my original work. Let's suppose somebody says vaccine contains harmful ingredient. What are we going to do to handle this? Have we checked the evidence? Oh my goodness, evidence? These are difficult to read and understand. It's written in medical terminology. Did you speak to your doctor to understand? Oh, my doctor doesn't have a time. So can you identify the health information? Can you read the medical words? Can you understand these words? And can you take your own decisions? Difficult. So what we can do? We can have A, B, C, D. We can access the health information which is readily available by various authorized bodies. We can approach to various healthcare professional or patient support group. We can ask the doctors. We can ask even online, a lot of services are being provided by government agencies. We can ask them whether to do it or not. Browse for health information and do a background check when you browse. Browse doesn't mean only online browsing. Even browsing means you need to go and read some literature. You need to collate, comprehend, and criticize the information that you have got. And then you should differentiate, you should decide, and take action or demonstrate in your healthcare practices. That's what is nothing but health literacy. That's an individual approach. Then comes the joint approach, where comes the role of organizational health literacy, where organizations come together and they try to empower their employees, and not only employees, but also they try to support the individual's health literacy. What we need in joint approach, we need legal policies. We need awareness campaign that patient support groups are doing it. We need mass media campaign. Media has to know that even if their advertisement, how it is affecting the population health. We need evidences which are linguistically acceptable for people to understand and replicate the knowledge. We definitely need social support, like you all are doing it over here. And the role of digital health literacy cannot be ignored. Now, before I conclude my presentation, I would like you to go through one scenario, which one patient was telling me. Patient got a pulse oximeter. And patient said, doctor, I'm doing really good. Okay, how much was your oxygen level? I always got above distinction. Yes, but how much was your oxygen level? What your record says? It was somewhere around 85, 88. It was always distinction. I never got less than 75, even if I'm running. Is it safe? So digital health literacy for the digital healthcare support is required. So it's not only just the health literacy, but in today's era, we need to also focus on digital health literacy and prevent the infodemic. It might hamper not only individuals' health, but also the community health. Thank you so much.
Thank you very much. I like how you coined having an evidence-based approach on different information channels and having reliance on who are we getting the information from. I also like how social media, where you only get the bits of information that you would like to share, because that has the most likes that you can get on social media. I like also how what you said about having a joint effort, an omni-channel approach on how you spread the information is very important as well. For our next speaker, she will be joining us virtually, Ms. Pruichberg.
Hello, everybody. It's wonderful to be here. If virtually, I wish I could be there with you. Thank you very much to the organisers for the invitation to speak on this really, really important topic. And it's a topic actually really dear to my heart, because you'll probably see that as we go through. You heard in my introduction my involvement over the last 20 years, either working for or with patient organisations. And this year I also, not by my choice, but became a consumer of our healthcare system here in New Zealand. And that actually reinforced, I think, much of what I already had been thinking in that space. Can I have the next slide, please? So we know the applicability could be across so many areas, and I won't go into all of those, but from health and wellness to diagnostics to advancing and supporting treatment or clinical trials. And the tools are many and varied, and that may be through websites or mobile phones, smartphones, or wearable technology, and more and more. Next slide, please. So as a unifier, clearly we can have greater connection where we have digital technology involved, and that can itself bring social inclusion and connectivity. It can bring a sense of community, improve access to services through such as telehealth and other ways around that. It may reduce costs and inefficiencies. It may help with improving safety and with data checking, it very definitely can bring geographical connection, regionally connecting people in rural or remote or outside of main regions. And it works well with good infrastructure. But I would want you to consider what is needed to get that right and other social determinants of health that fit into that. And that may be as basic as housing and the setting somebody's in, their education level, and employment. And there's many other pieces to that. But unequal circumstances such as those can interact to actually create further inequity where that already exists. Can I have the next slide, please? So everybody has learnings from COVID-19, and some of them are really obvious, and I don't want to belabor those. But one digital size doesn't fit all. Not everybody has a smartphone. So we really do have to think about who might be getting left behind in that. Who are we leaving out? What are the barriers? Inequities are perpetuated if they're not addressed. They're not fixed by digital healthcare or digital solutions. They may well be perpetuated if they're not landing within good infrastructure. We need affordable connectivity and access to devices, and wraparound support is needed. It would concern me where we see digital solutions, but there is not the wraparound support or training, and sometimes that's training of healthcare professionals. We saw with COVID, technology moved very fast. We moved everything online. Systems and technology moved, but trust did not necessarily move that fast. Trust in healthcare systems, trust where there was already mistrust. Again, a digital layer can be a further barrier. The next slide, please. So there's an opportunity for patient-led solutions, because I really would want some thinking around who is driving the intervention. Is it coming from an unmet patient need, or is it coming from systems trying to be efficient, or hospitals trying out new things, or industry or other companies? But really, is it coming from an unmet patient need? And have those who will benefit or participate in whatever the digital intervention is, have they been involved? We hear always about patient centricity or patient-centered care, but many of these things are not patient-led. They're not patient-centered. They don't start from that base, and they haven't involved patients or families right from the get-go. And whilst it might seem funny to write how is success measured, but what are the feedback loops? What is being put in place to know that said interventions are actually beneficial, effective, reaching everybody they need to? Could I have the next slide, please? So with digital equity and inclusion, I think it's really important to put that down. I've heard mention on a previous talk today about biases and community involvement and NGO involvement, but just actually at its center of everything is equity or inequity and health equity. Is everybody able to access and use digital technology? And there's many aspects to that. I heard, actually it was in an education setting, and it was in New Zealand, and it was this week on the radio, about how in a school setting, how laptops were being given to teenage children to ensure that they could keep up in a school setting with their homework and be able to hand in work on time. They noticed, the school, this particular school that was being interviewed, that the students were often handing in their homework after midnight, 1, 2, 3 in the morning. And when they inquired about that, they found that actually there was a hierarchy in the house, and where there was no laptop or device prior to that, suddenly there was a hierarchy, and the teenager who the laptop was intended for was the last one to receive the device to be able to work on. So it's actually understanding. So you can have equity and everyone may have access, but inclusion is what's needed to be around that to ensure that who you are trying to help is included. Health literacy is at the center of this talk, and there are fabulous speakers who are going to talk at length around that. But it's critical, and it's hard to measure. But if patients and those involved are not surveyed, we don't know how well the intervention is going. I've also mentioned around cultural competence and cultural safety, and actually it should be cultural safety that's underlined, because cultural competence might talk about sort of having an awareness and knowing what's around cultures, or knowing what might play out, but actually being safe and competent in that area is aware of your own biases. And a really central piece of it actually is power imbalances. It's critical and critically important to remember it's very rare that the patient is empowered. So it's essential to get that right and consider again that the patient is at the center. Next slide, please. So there are very many ways to have inclusive solutions. I've mentioned about a fair ability for patients to participate, but the healthcare professional and patient relationship, I mentioned also about trust. It's really critical. Skilled workforce in digital health. So healthcare professionals themselves understanding what needs to play out in a health literacy setting. We're trying to reduce stress and streamline systems, but being careful to not inadvertently add stress by trying to connect to devices and not understanding how they're being used and not understanding the information on there. And as mentioned, having alternative non-digital services also available to wrap around. Next slide, please. So with digital best practice, I think it's an opportunity for not-for-profit organizations, for patient organizations, patient advocacy organizations to play a really big part here on behalf of patients, to really represent and understand and convey patient need. And no one can do that better than patients, but alongside a patient organization. But it's also understanding how patients like to receive their information, or how they can receive it. And the layers are the key to health literacy, the layers of information. That may be video, that content, that may be pictures, that may be different levels and layers of written information. So patient education and training is really important. And of course, and I've mentioned access. But here is a role, as said, where patient organizations can really play. And for those of you who are in the audience or listening who are part of systems who are bringing digital solutions to the fore, please consider, if you haven't already, to have patient advisory boards, to have patient organizations at the table. Next slide, please. So again, talking about patient organizations themselves, I know we're possibly talking about digital solutions and technology and applications that are not patient-led or patient organization-led, but patient organizations themselves need to think about testing and usability, scoping properly, understanding what's already there, who's already working in the space that could be partnered. Cybersecurity, data and safety, there's a very big education role there for patient organizations to help patients with, and to be very, very careful of their own data that they're capturing and keeping, that it is safely kept. Having socialized policies and strategies. But the data safety is something that for anybody who's on a not-for-profit board or working in an organization, it needs to be something very, very seriously considered. And a lot of patient organizations have involvement with registries and databases. So it's a consideration that needs to be thought about at all times. Can I have the next slide, please? I've kind of mentioned this, but I think there are opportunities for patient organizations really around advocacy and advocating to those, as said, through advisory boards or other means or committees to make sure platforms are fit for purpose and that people can access them and use them. So involve patients from the outset. And bringing forward patient voices and marginalized voices, and part of that is around cultural competence and safety. And ensuring alternatives are there for those who cannot access digital settings, that there are, that one size is not only a digital fitting all. Could I have the next slide, please? So really, in summary, it's that digital technologies definitely provide valuable solutions for health. Health inequity absolutely must be considered, otherwise it will be amplified under an inequitable system, digital or not. And all interventions need to be considered through a health literacy and health equity lens. And just making sure that those who are intended to benefit are those that are invited to the table to be part of the solution. Thank you so much.
I enjoy, every time Bruce speaks, I always enjoy her, the way she speaks, because it's very provocative. And the summit here is not just about from the speakers, not just about the thoughts from the speakers. Now I have a question for the audience before our next speaker. I would like to invite everyone to close your eyes, because the title of Pru Echeverry is digital a unifier or divisor? Please close your eyes, raise your hands if your right hand is for unifier and your left hand is digital divisor. 1, 2, 3. Everybody, if you think is digital a unifier, please raise your right hand. If you think digital is a divisor, please raise your left hand. Open your eyes and look everyone around. Split vote, I guess. Both hands, I guess. All right, moving on to the next speaker. This is joining us virtually as well is Prof. Dr. Peter Chan.
First, like to appreciate the organizing committee of this important summit meeting for invitation, particularly Dr. Ratna, Dr. Usha, and many of you for invitation. I'm Peter Chang, working in the Asian Health Literacy Association, as well as the International Health Literacy Association with academia John with the Top University. And I'm working in the Sichuan healthcare system as a physician, also providing education in several other occasions like Hong Kong University and Pharmaceutical University of Medicine in Ho Chi Minh City. I'd like to talk about health literacy from the healthcare professional perspective. As we know, for many years, the patient has been simply called patient. And should the patient be patient on the long waiting list? In many other countries, like USA and other, we know that the patient has been on the long waiting list. And patients, they are losing their health, they are losing their life. But unfortunately, they are kept on the long waiting list. And the healthcare system has been asked to provide patient safety. Means in the healthcare system itself is unsafe. We have been doing a lot of progress in this regard. But do we need to provide helmet for patients when they go through the healthcare service? Do we have that helmet for them if they are in danger? So my question is that can health literacy the umbrella to protect the patients? For years, we have been trying to provide a better umbrella to protect our patient in our healthcare service. And health literacy has been shown to aim to empower the patient through the healthcare systems. They are no more in great risk. They can be in safe, under umbrella, with raincoat, with good shelter. But unfortunately, in many countries, this is studied by USA, one half of the adults have low health literacy. 2/3 of older adults do not understand basic health information. 4 times patients they will spend on healthcare service if they are with low health literacy. And that generates tremendous amount of burden on limited healthcare resources. In UK, NHS, the study shows 61% of adults struggle to understand health information that contain both words and numbers. And in Australia, 60% of the adults, they have low health literacy level. And USA CDC, they show the critical that patients with low health literacy, they are more likely to visit an emergency room. They have more hospital stays, and they are less likely to follow treatment plans and have a higher mortality rate. How about the other? In Europe, some of the countries are even worse. In Asia, usually many countries are showing low health literacy in an adult. This is a study comparing with those in Japan, Indonesia, Myanmar, Kazakhstan, Vietnam, and Taiwan. You see that most of the countries in Asia have a relatively lower health literacy than Europe. Even in Taiwan, which is shown with the best health literacy outcomes, 44% of the adults do not have adequate health literacy that can help them go through the healthcare services. We just passed through the past 3 years COVID. We lost a lot of our patients, and we do not have adequate instrument to protect our patients. Even now, we just overcome the big pandemic. The healthcare worker like me, myself, we are struggling to protect our patients, but unfortunately, we lost a lot of our customers, the one we love, the one we care. So we've been talking about health disparity, but I think the first step in reducing health disparity is to provide much higher patient health literacy. We have to put patient and healthcare profession on the same table. We don't separate them. We should put them together to solve together the difficulty of the healthcare decision makings. And in the future, we should lower the barriers to make health service more friendly, make it easier and simple and friendly for the patient. There are techniques how to do it. We will use different communication strategy according to the patient, based on the condition of the patient preferred, the learning style, the label health literacy help, because the right health question can lead to better health care. We should encourage patients to ask questions. You can see that if the healthcare system is well organized, like we have on the left, but unfortunately many of them are like the right side. We need a good teamwork of the communities and profession between the patient and the healthcare professions. We need to put them together. We need to put them in much better order in order to save our patients' life and their time and their health. So health literacy includes communication, not just healthcare profession and patient, but first between healthcare professions. There are different healthcare professions. They do not communicate well. We need to provide much better communication between them, between healthcare profession with the patient, not only the patient, but also family and the communities, as well as the social workers. But beyond that, we need to talk with the media, the regulator, and the investors for healthcare service, including those in the transportation, financial sectors, which is the job of healthcare professionals, to have better communication with all these sectors, which are heavily involved in the quality of healthcare services. And that is my key message. So I welcome you to join the coming Health Literacy Conference, the 8th, in May 13 to 15 in Ho Chi Minh City in Vietnam. And we have provided a much enhanced smart healthcare solutions for the healthcare professions first, but also for our patients. And I thank you so much for your attention, and I'm looking forward to your comment and question, and looking forward to working with you to enhance capacity and patient right, reduce health disparity, and promote much better health care, quality and quantity during the health care service for the patient. Thank you so much.
Thank you very much, Prof. Peter. It's very insightful. I'd like to talk more about it in a while.
Kindly allow us, I'll hold this promising panel for just 5 to 10 minutes, as we have Dr. Kloos-Runge, and he has to leave for some emergent situation. Please, Dr. Kloos-Runge, I invite you on the stage to have your remarks, please. He's leading the Global Market Access Group, and as of July 1, 2019, Market Access, Policy Affairs, and Sustainability Group at Bayer's AG Pharmaceuticals. Thank you. Please, a round of applause for sir, please. Thank you, sir. We're glad to have your time.
Well, thank you so much for the invitation and also for your flexibility to accommodate for some plans, other plans today. My name is Klaus Runge. I'm working for Bayer Pharmaceuticals in its Berlin headquarters. I've been to the region now for 2 weeks on the heels of the COP28 meeting, where actually for the first time ever, the nexus between climate change and health has been on the agenda. So I think the data are pretty alarming, also for patients in this region. So the most vulnerable are actually suffering climate change the most. That's not the topic of today's meeting. Today's meeting is also centered around the question how we can turn cutting edge technologies into products and services that patients can benefit from. And one term that has been raised repeatedly today has also been the term of health inequality. So how can we overcome this also for some of the cutting edge technologies that we see? So we all carry lots of wishes in our pockets all day until the moment we turn into a patient, and then you only have one wish, and that is health. So the issue is that with many thousand diseases, we still don't have treatments that can really change disease courses and disease outcomes for many patients. And one technology that is actually promising and that has seen the first applications in different geographies are cell and gene therapies. I refer to them as CGTs. And while I acknowledge that I'm not talking to an investment community or investor community, I think still a look into the number tells you that there will be a lot of investment going into cell and gene therapies in the foreseeable future. And Asia Pacific and India in particular will be a place where hopefully a lot of investment will be done in this field, and a lot of research that still needs to be done in terms of long-term outcomes of cell and gene therapies, and also in terms of pharmacovigilance and safety. So I think your best place here in India, also countries like China, to see this innovation coming through in the years to come. As Bayer, we are active in a couple of indications. So we have acquired some companies who are vetted into cell and gene therapies, two of them being AskBio and BlueRock. And here you see a whole array of indications that our scientists are currently working on. And you see that there's a mixture of diseases that we have in research, stemming from both rare disease, but also more prevalent diseases such as Parkinson's or heart failure. And you see with the columns on the right-hand side that we are progressing these compounds and these assets in clinical development. And the first data that we have seen around Parkinson's disease are pretty promising. And that there is more to come in the years to come. So both broad indications, but also rare disease indications. And that's important to understand that these products come to market at an increasing pace, because they are quite particular. Some of them are cell therapies, like our BlueRock platform. Some of them are gene therapies, where you actually use a vector, a virus as a transporter, as a Trojan horse, to bring it into the human cell and to develop its impact on the diseases. And in this context, the logistics around these therapies will be crucial. First of all, here you see that we have a large global footprint on the way we manufacture these products, and that we have to establish these ecosystems, not only at the core production sites, but also increasingly across the globe, because these are therapies where the manufacturing process as such is literally part of the product, and therefore you have to have local capabilities to manufacture and to fine-tune the products for individual patients. So healthcare systems would need to be prepared on the infrastructure side. So the BlueRock asset on Parkinson's, for example, is something that you have to insert and apply via a neurosurgery of the brain. So you have to have trained professionals to do these procedures. So the good news is that in India, we already see an increasingly broad range of regulation and a very vibrant cell and gene therapy community. I've listed here a few milestones over the past few years, and an acknowledgement that these cell and gene therapies come with very relevant disease areas. The one thing I would hope for is I'm coming from a continent, and if you think about the European Union, we usually refer to Brussels as our EU capital, so to say, as the Silicon Valley of regulation. So I would hope that things are not going to get overcomplicated. Of course, you need to have good standards in place. And there is debate also internationally, also amongst patients, whether you use embryonic stem cells or induced pluripotent stem cells for making these products. But I think when it comes to designing and executing clinical trials, there shouldn't be too many hurdles. In the country I come from, in Germany, you usually have to have 16 ethics committee applications to run a clinical trial. And I can tell you this is so burdensome that we oftentimes decide to do the trials elsewhere. So we have talked about some of the technology to some extent, but the question will also be, these are high-cost products. How will they be made available on a broader basis? Because at the time these products come to markets, they come with a promise of long-term efficacy, potentially even healing, but that needs to be proven over time. So, I think it's fair to say when consumers or healthcare systems say, okay, these come with a high initial upfront cost, so because it's a single application oftentimes, is it justified to pay it upfront? Of course, there are also budget constraints in many ways. So, and potential solutions have been applied in other disease areas, but also for cell and gene therapies, where the cost of therapy is being spread over many years. So it's staggered payments or any annuities, provided that the patient actually is doing well on the product. And oftentimes the high cost or upfront cost can be more than overcompensated by avoiding long-term cost of treatment of severely ill patients. The one thing I would like to refer to, and it was also subject of some of the previous speakers, is health literacy also amongst patients. I have brought an example that we, from our ophthalmology field, where we're pretty active. We had initiated something we call a barometer program, where experts, thought leaders in the field, and NGOs and patient organizations are collaborating to improve outcomes for patients worldwide. So this, I think, is a showcase of how we can bring the different levels of expertise and the different angles to the same problem together. In this regard, it's been eye health in a number of indications. So it has had a tremendous impact on clinical practice, on services rendered to patients, because with this initiative, we have really brought in what also Mr. Chang had referred to. We brought in the patient view into the dialogue with the healthcare providers, including in India. We've been able to really improve clinical pathways, have informed clinical pathways, and that has really changed medical practice in this field. And as a company, of course, we are interested in expanding these kinds of activities into different fields. Because the one thing that you see here when we look into the data, when you interrogate the patients about their disease, is that there's a huge knowledge gap around disease management for the respective patient. You see that roughly a fourth of all patients do not understand what their condition means, how it works. Half of them don't receive clear information on the disease, although, I mean, they are the ones carrying it or having it. And you see that roughly a third were not even sure about the treatment duration. And that is something that, of course, would have needed to come across in the dialogue with physicians. And roughly 60% don't have any information material, educational material at hand to handle their disease. And now we're talking, when it comes to cell and gene therapies, to therapies who are really the next leap in technology and medical science, with interference with stem cells and modified genes. And I think it becomes even more important to have these kinds of activities to bring patients, healthcare providers, payers, policymakers together to make the right decisions for better outcomes. So with this, I want to end the short keynote and thank you very much for your attention. I think it's important that you have this meeting. It says First International Patient Summit 2023. I hope there will be many more to come. I see smiling faces. There seems to be a commitment, and I thank you for your attention today. And again, thank you for the flexibility in terms of agenda. Thank you very much.
Thank you very much, Dr. Klaus. Thank you for putting in health literacy, for having a clear information on where the patient journey is, and continuing on to our session for tools for health literacy on the industry perspective. We have here Dr. Ashia Jahir, Patient Engagement Lead for MSD.
Thanks, Angst, and thank you to the organizers for including the industry perspective into this really important session when it comes to health literacy. Just to move on to I just have one slide, and the good thing is after you're following Prof. Peter Chang, it makes your job really easy because he covers a lot of it. So if I just can move to this slide, I'll just talk you through how I am going to maybe spend the next 8 minutes, talking about the perspectives industry brings to the space of health literacy. Now, if you look at the top half of my slide, and it's around the drug life cycle. It's something we as industry love talking about. The discovery, preclinical stage, the clinical development, approval and launch, and then the post-launch section. And similarly, when we look at health literacy, we can use the same lens. What is industry doing in each of these sections, and what are the tools we are doing to improve health literacy? Now, when we talk about the first phase, which is discovery and preclinical, when we talk about data mining, we do an unmet medical need. We develop a lot of studies, registries to understand that. We involve patients in that to get it right. In clinical development, again, when we talk about protocol development, patient-friendly clinical trial protocols is somewhat the buzzword. We've seen that if we involve patients, if we use more visual modes of developing protocols, we use aids like videos, we have better recruitment in clinical trials and better retention. Similarly, the power of plain language summaries. Patients want to be empowered to understand the research and data being done. A lot of congresses are now using plain language summaries to inform patients about the latest updates when it comes to research, as well as industry. Each of us is coming out with our versions of plain language summaries. Are they perfect? Maybe not, but we're getting started. When it comes to approval and launch, you can now see a lot of the labels that come with the new drugs have QR codes where you don't have to go through the tiny print in those information leaflets. But it's, again, more visually appealing. We're using infographics to inform patients about the drugs that they're taking. Obviously, we can do better. We also are using AI. You have chatbots. You can actually get information on the drugs as well as on your disease areas. And finally, when it comes to post-launch, adherence tools, compliance tools, there are enough and more websites which tell you why you need to take the drug on time and the importance of being regular. Now, that's how we've done it traditionally as industry. Is it correct? Maybe not so. Can we improve? Definitely. If you look at our panel today, you can see representation from patient organizations. You can see representatives from healthcare professionals, from academia and industry coming together. So what do we need to do? We need to step out of our silos and work together. And the bottom half of the slide is the view which we need to take, which is the patient lens. I know whenever I show this patient journey, which is very linear, Dr. Ratna gets very annoyed and she says, patient journeys are not so linear. They're messy, they're complicated. I completely agree. But just visually to represent on the slide, it just looks nice. So I've kept it there. But actually, when you look at the patient journey, from each aspect of the patient journey, we can do more. And the way I look at it is we need to reinforce some of the messages, the work we are doing. We also need to enhance, and that can come with collaboration, and definitely amplify. So if I just walk down what we should be doing and what we've started doing is true collaborations and partnerships. We are not the experts on the patient journey, so we need to get the experts in. We need to have what Prue mentioned is patient panels. We need to have patient advisory boards. So when we create information on screening and awareness programs, it gets the perspective of the patients in. When we talk about diagnosis and treatment, and when we talk about complicated diagnosis like biomarkers, are we allowing the patients to understand the biomarker reports? And here again, there's the need for us to partner as industry, diagnostic companies, healthcare professionals, along with the patients. So again, they understand what's happening with them. And finally, when it comes to treatment, shared decision-making. I think we all talk about the importance of that to improve patient outcomes and what are the tools we can use to do this. And again, this is where we all need to come together. And finally, when we talk about adherence and compliance, there's such excellent ideas when it comes to gamification. You know, we always have this perspective about digital tools are only used by young people, but I don't know, my mother loves Candy Crush, so maybe some of her compliance tools need to be gamified too. So again, there is a lot of potential for us to get insights into the patient journey and optimize them by working together and not in silos. And that's my perspective as industry. We have started this also with perspective of the tools which are available by multiple universities, the tool sheds which are available from Boston University and Maryland University, which tell you how you should do health literacy. But are they applicable for our region, which is as culturally diverse, where multiple languages are spoken? So again, I think I'd like to go back before I conclude to what Dr. Soumya mentioned. How do we change our lens from sick care to healthcare? And that's where we actually need to work together. All of us are doing amazing jobs. I mean, when I hear about what Dr. Usha is doing or what Prue's doing or Prof. Peter Chang is doing and what we are doing as industry, I think the need is just for collaboration and partnerships for us to enhance it and to look at it not just only from a patient-centric view of health literacy, but from a human-centric view of health literacy. Thank you so much.
Thank you very much. Indeed, I agree that patient journey is a very complex task to understand. And of course, every complex problem leads to change, and that's what we call innovation. All right, I hope you're still with me because this is one of the things that I'm very passionate about. I'd like to introduce you something that we are very passionate about, where we understand where the patient is coming from. This is patient-friendly communication from Ms. Araceli Lanorio, Philippine Alliance of Patient Organizations.
Good morning, everyone. I would like to say thank you first to my co-speakers here, and I would like to say thank you, Dr. Arcia, because we share the same stage again, creating our advocacy and aligning our advocacy in this together. So thank you, everyone, for inviting us, and this is a truly humbling experience. Today, I would like to share a story that underscores the profound impact of patient-friendly communication on my journey as a patient advocate. I would like to address the essential issue of patient-friendly communication, a realm encompassing physician skills, language proficiency, and nonverbal communication. Effective communication is not merely a nicety, but a lifetime tool that connects patients with the care they need. Physicians play a pivotal role in this process. employing skills that transcends medical expertise. It's not just diagnosis and treatment, but also convey information in a manner that's comprehensible to both medically literate and non-literate individuals. Next slide, please. A few years ago, I was diagnosed with neurofibromatosis type 1, a rare condition caused by genetic defects or mutation that either are passed on by a parent or occur spontaneously of conception. Grappling with the complexity of my condition became a significant challenge. Understanding the intricacies and implications proved to be a formidable task, and it highlighted the need for clear communication and awareness surrounding such medical diagnosis. And with that, I found myself navigating the complex landscape of healthcare as a patient facing a challenging diagnosis. In those moments of vulnerability, it became evident that the way information was conveyed significantly influenced not only my understanding, but also my ability to actively engage in decision about my health. Next slide, please. What defines communication as patient-friendly for both literate and non-literate individuals? Next slide, please. I emphasize the significance of patient-friendly communication, a vital aspect of fostering understanding and engagement in healthcare. Empathy, the ability to understand and share the feelings of others, is a cornerstone of effective communication. As we discuss medical information, let's approach it with compassion, recognizing the emotions that often accompany health-related conversations. Clear language is another key element. Using simple and straightforward terms ensures that everyone, regardless of their background or level of health literacy, can grasp the information. Our goal is not only to inform, but to connect on the human level, acknowledging the challenges and concerns that the patient may face when navigating their health. Moreover, the use of technology, visual arts, and interactive methods to enhance accessibility. Meanwhile, cultural sensitivity and support of family and communities can create a supportive atmosphere. Additionally, teach-back methods serve as a valuable tool for confirmation and reinforcement. Patient education materials and interpreter services also contributes as a comprehensive and inclusive approach. By blending empathy and clear language into our healthcare communication, we move beyond information delivery. We create a compassionate and accessible dialogue that empowers individuals to actively participate in their well-being journey. Next slide, please. Here's an example of patient-friendly communication, wherein Sarah, a patient, was diagnosed with neurofibromatosis, as having a conversation with her doctor. And with that, as we can see, the doctor is assuring Sarah that she is not alone and the doctor will be on her journey. Next slide, please. How does social media help in making communication more friendly for patients? The use of social media can contribute to patient-friendly communication by disseminating health information in a bite-sized, visually appearing format. Platforms like Facebook, Twitter, and Instagram can be used to share health tips, infographics, and promote awareness campaigns, reaching a diverse audience. Through social media, information dissemination, community building, patient education, timely updates, interactive content, accessibility, FAQs, crisis communication, engagement with professionals, visual storytelling, and preventive care promotion plays an important role in fostering patient-friendly communication. Next slide. Here are some examples of social media posted from both Facebook and Instagram that can raise awareness about health concerns like NF1, and the other one is that COVID is still circulating. Next slide. What makes scientific abstracts, clinical trials, and research conclusion easy to understand for everyone? In scientific abstract, layman language involves simplifying complex terms, focusing on important findings, and using everyday language. For clinical trials, clear explanation of the procedures, potential benefits, and risk in simple terms are crucial. Research conclusion should summarize key outcomes without technical terminology, making the information accessible to a broader audience. Next slide. Here's an example of a journal article abstract where some medical jargon highlighted as dyspnea, cardiac abnormalities, and cognitive impairment can be translated into a layman's term as difficulty in breathing, problems with the heart, or having a memory loss. Citing everyday language can help patients to understand the diagnosis so they can focus on the simple things. In a nutshell, making scientific things simple means using easy words, telling story, and making sure everyone can follow. Next slide. As I end, let's remember, patient-friendly communication is like having a friendly chat with a caring neighbor, not a confusing talk with a science wizard. Let's keep it simple, clear, and always understanding. Here's to health talk that everyone can join in. Thank you, everyone, and let's make patient communication everyday's language.
Thank you very much. Hello. Thank you very much, Shara. Ara is one of the members of our organization, and I'm very proud of her accomplishment. And I like to know from the audience who has a similar experience being a patient and having to empower yourself and became empowered enough to become a patient leader. Who has the same experience? Amazing, amazing. You are the champions of your own disease, and I like to know more about your stories, and this is very, very important. So moving on to our simple question and answer, I like to start off with Ara. Like I mentioned, you are one of the best patient leaders here, and I've seen the growth literally together from literally just being a patient. Now, she has overcome her emotional burden and is now speaking in a very structured manner that will help us all. Can you share a little bit more on how you have overcome those obstacles?
Hello. Thank you, Ines. As you have said, you've seen my growth. We both started in Papo. I used to be a shy and timid, a shy person, but as I evaluated myself as a patient advocate, Papo plays a pivotal role in my life because Papo was able to enhance my ability to be empowered as a patient leader, and through Papo, I was able to learn more to build the capacity. And right now, what we're doing with Papo, we also enhance our patient leader for the care of their well-being.
Perfect, perfect. That really continues the conversation to Dr. Usha, where misinformation is really out there. Having the chance to empower such patient, how will you put in your ABCD model to be incorporated in such a powerful patient?
Yeah. Thank you for the question. First thing is communication. Coming to this platform was first where I was able to approach all of you and bringing and offer this ABCD model to all of you. You are the one as an individual, as an organization who is going to take it forward and allow the information access, empower them where to approach and empower them where to ask the question, the right question, because asking question will solve a lot of doubts. For example, in English, we call fever. In Hindi, we call bukhar. In some other language, we might call jwar or jada. Now, the same different words for the same issue. Patient has to ask the question. That's the responsibility. So A. Then comes the B. Do not just buy whatever comes to your cell phone, or do not just accept whatever you browse. You need to browse the right platform, the right digital solution, and then do compare. This is your right.
Not just for the likes, right?
Just comprehend and compare. And then, we all are mature enough, we take our decisions. We share with our family and colleagues. That's what the ABCD model will help each one. Thank you.
Perfect, perfect. I hope Prue is still with us online, and I'd like to know her perspective on the ongoing AI issue and what could be the problem here in this ever-changing world.
I wouldn't want to present myself as having expertise around AI, but I would keep beating the same drum around involvement of people, involvement of patients, involvement of families. I think AI, has the potential to get away on us, and everything needs to be people-centered and patient-centered. So I don't have expertise in particular around that area, but would just keep on stressing, please involve patients and help them be able to participate and understand what's going on.
Your next title could be The Digital Divide on AI versus Human, I guess.
I better start researching.
So moving on to Arshia here, you mentioned about gamification and having the patient journey as very complex. But what triggers me the most, which is very, very useful, is that the plain language summaries. And this could be part of the empowerment process that our organization is doing. How can we move forward with this, with your model?
I think that's an excellent point. I can speak on behalf of industry. The way we've looked at the model we work in is our primary stakeholders have been healthcare professionals, but that's not necessarily true because our products and solutions go to our end users, which are the patients. And when we talk about research and data, it's highly complex clinical trials and research that come out. But patients want to know, they want to be involved in what is this research and whether they're getting the best care for their healthcare condition. So when it comes to plain language summaries, and maybe I can give an example from India, we recently acquired at MSD a company which had a product for pulmonary hypertension. And we had a young patient with pulmonary hypertension based on a readout, reach out to us and want information. Now, this is young patients who are following the data, who are following the research and want to know whether this is a right drug for them. And this is where, as an industry, we have a huge opportunity to actually make that data, which we are so proud of, accessible for patients. And this is, it's not an easy ask. You're talking about a big manuscript to bring it down into 1 or 2 pages. But yes, there is a need for us to do this. And it's a win-win situation because even doctors tell us that very often when patients Google things, they come back with half-baked information. And I think that's what Prue also talked about, the misinformation that's out there. So as owners of that data, owners of those clinical trials, we have a huge responsibility to ensure that that data is made accessible to our patients. Again, it all boils down to if patients are more aware, they're more informed, they're better health outcomes. So it's a very simple formula according to me.
Yeah, exactly. One tool that's very accessible to us are our smartwatches. Imagine in the future, if you take 10,000 steps, you get a 10% discount on your nearest restaurant or something, right? Not just by being simply healthy, but a reward that's through
Actually, you say
gamification.
that, and I can see Nidhi in the audience because that's exactly what's happening in Singapore.
Perfect, perfect.
And the government in Singapore actually it's kind of a loyalty program. The amount of steps you take, you actually get discounts. And again, it's really interesting how they've built it into the system. You get access to gyms, etc. And I'm not going to talk about it. I only live there. The expert is Nidhi.
Let's talk about it more in the future. For my last question for everybody, I'll start with you, Prue. What in 2 sentences, what will you put forward in our tangible output, which is the digital health literacy roadmap? That will be conclude our session. 1 to 2 sentences for you, Prue.
I realize I've said it so many times, but involve those who are intended to benefit from whatever the intervention is, involve them at the very, very beginning, and ensure that it actually is addressing some unmet need alongside the system change or whatever else is wanted. And if I'm allowed 2, you asked me 1, but I want to have 2, is to consider equity, health equity, and the elements of that which need to be considered around cultural safety. Thank you.
Perfect. Thank you very much, Prue. Sorry, I'll start with you, Doctor. 1 to 2 sentences. What will you put in the digital health literacy roadmap?
So before, the digital solutions are offered to the patient, understand what they know and what they don't know. And please fill the gap before offering to a digital solution. Otherwise, people will land up in actually a disastrous situation rather than being healthy. So digital solutions are good, but has to be offered very cautious.
Perfect, perfect. I'd like to continue with Ira first.
Thank you. As we have talked, so we have to enhance more our patient leaders as a patient itself, and talking to as a patient perspective. I was able to enhance myself through knowledge and capacity building. So if I can, I guess everybody can also, that to create on their well-being.
Perfect. And like to end it with you.
I just have collaboration. The only way we can get this right is if we collaborate and we keep the patient at the center.
Perfect, perfect. A very enlightening session for all of us. I wish we have more time, but this is just the start of our conversation, as we will be more active online, and watch out for our digital health channel launch. And let us be the Chief Innovation Officer, Chief Impact Officer, Chief Integrated Care Officer of our own health. And remember, we must outgrow, adapt, as from the quote from my idol, Albert Einstein. We can't solve problems by using the same kind of thinking we used what we created them. So I am Einstein Rojas from New Voice and the Philippine Alliance of Patient Organizations, a certified innovation professional at your service. Thank you very much.
Thank you, Chair and Moderator. And I guess we all would believe that you proudly carry your name, Einstein. And how can innovation and Einstein be far? We would like to I would request the panelists for a photograph. And it was a very interactive session, giving us ideas. How can we bridge the gap between service providers and receivers? That will help the layman and people a lot. Please. Everybody. Yeah, you can. You can invite. You can stand here. I guess it will cover. We are a good amount of people. You can stand in the center also. Can we have online, our guest of honors online? Prue? Dr. Prue? If you can have your camera and if you can have your online here, we'd like to share the space, a picture with you. Thank you so much. A small practice bridging the gap online and offline. We surely do what we say. Thank you, Chair. Thank you, moderator. Thank you, panelists. A very wonderful session.
Thank you.
It's with proud honor I take the opportunity to please move ahead to the fourth session. Access to advanced therapies, genomics, and gene therapy. Is Asia Pacific ready for advanced treatments? I proudly invite Chair and Moderator Dr. Madhulika Kabra. She will be joining us virtually. Additional Professor, Genetics Subdivision, Department of Pediatrics, HOD Medical Genetics, All India Institute of Medical Science, New Delhi. We would have her online. Next, I would please take the opportunity to invite Dr. Soumya Jaimur, Director, Singh Health Duke, NUS Institute of Precision Medicine, Inaugural Head, Singh Health Duke, NUS Genomics, Medicine Center, Co-Founder, Global Gene Corp. We are very valued and honorable to have you here. Next, our panelist would be Dr. Ritu Jain. She would also be joining us virtually, President of DEBRA International, DEBRA Singapore. Last but not the least, Ms. Giasilin Jayaraj would be joining us. He heads a Senior Director, Asia Pacific, Life Sciences, Global Industry, Unit Oracle Corporation. We are obliged to have you here, sir. Can we have you on the stage, please? And Dr. Ratna Devi would be accompanying you together for the session. Please come. Please, a very round of applause for the next panel and the discussion here. I leave the stage and dais to Dr. Ratna. Thank you, ma'am. Okay, we will start and take the lead with Dr. Giasilin Jayaraj. Sir, can I please invite you on the podium? You can please start your keynote speaker.
That we will hear the opening address from Dr. Madhulika Kabra.
Sure, ma'am. Sure, ma'am. Please. Thank you.
Hello. Good afternoon, everybody. I'm really sorry for not being there physically due to some commitments here, exams, etc., going on in our department. So I'm really happy to be here in this very, very important session. And as you know, we are in the transition period as the rare disease policy has been declared in India, and we are working towards the pathways to give appropriate and best possible care to our patients. So the dilemma of availability and accessibility to therapy is there, and we really need to find a way forward so that our patients can be helped. So I really look forward for the presentations in this particular session, and I really thank the organizers for inviting me to moderate this session. So I think the first session has already been taken in the previous one. So now Dr. Ratna can take it forward. Thank you very much.
Thank you, ma'am. And Giasilin, if we can have your address.
Thank you, Ratna. Delighted to be here today. First of all, I want to thank for giving the opportunity to really talk about technology, right? Data, registries, technologies. I mean, this is really something that we don't talk that often, especially in a patient summit like this. So I really want to thank for this wonderful opportunity. Can you put the next slide? Just a quick introduction. So my name is Jay. I work as a senior director at Oracle, responsible for life sciences global unit for Asia Pacific with the industry for the last 20 plus years. So my background, I'm a master's in public health, but also a master's in computer science and also management. So kind of intersection of all the three. So I think we all know the healthcare industry is at a pivotal point, right? It's marked by technological advancements, changing demographics, rising costs. I think it's very evident when we look at how therapies and treatments are increasingly delivered. So they are becoming much more preventive, they're becoming much more customized, more curative focused, and we are also seeing they are becoming more digitized. So you see at least one or two digital components now being part of the overall treatment life cycle, whether it's a medication adherence or whether it's a lifestyle changes. Similarly, we're now seeing a lot more use of genomic data. So this is where the treatments are becoming more precise, looking at the individual's genetic conditions. So if you look at from a healthcare organization standpoint, they need to become much more agile to really support the new business models that's really emerging. Yeah, next slide. So to do all these in one place against the backdrop of constantly evolving technology, new discoveries, again, the regulations. So we certainly deal with a lot of challenges. One is now we deal with larger data sets. I mean, if you really look at the volume of data, that's increasing rapidly. So again, the use of omics is again another important element to it. If you look at the clinical trials, now they are becoming decentralized as well, right? And also we have siloed data sets globally. I think depending upon whichever the countries you talk about, that a lot of data sources are silos. How do we de-silo them? That's again one of the challenges that we really have. So also there is big significant challenge around security. How do we secure the data that we have for both the healthcare organizations and also from a patient standpoint? So clearly, I think look at what is future really holds for us in the context of what I kind of talked about earlier. So next slide. Yeah. So at the heart of achieving all this is data, right? Data really is the enabler of digital transformation. Now we deal with explosion in terms of types of data, whether it's structured or unstructured, right? For example, now we have images, we have voice data, data that has its own semantic context. We also have data with different frequencies, highly varying frequencies that we deal with. So again, clearly, if you look at what is happening right now, the data streams with high frequencies are replacing data points. So we're really now moving from data points to data streams. So this is kind of one significant shift that we really see. Secondly, if you look at in other case, data is also becoming very periodic. It's becoming more sophisticated. A good example is scientific literature in a natural language form, right? So again, to really bringing all these together, unify the data, automating the workflows, and really collaborating with all the key stakeholders within the organization as well as outside to really find new discoveries, new treatment recommendations for patients, ultimately to impact health outcomes, right? So what we actually call this as data flow foundation, it's one of the important levers that really helps organizations to kind of becoming much more agile to really support the changing markets needs that we really see. Yeah, next slide. So in terms of where we see opportunities, really to apply technology, right? Again, the role of technology is playing a role across the clinical development life cycle, right? From the preclinical all the way to scientific research, preclinical, to the healthcare engagement with the patients, more broadly what we call healthcare management. So what I thought was probably just explain this in few use cases. Interesting, given the time challenges, we just have only 10 more minutes. So again, these use cases been selected in terms of 2 use cases from Asia Pacific context and the 2 more from a global perspective. Next slide, please. So if you look at registries, I think this, we have different types of registries. There are patient registries where we store patient information. There are registries of clinicians where we have a clinician registry, hospitals registry. Again, we deal with disease-specific registries, right? So I just want to, kind of give an example of 2 specific examples. One, which is more from how do we aggregate clinical data? That's as a one single larger data set. That's one of the use case. Second data is how do we really aggregate genome data? So these 2, I will give an example of what has been done. So I personally involved in 2 of the, very well-known national EHR initiatives. One in Australia, other one is Singapore. In Australia, what they actually call My Health Records. I think if we all know the patients get treated in multiple places, right? They go to GPs, they go to diagnostic laboratories, they go to hospitals. And India, if you look at more precisely in India, we have a referral system. Patient goes from one system to another. But what really happens is the patient data is getting siloed. There is no single health record for a patient. There is no longitudinal health record access to clinicians. Doctors cannot look at the patient's past history or family history or vital signs. Although we have started the journey in India to really looking at Ayushman Bharat, I think we're just still in the very early stage. But I think Australia has done this, very well. I mean, they have done it almost like, 5 years ago to really build a national electronic health record for every citizen. So today they have 23.7, million population data in a single repository. They are able to successfully navigate challenges in terms of multiple patient IDs. So they have implemented a technology called Master Patient Index, which will aggregate multiple patient IDs. They also have a centralized repository. So irrespective of which hospital patient goes, all their clinical data gets aggregated, the summary data, right? If you look at in India, we only have EMR, but what we need is the EHR. That's precisely where we probably need to kind of move forward. There's also challenges in terms of terminologies. For example, like one health system may follow SNOMED city, right? The other health system may follow, say, ICD-10, right? How do we normalize these terminologies when we really want to build one single unique health record for citizens? So these are really fundamental challenges they dealt with. Today, they have almost like 1.1 billion clinical documents. I can really see it covered 97% of all the public hospitals. 99% of the GPs are now part of this particular program. It's really very successful in terms of how they really scale this across the country-wise in terms of coverage. Next slide. So I think some of you probably know Taiwan started this initiative called Taiwan Biobank almost like 2012. I think they have really now come to the stage where they really have significant population data. So it's really a national infrastructure providing biomedical research community the access with biological specimens. Again, it's collected from more than 200,000 patients' data. Now it's available. So they do really have a very comprehensive list of phenotypes for each concerned participant who are part of this initiative. So they kind of follow through the recruitment, multiple visits through the very structured interviews. So they do have a lot of physical measurements as well. So again, this is not just collecting the data, but they really have a biobank where all this data has been stored in a central location. But they also provide access to anyone who wants to query this information through an online mode. So now they have 200,000 individuals. Anyone can query this information. They can look at the variant data, all of that. So there are a lot of publications being done now on Taiwan Biobank. I think probably we need to look at how do we kind of implement similar models in multiple other countries as well. Yeah. Next slide. So this is a use case. It's very interesting where University of Southern California, they actually partnered with Ellison Institute. Again, this is for cancer research. So the recent breakthrough been to train predictive algorithms to support breast cancer diagnostics. I think we all know to really apply a technology like deep learning in a field like this, it requires a vast amount of annotated data sets, right? So millions of annotated images to learn statistically significant inferences from the data that we really have. So they got around this challenge by pre-configuring a deep learning network to recognize fingerprints or individual tumors. So they can really now leverage unannotated data sets which are widely available. Again, this really helped them to provide very accurate predictions of clinical subtypes of breast cancer. They also use technologies like cloud to really kind of process large volume of data simultaneously. And again, they can able to give the output in a very quickly, in a few seconds of kind of speed, they're able to kind of provide that prediction model. This is again one good example of how we can apply technologies like AI for cancer research. Next slide. So this is a case study to really address the 90% of failures that we have. If you look at pharma companies, almost like 90% of the the compounds fails, especially when they develop new medications, right? So we all know the compounds are screened in the lab using human cells and then tested in animals, right? So this challenge is actually, doesn't really replicate how does it really affect human organs in the real life when we really, apply the active ingredients for the humans. So what they actually Wake Forest has created is they created a human organoid models of micro-sized 3D organs, which are they're growing in a plastic substrates. So they're really growing real cells of lungs, heart, kidneys, and liver. So testing the active ingredients to measure the toxicology and really get the yearly insight in terms of safety and efficacy of the candidate drugs doesn't really require an animal. So really significant breakthrough where they're able to kind of really, have appropriate topological profile for the models that we really have. Again, these types of innovations are now really scaling, where how we can really test the active ingredients, how can we predict the safety profile of the active ingredients much more yearly in terms of the life cycle. Yeah. So I think this is again at the peak of pandemic. US Center for Disease Control created an application called VSafe. In fact, my own organization developed for CDC. So anyone can report how they feel after taking a particular vaccine on a daily basis or weekly basis or monthly basis, right? So today they have almost like 150 million anonymous records. Again, it really helped healthcare professionals to really understand how people responding to different vaccines. So they're able to make really very informed decisions in terms of vaccine approval by US FDA. So I think this has become like a world-scale adoption of VSafe, become one of the largest real-world patient data gathering platform on a single therapeutic area. So it really, provided a lot of benefits. One is especially for mRNA COVID-19 vaccine for pregnant women. So we all know when the vaccine was initially, released, pregnant women were never part of the trials. So they do not really know what could be the impact for the pregnant women. But then there are many of them already taken the vaccine. So that data was available in VSafe, which really helped them to take approval timely for pregnant women for vaccine. That's one significant breakthrough using the VSafe kind of solution. Secondly, even for the formal approval of Pfizer's BioNTech vaccine, again, they laid down a lot of data from VSafe to large extent. And there has been a lot of longitudinal studies done based on the VSafe, and also for the booster dose that is released. Again, VSafe been really very valuable resource for that. So I think the interesting, given the time, I think I was able to kind of talk through a few use cases. So I think technology can really make a profound impact. If you look at an Asian context, every country is in different levels of maturity. I think the digital health maturity indicators now really can kind of show where we are in terms of our own evolution. So certainly, I think technology we can move forward in terms of how we can really help advance therapies and treatments. With that, I'll conclude my session.
Thank you. Thank you. And we have lots of questions, but let's move to the next speaker, Dr. Soumya. And he has a video which we will play. And he's also joined us online, so we can ask him questions later. So if you can play his presentation, please.
To be part of this panel discussion. I'm a clinical geneticist based in Singapore at KK Women's and Children's Hospital. The topic of today's presentation, empowering patient-led research in healthcare, is something that's very near and dear to my heart. As we can see at the bottom right, the motto of our hospital is patients at the heart of all we do. And that's essentially a guiding post for me as I look at ways of improving care that I can deliver to patients. So I was very excited when I was asked to be part of this panel and share some of the opportunities and challenges I see, especially in our part of the world. I'm going to start with a letter from our patient. And this is a long letter. So what I'm going to do, I'm just going to pick out some bits of it. And it starts off by talking about how they had been living all these years, wondering what was wrong with their child. They didn't have a diagnosis, and future was uncertain for them. And then we found the diagnosis. Thanks to social media, they were able to find a support group because he was the first patient in Singapore with Pura syndrome. But because of the Facebook group, they were able to connect with families globally. They found the emotional support, and the future no longer looks uncertain. And it ends off by saying that they hope that this program continues to help other families seek closure and bring some certainty to the future for those families as well. While this is a letter from a grateful parent where a diagnosis was made, it highlights multiple facets of what some of the opportunities are and some of the challenges are. This program was possible because we had funding to sequence patients with undiagnosed diseases. The second issue was finding a support group. And in the past, when we had patients with rare disorders, given our size, we didn't have that many patients. And so there wasn't a support group. But now with social media, there are many groups that have come up and they connect family on a much more real-time basis. And so with that, from a research perspective, what this story did was that because she was connected with the families, one of the physicians was actually putting a paper of patients with Pura syndrome. And so that physician was connected with us. And then we ended up with this publication on Pura syndrome. Institute of Medicine defines patient-centered care as providing care that is respectful and responsive to individual patient preferences, needs, and values. However, it's not every patient that participates. It's not every cohort of patients that participate. And that slow uptake of patient-led research hinders the realization of the truly patient-centered care. Every problem, there are opportunities, but also challenges. And over the next couple of slides, I will cover some of these. The first opportunity is the digital transformation. It allows patients and empowers them in making healthcare decisions. Patients can track their symptoms and access health information. This can be reported back to the physicians. And a lot of times they don't even need to go back to the hospital, and they can do this at the comfort of their home. There are, just like Pura syndrome, there are other patient groups as well that actively contribute to research by collecting valuable data. Some of them do it through surveys, such as that by My Data Helps initiative, and some are collaborative effort, which enable patients to share real-world data, like patients like me. What's also important is the stakeholder collaboration. These stakeholders are not just the healthcare providers, the researchers, but also the patients, the patient groups, and policymakers. And a successful partnership is needed for holistic healthcare improvement. Because of increased awareness, there is increased awareness among healthcare professionals about the benefits. Although it's slow, there is more acceptance from healthcare professionals because they see the benefit when patients actually take charge. Because patients, for a physician, we have many patients to look after, but for the patient, they are the only ones, and that is an incentive that motivates them to actually collect data, to look for answers that sometimes as physicians we may not have the bandwidth to. To help with that, it's important to empower patients with knowledge to play an active role in this decision-making process. And so an initiative called Patients as Partners does this through educational campaigns. With any opportunity come challenges, and with data, the biggest challenge is data security. And again, we've heard of hacking, data being stolen. And any data that's being collected by patient groups needs to have certain level of security so that patient confidential medical information is kept confidential. The big elephant in the room is resource constraints. The biggest resource constraint tends to be funding, but there are organizations such as Global Genius Organization and Whereas One project by the Chan Zuckerberg Initiative that provide grants to patient support groups working on rare disease research. The other resource limitations is manpower, technical know-how. And again, this is where creating a community that's not just local, but actually global, help narrow that gap of expertise. Lastly, it's important while there is awareness, there are educational campaigns, but health literacy tends to be low in general, especially in our part of the world. And so initiatives like the Health Literacy Project, which use plain language and visual aids to make health information more accessible to diverse populations. My collaborator in Western Australia is building tools to incorporate Indigenous languages into healthcare practice. In conclusion, we should actively support and engage patient-led research initiatives. It's important to encourage collaboration between the different stakeholders for improved healthcare. In terms of action, if you are a patient, please do consider joining online patient communities and reach out to patient advocacy groups for further engagement. With that, thank you, and I look forward to your questions.
Thank you. Thank you, Dr. Soumya. And if you could please continue to stay online for another 10 minutes. We'll hear Dr. Ritu's video and then we have a few questions for you. Thank you. Can we have Dr. Ritu's video?
Hello everyone, my name is Dr. Ritu Jain and I'm based in Singapore. I'm a patient advocate, mother of a girl with a rare disorder and the president of DEBRA International, the global organization for people living with a rare genetic disorder, epidermolysis bullosa. I can't join you today because I'll be on a flight while this video is being played, but I'm very honored to participate in the first International Patient Summit, particularly in my hometown and in my homeland.
Ratna, I can't hear. Sorry to interrupt.
I've been asked to share some of my
Can we increase the volume of the video?
thoughts on gene therapy and access to gene therapies and the advantages, disadvantages, etc. for our region. So let me start by sharing what I personally think of the first gene therapy to be approved for epidermolysis bullosa that was approved just earlier this year. And while globally our patients were rejoicing and there was a wave of optimism and hope amongst patient populations, advocates like myself were despairing, and you may wonder why. Well, as we all know, at least most of us here know, that availability of a gene therapy is a completely different ballgame than accessibility and affordability. Just because the gene therapy is available does not mean that it will become accessible to patients, say, in India and China and Indonesia, and far less these therapies undoubtful will be affordable in our lifetimes, or at least not in the next couple of years, maybe more than a decade. So yes, there are gene therapies like the recently announced approvals for products for sickle cell anemia as well as beta thalassemia, but again, look at the price tags, and these just indicate that availability and affordability are completely two planets almost. And currently, I don't think gene therapies will be possible for our part of the world. It will be a pipe dream for our part of the world, and I am not very optimistic. So yes, there is hope and there's promise, but given reimbursement pathways in the Asia Pacific region, I'm sure we will agree that accessibility will remain a goal that is not yet feasible. So we do see that companies that are investing in gene therapies, if you just do a quick research on gene therapy companies in condition or situation of gene therapy, companies involved in gene therapy, you will see almost 40 companies have gone out of business for due to their failure to secure funding, or even their failure to find promising outcomes that could translate to a product that could be marketed. So yes, the failure of gene therapies is driving the very high cost of products that are approved and become available. So until we can reverse that, until we can find novel ways to reduce the costs of clinical trials and of the product life cycle, we are not going to be able to see gene therapies in this part of the world, in my opinion. So is there hope? Yes, I am optimistic about the future of orphan drugs for our part of the world. It may not be gene therapies, but certainly countries like India and other countries in the southern hemisphere like Brazil are showing the way, are leading the way for innovative approaches, not just through reimbursement strategies like the CSR that India has implemented, or like the crowdsourcing that Singapore has, but perhaps we do have in India amazing initiatives, such as the government's initiative in offering incentives for companies to set up plants and reserve medications for Indian patients. So these incentives, the tax breaks, the other benefits that the government provides will certainly speeden up the rate of orphan drug development and access in Asia Pacific, perhaps not across the region, but in some of the most populated countries in the region, yes. And other than that, of course, we just hope that while compassionate use programs are available to a tiny fraction of the population in this part of the world, we do hope that innovative solutions, scalable solutions like basket trials and creative solutions to reduce the cost of gene therapy development will ultimately translate into benefit for the region. So I don't have amazing insights. I just speak as a patient advocate and a mother that my hope lies with orphan drug development in Asia Pacific. I know that we in Asia Pacific, countries like India, can be the crucible of creative solutions for the future. But for now, let's put our heads together at summits like this to assess what can we do collectively in shifting the needle. Thank you so much.
Thank you, Ritu. And Dr. Kabra, with your permission, I'd like to invite Mr. Anand. He's there in the audience, and he's done a wonderful job on patient-led research. So if you could speak a few words about the journey that you have had, the challenges that you've faced, and how you have emerged successful, that would be great. If someone can hand over a mic to him.
Hi. Good afternoon, everyone. I am Anand from DART. Thank you, Ratna, for inviting me here. It's really a pleasure to be among such lovely people. It's a long story, so we can't go back that long. But yes, I'm not from the medical background, and I don't know if that made it more difficult or it actually made it easier for us to get where we are right now. It started with my son, of course, the whole effort. Nobody understood the disease then. 10 years back today, we have a lot of material on Google. The difficult choice then was what's the path that we take, the direction for research. Do we do stem cells? Do we do a small molecule? What part of the muscle do we want to improve first? And there was a lot of things going on. And then, of course, I heard of exon skipping, and that seemed to be the most promising. Then the next hurdle was getting a bunch of researchers and scientists together. Not many people understood the disease, let alone the technology. We put in a small R&D and started from there. All I can say that I was very, very fortunate that I got connected to some wonderful people in India and abroad who really saw some sense in what we were trying to achieve. India has a very high population per se, and obviously so with the people suffering from these disorders. So we had to do something. Funding has been a big challenge. Let me be very honest. It's a big challenge today also. Of course, we did manage to get a drug out within some record time of 4 years. And we got our first approval to do a safety study, which the results were so promising that Indian FDA had no, CDSCO had no hesitation in, of course, they had a lot of clarities to be given, but we got a clinical trial approval, which I thought was a big, big, big achievement. And we did see a lot of benefit in this one patient that we did the safety study on. It was supposed to be a safety study, but yet we did see some indications of efficacy also. So that gave us a lot of heart. Then the next challenge was, of course, the research that went up cost a lot of money. Then a question was put to us in 2018. You've done your R&D, you got a drug, and who's going to manufacture it? Where are you going to get it manufactured? Now, the few big pharmas that we did approach, of course, they had to put in all the technology and this and that. And the end price when we talked to them was amazing. Now, it may work in the advanced countries where the healthcare and the insurance systems have got the back, but in India, we don't have that support. If the patients have to put their hands in their pocket to get to pay for the treatment, it would be ridiculous to even embark in trying to get a drug out which nobody could afford. Right. So we had to, then what we did was again, back to the drawing board, set up our own small mini pharma so that let's bring the cost down of the product. And I believe we've got it down to 7% of the existing, which was again a huge drop. I feel it's still a lot for the Indian population. Going back again, so we are there now, we've got a clinical trial, we've got our hospital approvals, everything is going good, hopefully sooner than later. Now, the clinical trial funding is what we are running after the government has come in. They are supporting us, nearly 50% of the clinical trial funding they are supporting us with. So it's been good. Now, in the beginning when we started and we had to get our first approval, I remember there was no guidelines even in anywhere to get any such kind of approval because India didn't have the N=1 clinical trial funder itself. Being a rare disease, of course, we got a lot of help from ICMR, from the CDSCO. The committees were very, very good. Dr. Madhulika was and is still, supporting us. So we've been fortunate, but it's been very difficult. We have had to educate a lot of people on how to, get these things done. But all I can tell everybody else is that don't worry. If somebody has an idea of getting into any drug discovery, just do it. There's a lot of help available now. A lot of technology is there today. So I don't think it's going to be as difficult as it was for us. Yeah, thank you.
Thank you. Thank you so much. That's very inspiring. Ma'am, if you're still online, back to you.
Yes. So thank you very much for those very nice presentations. I couldn't hear Dr. Ritu's presentation properly, though I could hear. So how do you want to take it forward? I have few comments to make, and then maybe we can take questions. Will that be okay, Ratna?
Yes, ma'am. Please go ahead.
Okay. So regarding the first presentation on registries, thank you very much. It was really nice, and you took us through the innovations and digitalization and how much can be done through digitalization in registries. So just a little bit about the scenario in India regarding registries, and as of now, I'm just focusing on the rare disorders. So one registry for rare disorders, which is called Registry for Rare and Other Genetic Disorders, which is coordinated by the Indian Council of Medical Research. The information is there on the website. And here, selected group of disorders are being reported, and it's a hospital-based registry. So obviously, we will not get idea about the prevalence, but then some idea about the families who are actually seeking care. So the disorders which have been included in this registry are primarily the ones for which some kind of treatment is available. Not all the disorders, but relatively common ones. So include LSDs, neuromuscular disorders, primary immunodeficiencies, and small molecule diseases, hematological disorders, and so on. So that data is being built up. The other registry, which is in place for a very long time, is a birth defect registry, which is through the WHO, and AIMS as a coordinating center was doing the quality assurance, but obviously that's not related to rare diseases always. So that's a registry which is also going on. And then there are many more registries which are individual disease-based registries. And again, they are being done as individual programs, like Registry for Cystic Fibrosis and many eye disorders. There was a discussion about eye disorders also. So here, I mean, some of the registries are very, very exhaustive, like the rare disease registry, and there a lot of patient data is being captured, but some of the institutions only are contributing to this. So we are really picking up the tip of the iceberg. So here my comments would be that many parallel initiatives are on, and I think there's an urgent need to bring all these together, and there's an effort going on through the Rare Disease National Rare Disease Committee, that there are various centers of excellence which are picking up these rare diseases, and then there's this registry. So it's an effort to bring all these together and then have some comprehensive idea, but then obviously we will not have the prevalence data with this. Regarding the genomic data, again, that's becoming extremely important for a country like India, because we are diverse and the genomic data for our country is different. And again, there's an effort going on. There have been some publications also based on the data collected by certain institutions, but then there is an effort to take it nationwide, and so that this data can be collated. The importance being, besides having our own database for, say, different variants, even our disease variations can be different. So effort is going on, and I think there's really a need to work in this particular area. Regarding the presentation on the patient-led research, I think this is extremely important. And I think for patients, it becomes very important in situations where we are not able to find, leave aside cure, we are not able to even give them a final diagnosis. So that becomes difficult. And Dr. Soumya would also agree that many times it is because of the patient pressure and their persistence and their involvement in patient care that we work towards identifying the genes further, or working towards identifying whether it's a VOUS actually disease causing, and so on and so forth. So individual patient-led research is actually in picture, and then when we work together, different collaborating centers may identify similar patients and we work towards it, and this is actually going on. But a very important example of patient-led research, I would not say it is supported research by the patient support groups. So we started working on cystic fibrosis in late 90s. And at that point in time, it was said that cystic fibrosis is not there in India. But now there's a large number of patients, and now we have a mutation database also for them. So our first few projects were actually funded by International Cystic Fibrosis Foundation, because they have a big patient group and they support research as well. So I think it is extremely important. We have many patient groups now in India. And I think patient groups can not only motivate the doctors to do research in this area, but also help at times financially to support this kind of research. So I think these are few points which I had to make, and we can discuss the questions and comments, other comments. Thank you very much.
Dr. Madhulika, I think you made a great point about registries. I think I was just doing a little analysis to see how many registries we have in India. I think it's about 100 odd registries.
Yes.
But the challenging part is all of these are siloed registries, right?
I agree.
It cannot, one registry cannot talk to another. You cannot
That's very true.
do any electronic exchange of data, right?
Yes.
So that's a challenge that we really have. How do we really build interoperable platform for connecting all the registries?
Right.
Then, for example, I want to do a simple cohort analysis. I want to say, how many patients above 50 years old who have certain types of disease traits. I want to see how many patients are available in the registry.
Right.
Types of, research hypothesis validation, you can't do right now. It's all siloed.
Right.
One submission is, come up with a model. How do we really connect all of them to a network? That's been so far, I think there's no effort has been made to do that.
Yeah. As I discussed, this is becoming more important when there's some government support for treating these patients. So they actually want to know the numbers and the numbers who are going to benefit. So unless we have collated data, like I tried to collate data from the centers of excellence, that data we have. But then we do not have data from other registries, which are going, like neuromuscular disorder registries are being maintained by the patient groups also. So I think, though a difficult task for a big country like India, but some effort we can probably take your guidance and see that how may not be absolutely perfect, but then, and then the other thing is that if we want really the registries to be combined, the amount of data has to be a little restrictive. We cannot have very huge data as we are sort of having for the ICMR registry as of now. So if some effort can be made in this direction and you can guide us that how we can do it and how parent groups can be involved, how the institutions can be involved, we can work towards it definitely. And I totally agree. As I said, in parallel, many things are going on, but the efforts are not being put together.
Thank you, ma'am. I just had one curious question, and this is with reference to what Dr. Soumya Swaminathan talked about financial access because of, proliferation of digital apps. Now we are talking of data, we are talking of digital. So we also see that with the access is also a risk. There's a lot of financial fraud happening. So in terms of health data, what is the risk? And maybe Jaiselan can answer that question.
No, I think anywhere there is a technology, there's always a prone to have, adverse impact, right? So I think it's all about how do we store the data. I think just to give an example of registry, right? Nobody will be willing to build one common registry, right? So everybody wants to kind of tightly control their own data sets. So how do we build a model like decentralized model? So the data stays at source, but can we just only give the read-only access without the data physically moving? So those models available today. So technically it's viable, but then I think if you look at simple example, in most of the hospitals in India today, half of them don't do vulnerability assessment, penetration testing to really see how secure the network is. Anyone can literally, hack the hospital data and kind of walk away with it. So we don't really put a lot of emphasis on how do we secure, how do we encrypt our data set. So there has to be a lot of effort needs to be done. But if you look at US, HIPAA by default mandates that you need to do annual vulnerability assessment, penetration testing. But in India, we don't still have any such mandatory laws. So I think there's definitely a lot of work to be done.
Yes. Thank you, ma'am. Maybe you could give us your concluding remarks. Dr. Kabra.
Okay, so thank you very much, Ratna, for involving me, and I apologize again for not being able to join physically. I think a very relevant session, very important messages were given, and the session which was taken in the previous session also, I think that we did not discuss much the accessibility to therapy, and I think it is extremely important at this point in time. So I think the key is working together, and because there are so many aspects when we talk of patient care, specific therapies, supportive therapies, having data, confidentiality of data. There are so many things which we have to work on. So I think this is a time where, as of now, the government is also very committed towards taking care of patients with rare genetic disorders. And I think we should take advantage of this time and work together. And I think all the speakers in this group are at a level where we can really work together and bring out something which will be useful for our country. So I would be really happy to sort of collaborate and whatever assistance I can give in this particular effort. And Ratna, we can discuss it later, that how can we take this forward, particularly the data thing, how can we make it simpler and at least collate data for some of the very important disorders which are there. And we can discuss this and with Dr. Soumya regarding the different aspects of the patient-led research, how, because some of the organizations, patient support groups are really interested. In fact, when this registry was being formed, the ICMR registry, the parent groups came forward and said that we want to put in the data. Individual patients came forward that we want to put in the data. But we felt that at this point in time, because we are just beginning, the kind of data which we need may not be it may not be the appropriate time to start that. But I think some of the parent groups like Hemophilia Society, Thalassemia Society, they are in there for a very, very long time and they have their own registries. So they could definitely chip in. So we can just bring all these efforts together and work towards a common goal and definitely collaborate. Thank you very much. Thank you.
Thank you, ma'am. Thank you, Chair. Thank you, the moderator, distinguished panelists, all present dignitaries here. I believe, yes, database is the backbone of any organization and research. And we are sure when we have reached to this day today here, with we concluding and united, sitting here and looking for future perspectives, we will soon have good and nice solutions to these ideas being propagated today. Thank you. Your presence, enthusiasm, and participation is a great source of motivation and unity for our future endeavors here. And I would like the panelists here, please, you can have a group photograph, ma'am. We can have our all online chairs and moderators, if they are available. Ma'am Madhulika, ma'am, Soumya, ma'am, and Rutu, ma'am, if you are here, please allow us to join this space and allow us to make this moment memorable. Thank you, sir. Thank you, ma'am.
Thank you very much. Thank you.
Thank you. With this, we break for a very well-deserved lunch here. Thank you, all the panelists, all the guests here. This was a wonderful session, and we hope this connect continues B2B level here on the lunch floor also. Thank you. We will take about half an hour break and we resume. Let's resume at about 2:40, 45. I'm all excited and ears for forthcoming interesting sessions. Thank you.
post-lunch session. Our first session post-lunch is on communicable diseases. Is the story over? We will be talking about TB, HIV, and Hep C, and what lessons we have learned from these three, epidemics and the patient movement in this particular area, and what is it that has taught us not only for preparation for future pandemics, but also to carry forward to, say, the NCD movement. It's my pleasure to invite on stage Dr. Professor Amitabh Banerjee. He's a professor of community medicine, D.Y. Patil, University of Medical Sciences and Research, and he will be chairing and moderating this session. We welcome you, sir, to the stage. And if I can have his introductory slide. Okay. So Dr. Banerjee is the professor in Department of Community Medicine at D.Y. Patil Medical College and Research Center. He's also the editor-in-chief, Medical Journal, D.Y. Patil Vidyapeeth, and the academic editor of PLOS-1. He has formerly chaired the IEC NIV Pune, presently chair IEC AFMC Pune, and has over 200 publications to his name, boasting almost 3,462 citations. He's also ranked amongst the top 2 scientists globally in Stanford University Researchers List 2023. Welcome, sir, and over to you.
Thank you. It's a pleasure to be on this platform to get the patient's perspective, as I keep telling that I've been hearing the patients also and the doctors also. I find the patients more interesting. The doctors are just giving what's written in the textbook. Patients are giving the very original first-hand information. So that's the great thing. So it's my pleasure to invite the panelists. We have got a very eminent group of panelists for this session, post-lunch session. I'm sure you will find it very interesting. Dr. Kuldeep Singh Sachdeva, he has worked in TB for many decades. He's an authority on tuberculosis, regional director, Southeast Asia, International Union Against Tuberculosis and Lung Disease. He has worked in the ministry, he has worked in public health. And in fact, I asked him what he is going to speak on. He said he doesn't know, neither I do know. So it's a double blind. And because being an authority, they don't have to, they just speak from the experience. So it's going to be worth it. Dr. Kuldeep Singh Sachdeva, sir, please join us. Similarly, we have got Dr. Manoj Kumar Pardesi. He's worked all his life with people living with HIV/AIDS. He's the founder member of National Coalition for People Living with AIDS. And I know him for almost 7-8 years. Half of the time he is in the Northeast, which is the hotbed of it. So he will be also sharing the patient's perspective, because this is a very social problem, more perhaps than a medical problem. So Dr. Pardesi, sir, please join us. Then we have got a online expert, Dr. Danjuma K. Adda. He is speaking from Africa on hepatitis C. Hepatitis C, you see, most of these panelists, they are connected. HIV, hepatitis C, then tuberculosis, because immunity goes down, tuberculosis surfaces. And then we have got a fourth speaker, Dr. Sanjay Sareen. He is into diagnostics. So for diagnostics, innovations in diagnostics, so all these are required to diagnose the disease. And shall we start with the, I was told Dr. Sanjay Sareen would like to speak first. Dr. Sanjay Sareen, you may start, please. Okay, there is a opening slot ke liye, there is a competition. I was to, Dr. Danjuma K. Adda. He would like to speak first because he has some commitments, followed by Dr. Sanjay Sareen. So, Dr. Adda, please, we welcome you. Please give your presentation.
Thank you so much. And I really appreciate this invitation. And it's indeed an honor for me to speak at this very important meeting. So my name is Danjuma Adda. I'm the president of World Hepatitis Alliance. And then I am also a person living with hepatitis B. So the World Hepatitis Alliance is an international, just on the next slide. The World Hepatitis Alliance is an international network of patients and community groups across the world. We drive advocacy and drive awareness about hepatitis. We are led and governed by people living with hepatitis. As in this instance, I'm also a person with hepatitis B. And I lost my mother to hepatitis C in 2007. And actually, that was my motivation for starting the charity work that I do. So we raise the voice of people and communities affected by viral hepatitis, calling for urgent action to see the elimination of viral hepatitis by 2030, because the World Health Organization have set the goal of eliminating hepatitis by 2030. The next slide, please. Though I will actually speak more off from my heart rather than really from the slides. So if I don't ask for next slide, you just bear with me, because it's more of a sharing my personal story and then the challenges faced by hepatitis community. Now, globally, hepatitis affects over 296 million people across the world for hepatitis B and over 96 million for hepatitis C. Diagnosis and treatment is uneven. As a matter of fact, only 2% of people, especially for LMICs with hepatitis B, have been diagnosed, and 0.1% are placed on treatment. Whereas for hepatitis C, about 13% have been diagnosed, and only just about 12%, 5% have been treated. That is even from just one country, which is Egypt. The World Health Organization have set a goal to eliminate hepatitis by 2030. And the goal is to make sure that 90% of people with hepatitis are diagnosed and 80% are placed on treatment. That is a very laudable, ambitious goal, which is not impossible to achieve, but it seems very difficult to achieve because of the poor commitment and lack of political will by countries and national programs towards achieving this goal. Next slide, please. Now, this is a cascade of care. I've talked about it earlier, about hepatitis across the world in terms of care, testing, and diagnosis and treatment. Remember, the goal is 2030 to reach elimination. But as it is now, very little has been done in achieving in diagnosing and even achieving treatment. And hepatitis C is curable, and this is one thing that bothers and touches the heart and head of some of us. Hepatitis C is completely curable with 3 months or 6 month treatment. Hepatitis B has an effective vaccine that could be administered either at birth to babies, and that will prevent infection, and there's an effective treatment. But the challenge remains, how do we diagnose more people? How do we place the pills and the medicine into the stomach of patients? So the missing gap is between diagnosis and treatment. And that is a major gap that needs to be closed if only the elimination goal by 2030 can be achieved. Next slide, please. Now, there are a lot of obstacles that faces a patient community, especially people living with hepatitis, towards living optimally their lives. One is stigma and discrimination. It will be very difficult to achieve the elimination goal of hepatitis B or C because of stigma. People are stigmatized, people lose jobs. As a matter of fact, in some countries in Asia, people don't get visas to travel if they have hepatitis. People are diagnosed with hepatitis are sent out of jobs in families. People with hepatitis are not even accorded the rights that they deserve as living beings. And that is a very big problem to be overcome. I know when I was personally diagnosed with hepatitis, it was very difficult for me at that point because hepatitis is seemed to be like a death sentence. So majority of people are internally stigmatized, and even stigma in the social sector, stigma in the workplace, stigma limiting people from achieving their life ambitions and life goals. And hepatitis, to be honest, is like the neglected child in the home, whereas the older siblings are getting so much attention in terms of funding, in terms of care, but hepatitis is so neglected. The next slide, and that will now show some of the barriers the community experience. So there's a lot of equality. In the context of universal health coverage, of leaving no one behind, hepatitis B is neglected. Hepatitis C is neglected. This is a disease that is curable, a cancer-causing infection, but there's very little in terms of care, very little in terms of diagnosis, very little in terms of support, peer support, or even testing and treatment to achieve the goals of elimination. Next slide, please. Now, stigma, I've mentioned this, out-of-pocket cost is a very big challenge. Most countries and programs do not have health insurance, and so patients have to pay out of pocket. There's very poor political will across most countries in achieving elimination, and inadequate testing and diagnosis. There's low awareness of viral hepatitis. There's very poor global and national investments towards hepatitis elimination. And yet, this is a cancer-causing disease. 70% of liver cancer is caused by hepatitis B, and about 15 to 20% by hepatitis C. And yet, there's very poor investment, very poor support in terms of testing and even diagnosis or treatment for people with hepatitis B. So I'll round up by saying, to achieve the goal of elimination by 2030, we require collaboration among clinicians, collaboration among patients, collaboration among communities. To achieve elimination, services need to be simplified, services need to be decentralized, because the WHO set a goal of people-centered care. Person-centered care cannot be achieved if the lived experience of patients and communities are not integrated into co-creating healthcare. And that is a big challenge we have in most programs. Patient voices are not included in co-design of health programs, in co-design of treatment guidelines development, or dissemination of guidelines, or even implementing services. Whereas the global sector strategy for hepatitis and HIV clearly talks about empowering communities. The hepatitis community is so disadvantaged because patient communities are not actively engaged. They're not actively engaged to amplify the voice, and even for peer navigation, or even for community services. So for the elimination to really happen, there's need for patient empowerment. There's need to make the patient to sit in the driving seat as part of the healthcare system, as part of the people that will co-create the health services that is meant for them. So achieving elimination is possible. We have an effective vaccine that can prevent hepatitis if babies are given this vaccine at birth. But this is not done across the world. Most babies are not given this vaccine within 24 hours of birth. Hepatitis C is curable with effective direct-acting antivirals, 3 months treatment or 6 months treatment. But most patients do not still have access. They have to pay out of pocket. And this has driven many people into catastrophic poverty. So this has to change if only there is increased programs, and we ensure that patient voice is adequately captured and patients are empowered to really be in the driving seat towards working towards achieving this elimination goal of hepatitis. So we can do it if all we work together as clinicians, community, government, policy, industry. If we all collaborate and work together, we can achieve this goal of eliminating hepatitis. And as a person living with hepatitis B, I can tell you there's a mental torture to this. So patients need to be empowered. There's need to break down this stigma so that patients who live in hepatitis, either B or C, can live a fulfilled, happy life without the fear of, being deprived of services. So thank you so much for this opportunity. I'll round up by sharing the opportunity we have for the World Hepatitis Summit. Can you go to the next slide? We have the World Hepatitis Summit coming up next year in Lisbon. Please, you can sign up to our website and register and be part of this. And I'm happy to be here. I'll sit back for the next few minutes if there are questions or comments, but the hepatitis community is happy to be part of this. And thank you so much for giving us the opportunity to be here. Thank you so much, and over from me.
Thank you, Dr. Adda. Very good summing up. And just one question I'll ask you. Like, what is the cost of antiviral for hepatitis C? I believe it's very costly in the Western countries. India, it is quite cheap. What is the situation in Africa cost-wise?
Now, hepatitis C treatment depends on where, but there is a negotiated price of $60 for 3 months. And that was a negotiated price in Geneva by the Hepatitis Fund and then other partners. But the unfortunate thing is that that is a cost at production level. Before it goes to countries and before it gets to the patient, the middlemen, the country people increase prices. And at the end of it all, patients in LMICs might get that drug for like $200, $300. Whereas the cost at production level should cost less than $50. And yet we're talking about communities that are living less than $1. How many people can afford to buy hepatitis C treatment for $250 or $300 as it is in most of LMICs, like Africa, where I come from? So that is a big gap that needs to be addressed. And I hope that maybe if there are industry partners here, they will be able to tell us how best we can get the medicine, because the most expensive medicine is the one that doesn't get to the stomach of the patient. And we have so many people dying of liver cancer because they cannot afford this treatment. Thank you, and over from me.
Thank you, Dr. Adda. We regret that Dr. Sanjay is not able to join for some reason. So I request Dr. Sachdeva to give his presentation on tuberculosis.
Thank you, sir. I don't have a presentation per se. So primarily, I can talk about TB elimination or TB control, whatever the other countries call it. Just to give you a perspective, TB, they say it's almost a 20,000-year-old disease. So the one good news is that the very fact we are thinking about elimination now points to the fact that there are now tools available by which we can think about TB elimination. So that's a scenario which is optimistic. And the tools which are available are both managerial tools, public health tools, as well as better drugs, better diagnostics, and diagnostics which are very sensitive, specific, drugs which can almost cure you 100%. Even for now, for drug-resistant TB, you expect around 90% of cure for drug-resistant TB, which used to be about 40% about less than 5 years ago. So huge developments on science, huge developments on management science, public health, huge interventions on public health side, which have at least made us think that we can eliminate TB in near future. And that is what the global targets are saying. Even UN Sustainable Development Goals say 2030. India said we will try and eliminate it by 2025. Now, the basic interventions for TB elimination, again, some of the old one is early diagnosis, early, quick, and a correct diagnosis, then early treatment. So those two still hold true. Added on to those basic interventions are now, first I'm talking more on the science part of it, are now what we call as TB preventive therapy. And we also have a vaccine in sight in near future. We are looking at vaccine globally to be rolled out by 2027 or maybe end of 2027. So there is a huge hope on vaccine side also. On the managerial or the public health side, how do we increase access to patients? So within TB program, there has been huge focus on engagement of private sector. How do we get patients from private sector? So especially in our country and our part of the world, which is Southeast Asia, we see a close to 50% of patients being seen in the private sector. And that was a huge gap which was existing about 10 years ago. And I recall when India started rolling out private sector interventions in 2012, 2013, the first year we could only reach out to around 3,000 patients. And last year in 2022, they reached out to 700,000 patients from the private sector. So huge buy-in with the private sector, huge interventions on the private sector side, and also the national program supporting private sector engagement in the form of putting funds for private sector to reach out to patients. Also allowing all public health actions free of cost to private sector patients. So that's a huge plus on the public health side, that they've shown that you can increase your reach. And now, at least in India, the gap between estimated and the what you detect is narrowed down a lot, and we roughly miss around 300,000 patients now, as against 28 lakhs or 2.8 million patients. Program is able to reach about 2.5 million patients. And if we see about a decade ago, that was close to 1.5 million. So huge gap has been bridged by experts, public health experts, and the suggestions from the public health experts. Also, with the onset of when we saw the COVID pandemic, we also saw a huge mobilization from all stakeholders. We also saw a huge mobilization by patients, interest by patient advocates, and also by community to increase accessibility to services. So another intervention called community engagement, or call it patient engagement, we call in India, we call it engagement with TB champions, which is patients who have been cured of TB, has also seen increase in access to a large extent. And if you look at the national program now, specifically in India, so close to about 30,000 TB champions are involved in the program. There is a huge all state, districts, and even blocks have what is called as TB forums, which are again led by TB champions or patients or patient advocates or TB activists or TB Vijeta. The various names have been coined for that. So that's another intervention. Also, huge political buy-in, and that's one of the major plus which we see in many countries now. I have seen even Prime Minister of Timor-Leste saying that they will eliminate TB by 2025. India, of course, has committed to eliminate TB by 2025. So all this has led to a huge interest, advocacy, and a huge mobilization of resources. TB program alone has seen its budget almost tripling in last 7 to 8 years. So the budget has almost gone by 3 to 3.5 times what it used to be in 2015 level. So generally we track all our indicators from 2015 level now, once we have achieved the Millennium Development Goals. So what we have seen is a huge increase in funding. Whether that's still sufficient or not is another question, but that has seen an increase of almost 3.5 times from the 2015 levels. Also with this huge political advocacy, another intervention, again a public health one, which is rolled out, it's called Pradhan Mantri TB Mukt Bharat Abhiyan, or it's actually people's movement against TB, where any individual, organization, government servant, private people from private sector, all walks of life have been given a clarion call to adopt TB patients while they are on treatment, offer them livelihood support, offer them treatment support. And now with the help of about 100,000, what we call as Diksha Mitra or Friends of TB, almost 1 million TB patients have been adopted by them, and they are, it's like hand-holding patients in their journey towards a logical cure from their disease. So there, we see a huge movement on the patient side, and as I see, this is a patient summit. So involvement of patients, communities, and other stakeholders. We actually have drawn what Manoj will talk about it, is from the HIV program. So HIV program was one of the first program which showed huge involvement of people affected with the disease. Same was later scaled up to TB program. And now even TB program boasts of involvement of patients with disease to a huge extent. How much of budget or funding is going into that? Now, I mean, now about 1 to 2% of overall national budget goes towards engaging with communities, which is a national budget. And outside of what we call as extra budgetary or not coming from the national government will be another 3 to 4%, which is now dedicated towards involvement of patients and communities. And they assuming the charge of taking their own health in their hands and seeing to it that all patients are reached and that they reach their logical end of cure, and the journey is also very smooth. So they not only ensure cure, but they also ensure that the journey is seamless, a smooth journey, and they don't have to undergo many challenges in that journey. So that's also a huge plus which we have seen. So these are the public health interventions which are playing a huge part towards TB elimination. Where are we now? So if we see, India still remains a high burden TB country, but if we compare ourselves with the global achievements, in reduction in incidence, we are almost, again, I'm using 2015 as a benchmark. So our reduction in incidence is almost 18% versus 8.7% global reduction in incidence. So you see the huge advocacy by bureaucrats, politicians, patient groups, TB champions have actually enabled you to extend resources to a large extent, engage with the private sector and show you that accelerated decline in incidence is possible if you involve all stakeholders and try to work towards a common goal. So similarly on mortality, we are matching with 28% reduction in mortality. What we still have to match is reduction in catastrophic or out-of-pocket expenses, which still remain very high in our country. And there is another intervention which is called engaging with the private for-profit sector to contribute them towards the TB program, what I call as extra budgetary resources. So almost now 400 for-profit corporates are contributing resources either in kind or in cash with the help of various civil society organizations to help TB program achieve its goal. So again, a huge intervention, again guided by public health experts, demanded by patients. So there is a huge voice there. And we have been able to extend and show that kind of a support to the national program that yes, we are there with you and we will walk this path together. So that's again a very strong public health movement which is occurring, and it's called in our Hindi we call it Jan Andolan, or it's a mass movement for TB amongst the population. So that's again a movement which is so we are on the right track. We are all geared up to be there. Yes, there may be implementation challenges, there may be some shortcomings in implementation, which we can discuss, and we can always try and improve those implementation challenges. We can saturate our existing interventions. We can roll out future interventions in a more logical, rational, well thought out manner. But we are prepared to meet this challenge head on. I think, sir, I'll end here and
thank you, sir. It's very exhaustive and very first-hand experience. I have just some doubts as an old school. Actually, when we were in, earlier days, we used to say that tuberculosis infection does not mean disease. Like 30-40% Indians are carrying. So I was just wondering whether hope we are not going to overdiagnose people who would not have progressed to disease. I mean, this was a teaching, old-time teaching. People carry infection, but everybody is not disease. So any thoughts on that, sir, vis-a-vis the program?
So major change which has occurred within the TB diagnostic algorithm is that now they don't rely on a single test or a symptom to say that you have a TB disease. So they have put in an algorithm which increases the sensitivity, and also at the same time, you don't diagnose false positive, you don't rule out false negative. They have put in checks and balances. So like, if you remember, sir, olden times we used to have mass miniature radiography.
Yeah, exactly. That was
to
discontinued.
diagnose TB.
Yeah.
So what has changed now? We still use X-rays to diagnose TB. But what has changed now is in 1950s and 60s, X-rays were used as a diagnostic tool. But currently X-rays are used as a screening tool. So they are not used as a diagnostic tool. So once you use X-rays as a screening tool, what you are trying to do is, and then with high sensitivity. So X-ray have a very high sensitivity. There'll be large number of false positives on X-rays. Now, how do you rule out false positive? You follow it up with another diagnostic tool, preferably test, a smear or a sputum test, a molecular test to rule out TB. If you cannot get sample, then you use clinical symptomatology and other things to rule out TB. You also look at other adjunct supportive investigations. And currently, if you see, sir, almost 80% of patients have a microbiological diagnosis. We still use clinical diagnosis to some extent, 10 to 20%. But that's when the patient is sick, he's showing all the symptoms of TB. So to a large extent, the problem of overdiagnosis and underdiagnosis, we are trying to take care of this. The microbiological diagnosis is very sensitive and specific. a new molecular test like GeneXpert, TrueNat. We also have further now one more test called PathoDetect, and a host of PCR platforms which were installed in COVID can also do a TB testing. So all this, an algorithmic approach has helped us to actually find the correct diagnosis. And if you, we'll come to you. If you miss a diagnosis, you can still do culture result or other things to do that.
Second question, sir, is on the BCG vaccine. I think 2 days ago, there was a news also that they are going to see for revaccination with BCG. And as per, again, old school, BCG was not found to be very effective. So are you going to having a new vaccine or the same vaccine we are going to?
So currently there are many vaccine candidates which are in the pipeline. I said globally expect one to be rolled out in another 3 to 4 years. In India, what they are trying to do is, and what the evidence in almost 27 or 28 countries, which do BCG revaccination. Has shown that if you revaccinate the vulnerable population at adolescence or thereafter, I mean, what India is trying to do is at 18 years of age and above, you can demonstrate some reduction in incidence. And it's a complementary strategy to TB preventive therapy. So one more armamentarium in the prevention basket of TB. So the first armamentarium being airborne infection control, second being TB preventive therapy, third is they are planning to roll out BCG revaccination. And what they are also saying, they are doing it on a pilot, as a pilot learning project. So they'll have about 180 districts which will implement BCG vaccination and 180 controlled districts. Over the next 2 years, they will try to come out with some evidence on whether it's working or not, and then take it on further and scale it up nationally. So currently, it's not a national scale up. It is under the guidance of Indian Council of Medical Research on a pilot mode.
Third, last question, sir, very important. You have covered it in great detail. That is involving the private practitioners. Now, a lot of people, particularly in rural areas, they go to Ayurveda, homeopath, other system. Are you going to involve them also in this?
So there is a actually MOU with Ministry of Ayush. There is also an engagement with Ayush providers at state level, district level. So there are definitive interventions on involving Ayush. They are also being incentivized on if they sort of refer and get a TB patient diagnosed. They are also being offered free drugs, free diagnosis from the program, which they can refer the samples, get a free diagnosis, and if they are diagnosed with TB, they can use the drugs which the program gives them. So huge involvement of Ayush practitioners, and even beyond Ayush, they are also involving other pathways. So Himachal has, Ladakh, and those areas they have Rigva, Sopa, and other pathways also, which are not listed in Ayush, are also being reached out.
Any questions from the audience? And tuberculosis is important, yeah, please.
My name is Nidhi and I'm from Singapore. I'd like to highlight the fact that the TB bacteria likes to sit in the gut also. And many people are not aware about it, including doctors. I believe a lot of gastroenterologists are misdiagnosing patients who have either Crohn's disease or ulcerative colitis, and they are being diagnosed in India as having gut TB. So is there some level of awareness being created around that?
Yes, of course. I think AIIMS also did one study on gastroenterological TB. And we also, specifically in the pediatric age group, we say you can take a gastric lavage or a gastric wash or a stool sample and run a molecular test on that to get a confirmatory diagnosis of TB. It's not that sensitive and specific as with other samples like sputum, but it's still, if you get a positive test, it's a good help on your armamentarium to say with definitive strength that it is TB. Of course, clinicians still use, and we do give them a leeway in difficult cases to diagnose TB on clinical trial. ground. So that's what I'm saying. Almost 80% get a microbiological diagnosis. But at the same time, because TB has manifestations, which are so many, we do allow some leverage to clinicians, coupled with supportive evidences, to use their clinical judgment along with some laboratory support to arrive at a diagnosis of TB.
One
Sir, one
thing
more question.
came to mind just
And
regarding.
just for your information, also, AIMS has developed a guidance document on diagnosis and management of extrapulmonary TB. The first edition was way back in 2016. It has just been revised this year. And again, they have used the Cochrane group to find evidences on diagnosis and management of extrapulmonary TB. It's a very good document to go through.
Anyone
Yeah.
from the audience?
Sir, one question. My name is Jay. I'm from Oracle. So recently I was involved in a research study on digital health interventions for tuberculosis. So what I found was the last 2 years, we are not using any medication adherence technologies like 99 dots, VOT. So we did a lot of pilots 3 years ago. It was found to be very useful to really track the medication adherence, but they're not really using it anymore. Any specific reason
No,
why?
all these technologies which are technology, internet-based and other technologies are actually approved under the national program. What I also referred in my initial talk is that while there are huge number of policies and interventions, not all have reached their full saturation levels, and not all are accepted by patients per se. We are here talking about patient perspective also. So while 99 dots has proven to be a good technology, what we observed is that the uptake of 99 dots by patients remains poor. And more than the uptake of 99 dots, the action by so-called providers on the signals which you get from 99 dots has been not very, very optimal, which we would desire. It's a question of implementation shortcomings, but all these technologies are approved in principle, including medication, pill boxes, 99 dots, SMS reminders. So they are part of the national policy, but their implementation does remain suboptimal.
Last question. I am taking the privilege of asking the last question.
I had one question, sir.
Okay.
So
Last but one.
again, this is a learning from HIV TB where comorbidities were taken into consideration and screening done for both. So TB patient for HIV and HIV for patient. Is there any such thought process for diabetes? Because we see an increasing trend of diabetes in the country and also globally, and people with diabetes being more prone to tuberculosis.
So again, TB diabetes screening, bidirectional screening, again is a policy from, I think, 2013 onwards. So where it doesn't happen in true letter and spirit bidirectionally is because the diabetes program does not have a very good structure to capture data, report back. While all TB patients, almost 80–90% of them are tested for diabetes, and we know what is the percentage of diabetes within the TB patient. The same is not happening with the diabetes program because they are more clinic-based. So there are diabetic clinics. There are no district-based structures within the TB program. So as and when the NCD program matures and they are able to capture and share the data, it will see the true light of the day. Again, in policy, in principle, it's an approved policy. Again, a suboptimal implementation. Main challenge remains on the side of the non-communicable disease program.
Last question, that we are a country where a lot of animal husbandry, bovine tuberculosis, particularly rural areas. So we don't treat any program on that because we cannot eliminate as long as there is a extra human reservoir.
So there is a lot of studies which have gone on animal TB, and many studies have actually pointed out that we don't see much of transmission from animals to humans. But we have seen reverse transmission from humans to animals in our country, especially from southern part of India, Kerala and other where we have seen transmission from humans to elephants and well documented. transmission. So, bovine tuberculosis causing human tuberculosis, not well documented, but humans transmitting to animals is documented to some extent. But taking your cue, yes, as we move towards TB elimination, zoonotic TB, also non-tuberculous mycobacteria will become an important component which will need to be addressed in future.
Thank you, Dr. Sachdeva. You all will agree this was a very informative, lot of my old doubts, and I think better than a prepared presentation where post-lunch everybody would have gone to sleep. So in fact, I would have gone to sleep. Yesterday I came late night after 1 a.m. So I thought I might go to sleep. So that's why I kept on talking. Now we come to the last
Thank you, sir.
Manoj Pardesi. He will be talking about his experiences and patient experiences living with AIDS. Manoj, please.
Thank you, Doctor. So till the presentation. I just request, I know after lunch little bit everyone is drowsy. So I request just pay 5-10 minutes attention. Keep your phone aside and let's hear the journey of patient empowerment. Since morning we are discussing on the patient empowerment. So NCPI is a national coalition of people living with HIV. We call it as a movement to improve the overall quality of life and keeping human rights at center. And I think that's the success of the overall HIV program globally. Because even globally, the HIV movement started with gay people rights. And that's what that right-based approach has been inbuilt in the whole HIV movement. Before going to this, like just since morning, like what I have heard is that there are prevention, care and treatment tools are available. But because of lots of issues or barriers, it is not accessible or it is not affordable. Literacy, patient literacy is a problem. Quality is a problem. Stigma is a major issue. Political commitment. All these things are lacking, which is creating a barrier between the preventing or care tools to the end users. Can we go next? Okay. So, like this is a, can you, yeah, take it. So mainly, I'm not going to talk any data or number, but it's a like human face to the HIV epidemic. As we all aware that when initially people now are calling HIV, previously we used to call AIDS, and AIDS is equal to a death sentence. So from the death sentence, fear, shame, guilt, stigma, the movement started with the hope, courage, like being a positive, creating a positive change and contribute towards the HIV response. We not only asked for treatment, we sat together with the government, we sat together with the policymakers, stakeholders, we designed the intervention, how we want, how it will be received from the community. And that's the biggest strength we brought globally to halt and reverse the HIV epidemic. Next. Let's skip. These are the few cases where initially HIV patient, we don't call patient, but in today's conference, everyone is using patient. So I will use that word. So these are the stories where initially people put behind the bar and they fought, they took the legal way to fight the battle. And that's what I think today we have a HIV/AIDS Act in India, which is passed in the parliament in 2017. Next. So, like, I will not go read everything. Can you go back, please? Sorry, I was not aware that this is happening. Okay. So, as I like, initially it is very difficult even to cope within. And we thought we can only discuss with doctors because any disease is we have to first see to talk with the doctor. But in HIV,
the peer support has helped a lot in building that courage and confidence. Next. So we realize that if we have to, our voices should be heard, we have to build our capacity, we have to build our strength. So we heavily invested in collectivization. We came together, we learned a lot. Treatment literacy is one of our key strengths. Like even a illiterate person will be knowing what is CD4 count, what is viral load count, which medicine they are taking. That much treatment literacy has been happened in the HIV field. And that is because of like the whole investment in the patient empowerment has been put. So lots of us, like previously, now everyone is very familiar with the technology, but in 1995, even 2000, we still used to use that big computers, and one computer is used by 5-6 people. So, but we invested. The point here I want to make is that we invested in our capacity building, and the whole lots of people since morning is talking that somewhere we need to invest in patient literacy and empowerment. Next. So initially, like lots of barriers were there, especially access to treatment. I still remember the cost of 1 month medication for HIV was 68,000 rupees, which is highly impossible in the year 97, 98. 68,000 rupees per month is beyond even whoever will be the big businessman. For them also, it's very tough. We fought our battle. We fought with the patents. Lots of patent opposition we filed, and we make sure that treatment is accessible, then affordable. So the moment we also pushed government to have a free ARV rollout program, and we did everything. Like we did protest. Lots of us were kept in this Tughlaq police station for some while. They didn't arrested us, but they kept us hold for whole day, and then they released us. So we fought for our treatment, and as a result, like today, treatment is the Indian ARV is not only catering to India, but also the 80% people living with HIV population globally. Next. So these are some examples. We never, all opportunities we used, wherever we got the opportunity, we fought for against the patent, we fought against the affordable prices, and also we fought about the latest drugs should become as part of the treatment rollout. Next. Okay, let's go next. So here is the topic which we have been given, like HIV lessons. So patient empowerment, involvement in planning, decision making. Then the most important is we also played a role of peer. So services given through peer is one of the key change maker in the HIV intervention, and that giving face and voice to the epidemic has helped in controlling and also for patient like living a healthy life. TB, sorry sir, don't take it personally. TB is still a medicalized approach. Tokenism approach towards community engagement, and besides high level political engagement, infections are still rising. Like, and lots of reasons, lots of barriers, not only the things, but one of the things we see that if patient engagement will be ensured, we will also make health system accountable, and then it will be a win-win situation for both. So that is something which we can do, and same thing for diabetes, because HIV in diabetes is also increasing among HIV. Now because of the some NCDs are HIV ARV induced, and some NCDs are age specific. So NCD is a bigger issue in now people living with HIV. So overall, like globally, the HIV funding is shrinking. And the result is like there is a lots of kind of engagement has been reduced. Engagement at every level, not only at political level or bureaucratic level, but even the donor level. And then since funding is not there, then automatically even programs are getting affected. So now, to give you the scenario, infections are almost rising in every state. Infections are rising among young population, and that's not the like if we not able to control it, it will again bring back us to the era of early 90s. And most of the state AIDS control society here, the program is decentralized. There is a national AIDS control organization and a state level state AIDS control organization. So state AIDS control organization is not having a full-time person to look after the HIV program. And then it dilutes the leadership, and then that is also affecting in the implementation. Long COVID, I don't know like who are the researchers here, but we are noticing that people, those who took 3 vaccines, are their infections are not going early. Even the common cough cold is persistence for more than 20 days, 1 month. Even besides of 1 or 2 antibiotic course, it is not going. So I don't know whether it is a area for research and how best we can do it, but definitely research is needed among people living with HIV, those who had COVID and those who had vaccine, both. Can we go next? So I will just not repeat, but these are the things like which we can see to replicate in other responding to other illnesses. Next. So initially, actually, every death we used to personalize, and we used to think that okay, ab 6 mahine ke baad mera number hai, something like that. But today, at least, like because of lots of people's activism, we are still here, we are alive, and we are contributing. Thank you so much.
Thank you, Mr. Pardesi. It's very well covered many aspects. I have certain probes rather. Very important thing you said about peer group education. Peer teaches the safe behavior to the, and secondly is the empowerment of women as a decision maker. So summing it up, do you know anything? Can you say something about the pioneering project in India, Sonagachi project? So I would just like to highlight that because that was one of the success stories, Sonagachi project. And of course, Thailand was another country with 100% condom use. It eliminated, it had a very high rate, and particularly in the armed forces, and it brought down that Thailand. So something about the Sonagachi project.
Sorry, sir, I'm not much aware about Sonagachi project itself, but I know that there is this collective has been like able to create a mass kind of
good you don't know, because then I want to speak on Sonagachi.
Yes.
Well, it just happened by coincidence. I was in Kolkata that time. I was in the armed forces. I was almost got involved with it, but didn't work out. But this study was done among commercial sex workers. You know, initially when the HIV first came to India, it was only focused to high risk. That is the commercial sex workers. It was all with promiscuous behavior or drug addicts. So that was confined. The epidemiology, that was the stage 1. And all places like Sonagachi in Kolkata is the red light area. So they had 5%, above 5% like other red light areas, the positivity among the commercial sex workers. So the All India Institute of Hygiene Public Health, Dr. Jana was the principal worker. and Professor Chakravarti, he made this project. And they took the leaders among the commercial sex workers, those who have good communication skills, and gave them the education. And these commercial sex workers, they went and to other sisters, those who are working in the red light area, they educated all others. So 100% education of the high risk group, commercial sex workers. And they empowered them also. Any client who would come, they would insist that they use a protection, otherwise they will not entertain them. So after a couple of years, the prevalence in the Sonagachi area among commercial sex workers went down much below the general population also, antenatal mother. In fact, I was in FMC that time. I used to teach my students the stages of the epidemiology. Stage 1 is that high-risk group, commercial sex workers, and then the bridge population, their clients, the truck drivers and soldiers, and then they infect their spouses, and it comes to the general population. So stage 1 is the high-risk group, stage 2 is the bridge population, and stage 3 is the general population. Then I said there is a stage 4 also, that the Sonagachi project is so successful that to have safe sex, one has to go to Sonagachi. So that was the stage 4. The message to convey is that it can be done. It can be done because as it is, the stigma is associated with HIV and stigma is associated with commercial sex work. So by focused here, they remove the stigma among the commercial sex workers and they remove the stigma about the sex work also. So this is something, a professionalism. And unfortunately now, Mr. Pardesia was talking, again, it is among youth, HIV is rising. This is a matter of concern. And probably I have seen in some countries, Western countries, when the antiretroviral, I mean, this can be a side effect of having effective treatment. Once the effective treatment is available, people become careless. They are treatable. So can it be that psychologically we have to study that also? It happened in the Western countries first. People become careless that the treatment is there. When they were concerned that there is no treatment, they were more careful. So this, of course, their drug addiction is also increasing and other things are also increasing. So it's a it is not an isolated problem. It's a psychosocial, lot of things are involved in this. Thank you. Thank you, Mr. Pardesi. I think this was a good session. Any questions from the audience?
One question. Since HIV and TB need antiretrovirals and antitubercular drugs, we also know that the LMICs or South Asian countries are hotbeds for antimicrobial resistance because of incomplete treatments. And this is like a double-edged sword, that you do not have new treatments coming in because it takes a long drug development pathway. At the same time, you see risk behaviors are increasing, and then there are other comorbidities like diabetes that is increasing in infection. What can be done to manage this situation, and what can patient groups do to spread awareness around this?
So what TB program has done is a policy called universal drug susceptibility testing. So before you initiate treatment, you do a drug resistance profile, which is at least to rifampicin. So if you get a rifampicin resistance, then you do a full-blown DST. But if you don't have a rifampicin resistance, you treat them as DSTB. So that policy helps us to some extent to differentiate patients who need treatment for drug resistance versus who can be managed with a larger number is drug sensitive. Similarly, HIV also started viral load testing and testing for resistance. Fortunately, we don't find much resistance as on date. The kind of testing they have undergone, they have not found much high levels of resistance among HIV patients so far. But maybe as you scale up your viral load testing, you'll start getting up those numbers. But they are also sort of introduced that policy of shifting to another regimen. And that was introduced, I think, about 7-8 years ago. So I'm presuming they must have scaled up viral load testing and started categorizing patient who needs to go into which kind of treatment. But so far, they have not shown very high levels of resistance in HIV. The adherence tends to remain good in HIV patients, courtesy advocates like Manoj.
So we are consistently advocating with NACO. So the current Global Fund cycle is actually now the money is allocated for the drug resistance test. And so that will start like after the April 2024.
Thank you, sir. Respected dignitaries, eminent panelists for giving deep analysis and overview on lessons learned from past to how to dwell and deal and prepare ourselves for future pandemics. But as we always say, precaution is better than cure. So yes, and we'll make sure that next time before the summit, we are better prepared. And yes, I insist we all should put our hands together for the milestones we have achieved and reached here. And we are discussing these important topics and, adhering to the future analysis that we can all do together to make our patient services better. Please put your hands together. Everybody appreciate yourself and thank you. Thank you, panelists. I'll please request you all for a photograph, please. Yes, sir. Anyway, do we have Danchuma sir online? I would like to put 2 points forward. This session is casted online on Zoom. You can share the links with your committees, organizations, families, and I think it's worth sharing this awareness. Also, we have very nice photo booths being crafted for you all, where you can take good memories along with you for this event. Thank you. Now, please allow me to invite our next panelists for the session on women's health, endometriosis, PCOC, and NCDs, the double disadvantage of gender and being left behind. How can we prioritize women's health? I take the honors to please call upon the chair and moderator for the session, Dr. Ratna Devi, Director, Patient Academy for Innovation and Research and the backbone for this event. Please put your hands together for Ms. Ratna Devi. It's a proud privilege to call upon our next panelist, Ms. Sudhapa Biswas, Co-founder, Executive Director, Cancer Foundation India. Can we have you on the stage, ma'am? Okay, she'll join us virtually. Next, PCOC and metabolic syndrome will be covered by Ms. Chand Kaur, Founder and Chief Executive of PCOS Relief UK. Ma'am, can we have you on the stage? It's an honor to have you here this evening. Please put your hands together for the lady. Next, please allow me to call upon Ms. Ranjit Preetham Kaur, Board Member, Reach to Recovery International, Breast Cancer Support, Malaysia. It's an honor to have you, ma'am, here. Please. A big round of applause for the ladies here. The woman power, we all can see that on our dais. Last but not least, Ms. Surita Morgan, President, Endometriosis Society of Malaysia. Ma'am, it is our honor to have you here. I leave the session to the chair and moderator, Ms. Ratna Devi. Stage is yours.
When I designed the program, I didn't realize that the saying that women always come last will come true. With an all-women panel and discussion on topics that are women-centric, I hope this will be an interesting session that we will have today. So as I keep reflecting on this topic, we have maternal and child health programs, we have reproductive health programs, not only in this country, but globally for nearly 3-4 decades, 5 decades, 6 decades. And many of us keep talking about safe maternal health. And very recently, I think last year, we had the topic around patient safety, also talking about safe maternal health. But we talk about NCDs and the 5x5 as a WHO strategy, where we talk of diabetes, stroke, hypertension, cancer, mental health. But then conditions like PCOS and some women cancers as well as endometriosis are lifelong, debilitating, take away productive years of life. However, because it's women centric and not much is discussed on it, it never gets included into policy or into health sector financing, for example. So you still have insurances that deny treatments because many of these conditions are related to fertility, and fertility is considered something that is a luxury. So it is not covered. So today we have excellent panelists on board, and it is my pleasure to first invite Shutapa, who is joining us online, and she will be talking about HPV and cervical cancer. And with the IRC report and its targets of 1990 and how we want to vaccinate every woman and every girl who deserves the vaccination, what is it that we can do? And she leads a patient organization or a civil society organization called Cancer Foundation of India. So what is it that we can do? Over to you, Shutapa. Shutapa, we are unable to hear you.
Can you hear me now?
Yes, we can.
Okay, thank you so much, Ratna. I'm missing the opportunity of sharing the dais with such powerful women. My loss. But I would really want to congratulate the organizers of the first International Patient Summit 2023 for including cervical cancer. You know, when you talk of cancers of women, what gets included mostly is breast cancer. I'm really glad that you all thought of including cervical cancer as the cancer of women that we need to focus on. We have to understand that it's a reality that, you know, women are getting cervical cancer and they are losing their lives to it. I've been working for the past 23 years on this. And a couple of things that I've seen that, you know, there are a lot of things that come into play when we are talking of cervical cancer prevention, because people in general don't understand if it can be prevented. You know, we are often told a cancer can it really be prevented? So, you know, it can be prevented. There are ways to do that. And now what, as Ratna mentioned, that, you know, this is the only cancer that is up for elimination. WHO has come up with a very clear strategy where you need to vaccinate every young girl between 9 to 15, 90% of them. 70% needs to be screened with a high performance test, even if they come once in a lifetime. And the third is to treat all the precancers and cancers, which is 90%. Of course, 100% coverage is the best, but they took it to 90%. And that's the target for 2030. We don't know if we'll be able to achieve that or not. But one of the things that needs to be clarified here is that, you know, the difference between elimination and eradication. We are not eradicating it. Elimination here means that we would bring the numbers down, the incidence down to 4 per 100,000, which means it will not be a threat to public health any longer. It will remain as a disease, but can be controlled over a long period of time. So which is the primary thing that everybody has to understand? It's a very common question that we hear. And, you know, when it comes to women, we found that, you know, I'll start with screening, Ratna, that, you know, screening, we find that women do not go for a health checkup when they don't have symptoms. Now, what the fundamental of screening is that you don't have a symptom, you still go for a routine test. There are a set of tests. Now, some that the government offers for free, the visual inspection, but if a woman wants, she can go on her own for a pap smear or any other test, HPV DNA test, whatever she has access to. But it's a matter of routine that every woman without having symptoms would go for regular test for cervical cancer. That's the screening piece of it. Now, the government has its own guideline. There's as Ratna says that, you know, we have the NCD program, which is called the NPCDCS and renamed as NPNCD, including a few more diseases. The entire focus is on NCD screening, now which includes 5 tests. You would have blood sugar, blood pressure, and 3 cancers, which is cervical, breast, and oral. Now, what we see in the field, that the government issued a guideline in 2016, gave it to the states that please roll it out. And when we are currently working in 2 states, Mizoram and Meghalaya. Mizoram has the highest cancer in the country. So working with the government there to streamline the cancer screening. So what we found there is that, they're not doing the 5 tests. They're doing the blood pressure actually for all, and blood sugar on request. And none of the 3 tests for cancer are done. But it is reported as NCD screening. So the government of India is receiving a huge number that NCD screening is being done. But when you see the NCDIR data of ICMR, which says the screening is 0.6%, 1%, 2%, it varies. That is the reality. So screening, though they are supposed to, it is not being done. Staff is recruited. All consumables have gone to the sub-center level, but it's not being done. And we've been working for the past 3 years, and the reality which I see is that none of the staff in the screening units or the NCD section is screened. They themselves are scared of screening. Now, if they are not convinced, how do you think they're going to convince the community to come and screen? That is one of the things of the many barriers that we have seen. So that is what happens with the screening tests. Then we come to the other part of it, that women, once the government is rolling out a screening program, women themselves, as I said, they don't come up for screening. Indian women have very high threshold of pain. Until they really have a serious issue, they are not able to get out of the bed, they will not go for any health checkup. Now, what happens with cancer most of the time is a very, very quiet disease that grows. And especially for cervical cancer, you don't have apparent symptoms. And those that are there of, irregular bleeding and other things, they're not aware of the symptoms. And even if they're aware, they will think that it will go on its own. Now, this particular cancer is caused by a virus, which we know is a human papilloma virus, the HPV. So when it comes to the virus, there's an infection that happens there. It's a very slow process. And thankfully for cervical cancer, it has a very long, like 8 to 10 years pre-cancer phase where you don't have the cancer, but you go through the phase where the cells are transforming. There's a transformation zone where the cells gradually get cancerous. And that's a long period. That's why they say if you screen within every 5 years or so, since it takes 10 years, 8 to 10 years for the cells to turn cancerous, you should get screened every 5 years, if not every year. No need to do excessive screening. So that is one of the things, but women would still not go for it. So that's the reality. They will not go for a gynecological checkup on a regular basis. That brings me to vaccination. Since it's a virus, so there's a vaccine. Now, again, the vaccine currently what we have is imported, so they are expensive. We have the Indian vaccine, which is still expensive. So we are hoping that, India will roll out its own vaccination program. It has included the vaccine in the UIP, the Universal Immunization Program, which means that every girl in the country gets it for free. That's one of the goals that we have had for a very, very long time. All of us who have been working, negotiating with the government, with the companies and the governments, really a lot of work has been done by a lot of us across the country. And we have it included in the UIP. It was supposed to be rolled out in January 2023, but it didn't happen. We are hoping it's going to happen soon. We are going to keep the pressure on so that it happens. Now, when that happens, then every girl between the age of 9 to 15 is supposed to get, 2 doses. If we have little more evidence, it will be 1 dose eventually, probably. And then it will be, if they're more than 15 years of age, they get 3 doses. So in the long run, we see that girls will get vaccinated. And when they reach adulthood, like, 25 plus or 30, they will also get screened. So when you have these two coming together, eventually cervical cancer will come down in a period of 15, 20, 30 years. So which is what I think is very, very positive. And what we find is that the government would try to do that because we have an indigenous vaccine now. Then comes the third part of it, which is the 90% women who have been diagnosed need to be treated. The third piece of the elimination strategy, which is treatment for pre-cancer and cancer. Pre-cancer is an OPD procedure, very, very simple. So if you are screened and something is found, you are found to be positive, then you go for a pre-cancer treatment, which is very easy to do. And if you get cancer, normally it will be diagnosed early, at an early stage. So again, it hardly costs anything. The treatment is very, very simple, and you can get back to work as soon as possible. And I think that is what is most important for a woman, because when you are getting cancer at the age of 30, 40, 50, we would really want the woman to get back to their life as soon as possible. So Ratna, if you would want to ask anything else if I've missed out.
Thank you. No, you put it up very well, the 3 strategies for elimination. Just a quick comment that any woman who's undergone these tests knows how uncomfortable it is. So maybe provide a sensitization on how to do the screening and make it comfortable so that more women can be confident that, it's the test is done with dignity, might be something that will improve uptake of these screening tests.
I just want to add one point here that, gradually over time, the tests are also improving. You are having better tests. Now we have come to self-sampling, which is being tried and tested, that you just have a small little, vial, which is given to you. You take it home, and at your own home or at privacy, you will take the sample from your vaginal area or cervical area and put it in that tube, in the vial. And either you deposit it to the center, wherever they are screening it, you're testing it, or you would have a health worker collecting it. So that model is being tried out. And if it picks up, then great. So you would find a lot of advancement in trying to make it as easy, as comfortable for a woman as possible. So that is happening. And even for the vaccination, again, if it becomes 1 dose, which we are looking at, there's enough evidence. So it becomes even easier. A girl doesn't need to come back again, because there's a huge amount of non-compliance that happens with, screening, with vaccination. Many of them get the first dose, and then the second and third becomes very, very difficult. So it is probably in the next summit, we'll have something more positive to talk about, and we'll answer these questions. Hopefully, we'll have better evidence coming up.
Thank you. And point of care diagnostics is becoming a reality. So it's not going to be next summit. I think it's going to happen very soon. Thank you. I'll call upon stage our next speaker, Chand Kaur. She's the founder and chief executive of PCOS Relief UK and a key leader within the healthcare sector, with over 10 years of experience being a founder, vice chairman, chief executive, and director, all at a very young age. And she is instrumental in establishing benchmarks in terms of covering all aspects of human well-being, from working life, quality lifestyle, learning, training, safety, physical and working environment. And over to you, Chand, to speak about PCOS and metabolic syndrome.
So good afternoon, everybody. Apologies, I think I'm starting to develop a sore throat, so please bear with me. I first off want to thank Dr. Ratna, her committee, and everybody here today to put on this absolutely amazing event. It's been an eye-opener and a real source of education, but also it allows us innovators, leaders to network and see what's going on around the world and how we can network and come together and support each other. I'm going to talk about PCOS, so that's a short for polycystic ovary syndrome. So I will just start off. Oops. So who am I? I am Chand Kaur. I am the founder and chief exec of PCOS Relief from the UK. I actively sit on the Women's Health Plan as well for the UK in Scotland. That's leading. As well as that, I'm actively involved in international health care as well. PCOS Relief. So we are a charity that supports females diagnosed with polycystic ovary syndrome. I established the charity on my own personal journey being diagnosed. So I was diagnosed after a 6 years battle with my GP, and to a point where I personally felt suicidal because I was left vulnerable, I was left with no information, and I was left just to deal with it myself. So when establishing the charity, I knew 3 main focuses that we wanted to focus on, which would be the advancement of health, the advancement of education, but also support ethnic minority community females who have been diagnosed with this condition. Polycystic ovary syndrome, so for those that don't know about polycystic ovary syndrome, is a hormonal reproductive disorder that has no cause and no cure. It affects 1 in 10 females worldwide, but 1 in 5 within ethnic minority communities, and it's still a condition that has no support at all. So it's very common, but there's a lot of lack of information, resources, signposting, and support out there. So And also in regards to that, there's over 80% of cases that are undiagnosed because of the lack of support that comes with this condition. It's a condition that doesn't affect how a female's ovary functions. It also has links with obesity, heart diseases, stroke, type 2 diabetes, and furthermore, such as anxiety, depression, and suicide. Yeah. So impact on physicality and emotional. So it both impacts your emotions as well as your physical side of things. So in terms of physicality, it affects your infertility, it affects your weight gain, it increases the risk of long-term health conditions, as mentioned, heart diseases, stroke, type 2 diabetes, and much more. And in regards to the emotional side, it causes depression, anxiety, suicidal, low confidence, and low self-esteem. Because with this condition, it's so linked to infertility. So imagine when being diagnosed, you are told that either you're going to struggle to conceive or you're going to be infertile. And in our case, in regards to our charity, a young member at the age of 10 was told by her GP that she was going to be infertile, to which point she said to us that she would never want to try to have a family. And that's not the message that we want to give out to any female going through any sort of menstrual cycle issues or women's health issues. These are also possible symptoms. The reason why I've said potential symptoms is because not all females have all these symptoms. You can have maybe 2 out of it, you can have 3 out of it, or you can have all of them. So again, there's a whole list of things that comes with this condition. It's not just a condition that has links to your menstrual cycle. Apologies about my throat, guys. I promise I do sound better than this, trust me. I got a really good Scottish accent, but not today. So in regards to PCOS, it manifests differently in Indian women, surprisingly. And with research, when we talk about Indian women, we talk about there's a lot of higher numbers of PCOS within Indian women. In regards to PCOS, PCOS often presents itself in younger ages within Indian women's, research has shown. It also shows that there's a huge link with insulin resistance, and 80% of females diagnosed with this condition has challenges with insulin resistance. There's a lack of awareness and understanding, as I have mentioned, because due to social stigma, this condition is linked with infertility, and a girl's seen, especially a girl within ethnic minority, if she's seen as infertile, I mean, she's going to be rejected for marriage, for relationships. She might even be rejected from her family as well. So there's a massive stigma and taboo around this condition. There's also limited access to information. So again, when we talk about PCOS, it's a condition that has no cause and no cure. And in the UK, unfortunately, GPs don't find it fit to be supporting this condition. So again, you're left on your own. There's a language barrier. When we say language barrier, because again, there's not enough information out there. There's not enough information to suit everybody from every ethnic minority community or even the Western population. And there's lack of diagnosis. When we talk about lack of diagnosis, again, it comes down to there's no support. The only support available is the pill, the patch, and the coil. And again, you can't be on that because if you are overweight, which you're more likely to be on, you're more prone to have a blood clot. So there's nothing available for females with this condition. Oh, my slides are gone. Oh, I think I've just got 2 more minutes. I think the slides are done. Yeah. I think I just got. Oh. Perfect. So when we talk about, so when I sit on the board of the advisory boards, I'm the only Asian person that sits on the board of that, and I take great pride in that. because I'm able to advocate for Asian people. I'm able to take the information away and actually say, this is what's needed for Indian communities, the Muslim communities, the Arabic communities, and so on. But what we find in policies that there's a lack of voice from, I do mention Indian women, but from ethnic minorities in general. They don't get asked in terms of how can they be supported? What barriers are they facing? How can we get them more involved? In terms of when it comes to research as well, all research is done is from the Western side. There's no really research comes from actually Asian communities unless it's within Asia itself or within, you know, India or Pakistan or wherever it may be. And accessing to services, treatment, diagnosis, it all varies because again, with PCOS, it's not just one condition, it's linked to so much. So in terms of signposting and actually getting available information can be so varied because again, it's so limited. The impact of these is there's delayed in diagnosis and treatment. As I mentioned, over 80% of cases are undiagnosed because there's lack of information available to actually make things happen. I think it went too forward. And then again, is increased risk to long-term health conditions because if we don't actually have females advising us or telling people this is our challenges, then how can we support them to prevent them from actually getting long-term health conditions? And again, you got emotional distress. It leads to isolation, depression, suicide. I mean, my personal journeys, I think I only had 5% left in me before I actually took my life away. But I actually felt really suicidal because I was left on my own with a condition I had no support on. So how do we support? So in terms of PCOS, I take it from my personal journey and how I would want to be cared for. So we support in terms of navigating a female's journey with PCOS, establishing what stage at PCOS is she? Is she actually on the higher spectrum where she is overweight, or is she actually on the other side of the spectrum where she's really thin, she's really healthy, but she's still got PCOS and she is still enduring all the challenges that come with it? We provide a safe space, a safe environment, because again, if you're from an ethnic minority community or either any community, there are barriers to be linked with a condition that is so close to infertility. We advocate and we increase the awareness about PCOS. So I'm very grateful again to be able to be speaking about the work we do here today. We empower females to take control of their own health, because what we do is we provide the education that allows them to then implement that in their everyday life. We raise the awareness within the Women's Health Plan. So again, I'm a true advocate, and if I don't see PCOS in the Women's Health Plan, trust me, I will be settling a debate about that. And I work closely with the Scottish Parliament and the Westminster, so I do take pride in holding MSPs, councillors, MPs to question and ask them, why are we not doing more for females diagnosed? Why is there a huge delay in terms of even just going to see a gynecologist or a dietitianist or a nutritionist? So these are some of our services. They're all free services for all our members. So we have the steering group, which is a monthly steering group where we allow a healthcare professional to come and speak to our members. This is a chance where our members have that direct one-to-one to ask questions that they potentially could not be able to ask their GP. It also allows a safe space because they meet other females diagnosed with this condition. So they can build a platform of friendship, networking, and also share information and advice. The diet and nutrition classes and the weight management work hand in hand because they are a 12-week program. In that, we provide all the resources. We provide personal trainers, we provide nutritionists, dietitianists, everybody to provide that education side of things of what to eat, how much to eat, what to exercise, how much to exercise, so that after that 12 weeks of those classes, that female is able to feel confident within herself that she's able to take those independently afterwards. We have the comfort talk, and this is for your mental health and well-being. So again, if a female does find herself in a difficult situation, she has access to somebody that she can speak to. And again, we raise awareness within community areas. And when I say community areas, I mean like the Gurdwara, the temple, the mosque. We actively go there. We do provide safe spaces to discuss and advocate women's health. And that's me. This is some of our photos that we've done. So that's within the Scottish Parliament. And then this is some of our workshops and everything like that. So we take great pride in the work that we do. And again, apologies for my throat. I sound terrible, my God. But thank you so much.
Thank you. I just had one very quick question before we move to the next speaker. PCOS is often taken as a lifestyle disorder, considering that there is rising incidences of childhood obesity. So pediatricians usually sort of tell the children who are obese that it is because of eating disorders and they don't test for PCOS. Is it a similar problem that you face in your country? And what is the advice then to pediatricians?
It is definitely something that we do face. And especially when we talk about children, no parent would want their children to go and see a gynecologist, especially when they've not hit puberty. You know, and I don't think people actually think that a female can go and see a gynecologist before she actually has her menstrual cycle. So this is something that we do definitely see. But I think when we talk about a woman, I think first we have to understand that, or first we have to all accept that a woman is seen to have a menstrual cycle, but also she may not have a menstrual cycle. So once we start to come normal to say, okay, we've got a daughter, we've got a sister, we've got something, then I think we will start to normalize to actually go and seek the support. And I would advocate that a female, I think, instead of being close to their GP, I think she should be close to a gynecologist.
Thank you. With that, I would like to call on stage Ranjit, and she is a board member at the Reach to Recovery International Breast Cancer Support, United Kingdom. She's also a consultant and trainer for several regional and global cancer-related organizations in topics such as peer support, peer navigation, doctor-patient communication skills, and health literacy. And she will be today speaking about NCDs and gender. Over to you, Ranjit.
I just good afternoon, everyone, and thank you for being around still in the afternoon. I wish to thank Ratna for having invited me to speak here, and I hope I can do some justice to this topic. So my area that I'm going to talk about is prioritizing women's health. And well, mainly I'll be speaking about various things about issues that are faced by women and what could be the possible solutions for this. And I mean, under the UICC, we say that before their diagnosis to life after treatment, all that entire continuum, women suffer from many different forms of stigma with regards to NCDs. Now, the issues could be gender norms, societal views, additional fear of discrimination, feelings of shame, emotional suffering due to the physical harms of NCDs, especially cancers like reproductive system, like breast, cervical, ovarian, and others. And misconceptions run rampant in such situations. So I think that there is this whole thing about taboo that brings about a lot of social stigma and shame. And somehow even the women tend to blame themselves. So what we look at is perceived stigma, which actually is a lot to do with prejudice and discrimination. People are being prejudged. Health-seeking behaviors make treatment choices, decision on traditional remedies, myths, misinformation, stigma, such as harmful mental health, social well-being, prejudice and discrimination. We find word of mouth from one woman to another of NCDs, for example, being contagious, or perceived cancer-related stigma affecting mental health and potentially treatment choices for patients with cancer. So perceived stigma could be misunderstood in Asia. There was a study in 6 Asian countries of prevalence of perceived stigma among advanced cancer patients, risk factors, and also its association with patient treatment choices. So adults diagnosed with metastatic solid cancer self-reported surveys actually showed perceived stigma is unique among an Asian advanced cancer patients. So stigma is important to assess and address, taking into consideration the various socio-demographic, clinical and psychological factors of cancer patients. Now, I'm using the word cancer a lot, but I think it can be related to NCDs. Now, women have lived experience. Their responsibility starts as daughters, as a sibling, as a wife, a mother, a working woman, a caregiver for disabled and the ill, and even as a grandmother today. I find women, after having finished their work life, they end up becoming the babysitters for their grandchildren. Right. And so social expectations are women's health is not prioritized, not by anybody, not by the women themselves. And I think that was also mentioned by one of the previous speakers. Now, they're expected to take care of the family and the home and engage in gainful employment at the same time, whether they are in a farm, in a village, or they're out in the city. So NCD diagnosis and treatment, it is difficult to transform from being a primary caregiver to being the one in need of care. It's such that the woman herself thinks that she should be feeling guilty if somebody is going to take care of her. She's unable to fulfill caring duties, which is expected of her, and disappointment will come into her and she will feel a sense of guilt. Now, responsibility is not always taken up by her partner or others if she is ill. And the risk of emerging nuclear families is another issue that we are facing in our part of the world. So in some communities, there's also a risk of disruption in relationships within the family as well. So you can imagine how the entire family unit can break down just because the woman has got a problem. But if anybody else has a problem, the woman has to fix it. So what are the barriers to prioritization of women's health? Firstly, language barriers. The language barriers are more to do with sometimes healthcare providers are using technical or medical language and the woman cannot understand or her family cannot understand, or she has her own cultural language which she's unable to relate to when she speaks to the healthcare providers or even anyone else in the city where the hospitals or even the care centers are. The distance to medical centers and transportation issues to alien cities. Have you seen people from the village come to the city and they're looking very strangely around because they just cannot connect with the city. Gender imbalance among healthcare providers, especially people in the specialist line. We have more men than women sometimes in some parts of the world, where if the woman wants her intimate parts to be examined, she may refuse, or the person who so-called owns her body may refuse. So I'm going to say owns her body. Who owns the woman's body? That's a question we should be asking. Shortage of women healthcare providers closer to the home. Okay, and because of that, long distances may have an impact on the woman not even seeking healthcare services. Even if she decides to do so. Financial loss and time away from responsibilities. If she has children to care for, then she has to leave the children with somebody and she has to pay that person. So that's a financial loss. If she's working in a farm, she'll be losing income for that day or for the number of days she's going to be away. Mistrust in Western medicine and healthcare providers. There's a paternalistic approach as well, but there's a mistrust in Western medicine approaches, and that creates a preference for alternative remedies as well. Availability of misinformation. There's much more misinformation than information available. Rely more on religion and prayer. Some communities prefer to just rely on prayers and religion, thinking that the problem may go away. Availability of fatalistic mindset. There are some communities that are fatalistic when certain diseases take place. And they think that nothing can be done. That's my fate and I'm going to die. Limited access to health information, be it through word of mouth in the community or whether it's from healthcare providers who sometimes don't have time to spend with the woman, and also out-of-pocket healthcare and other expenses that may stop her from having to receive services. So what are the solutions? Empower, enable, enforce the fact that they are equal citizens in their country. So women are looking for hope and reliable and trustworthy support and solutions. Now, changing the narrative from healthcare expenditure to healthcare investment is very important for our governments, because healthcare is always looked at as an expenditure. It should be looked at as an investment so that after the people have been given treatment, they can continue to live productive lives and be a contributor to society. Harnessing local resources that are available as having one point of contact from the community. We are beginning to see women leaders in communities, in villages, who can actually take on the role. Like in Malaysia, we always have one woman in each village among the leadership who is in charge of women's health and welfare. And she can be the main point of contact. And I'm sure in most countries, we can start developing such a position. Or even women. I've heard about India, the Panchayat, they have the Sarpanch being a woman in some of the places. So maybe you should keep pushing for that, to have more women in leadership. Task shifting, going digital. Power of the mobile phone, you just do not underestimate that. All you need is one person in a family for patient-reported outcomes, and also connect with healthcare providers. You can collect data online as well, and management of side effects, medication issues, any other things. If there's an app and they can be taught how to handle in a simple mobile phone, is all you need. And in 2023, WHO had launched a framework of meaningful engagement of people living with NCDs and mental health and neurological conditions. This is mainly for participation in health as a human right, and that our lived experience is invaluable for understanding barriers, identifying solutions, and planning policies, programs, and services with us included. And we can also aid in accountability for it. So it's important structural, cultural, capacity, and resource challenges to realizing the full benefit of engaging with patients. And among patients, there are many women. So I think that this is one way we can go through. We've got our foot into the WHO door. A recent Lancet Commission on Women, Power, and Cancer has been found, and this is now being rolled out in different countries. It's basically for policymakers and academic and medical institutions must fully recognize the value of patient advocates and patient support organizations, and also to have shared decision-making and sharing power with patient representatives. Storytelling is powerful, but more importantly than that is not just telling a story, but you need to have information, education, awareness within that story itself. Humanizing Healthcare was a position paper that we had developed in the International Experience Exchange for Patient Organizations, and it's a roadmap for change which includes people at the heart of healthcare, health literacy, digital healthcare to build the capacity by harnessing the power of patient data. Humanizing healthcare should include 50-50. This was a survey done where we found that people actually responded and said there should be a 50-50 model of prevention and cure. And so we will not be called Ministry of Sickness and could be called then Ministry of Health. Prioritizing diversity, equity, and inclusion. I think Chand had just spoken about that, because you need to make sure that everybody, every human being, we are all diverse in our cultures, in our way of life, and we can be included, because we will enrich the healthcare system a great deal if we are included in it. Communication skills, not just the patient's communication skills, the healthcare provider's communication skills. When breaking bad news, when talking to the patient, you need to speak in a language that the patient understands, not the language that you understand. Woman to Woman is another program of peer support, which is a reach to recovery concept, which says a woman with lived experience of breast cancer can actually provide psychosocial support, practical information, and navigation to the woman who is newly diagnosed. And This also includes reach to recovery, support, and early detection programs. And we have these programs throughout the world, including Malaysia. In Malaysia, we also have the community outreach services in villages, where Murni, which is a mobile clinic where we provide clinical breast exam. Our nurses provide clinical breast exam for women and also talk to them. They have conversations with the women to find out what other health issues do they have and how they can be navigated into the healthcare system through the village clinics, and where we educate the village clinic women that there is a change now in the dimension of not just maternal and child health care, but more than that. So validated socio-educational storytelling, which is what I was talking about. We can leverage on Asian and African culture and tradition of storytelling, which can be done face-to-face and through YouTube. But they must have embedment of education in it. And this is now being included in the Lancet Commission as well. And a one-stop NCD center in the community would be a great help, because at one time there used to be one-stop help center for maternal and child health in villages. And I think we need to now graduate to NCDs and other emerging diseases. And that could even be things like enabling women to receive information, advice, and rehabilitation for, let's say, stroke support group, diabetes support group program, and in need of those who are in need of help from those with lived experience and also from healthcare providers. This is the National Association for Stroke Patients in Malaysia, where we have such a program. Now, educating GPs to practice prevention, where they can actually provide information to their patients, they who are closer to them, their clinics, and also managing medication and long-term side effects. I remember I was a student of physiotherapy at one time, and the patient came to the doctor to see for a follow-up. And the doctor said, did you take your medication? She said, yes. And then he said, so are you following the dosage? She said, well, it wasn't getting better, so I took all the medication together. So the thing is, you need to have that communication, ongoing communication, so that people can learn as to how people in the communities are actually taking their medication. The other thing is long-term side effects of certain NCDs, where we can actually address that issue with the inclusion and with the active participation of people living with such conditions. The other thing is harnessing the education system, including young people from secondary school and universities, to do community-based projects to create solutions for empowering and prioritizing women's health. Learning also, they would need to learn from the grassroots women and community, and through community education, they will be one day graduates or even as medical professionals, and they can be mindful as to the fact that there is a cohort of people existing in the community. With that, I thank you for listening. These are my references.
Thank you, Ranjit. And I think what you said in the middle of your presentation, empower, enable, and give them an equal space at the table, sort of sums up, the whole stigma and misconceptions around gender and women's health and NCDs. So thank you for putting that all together. I'd like to now invite Surita Morgan, who is an endometriosis patient, and she has been suffering for 28 years. As a patient, she's currently the president of Persaudan Endometriosis Malaysia, or My Endosis, and she's going to be speaking about endometriosis and lifelong diseases. So over to you, Surita.
Good evening, everyone. Thank you for the lovely introduction, Dr. Ratna, and of course, a big thank you to the organizers for inviting me here. Now, I'm truly honored to speak on this first International Patient Summit, and the organizers, I believe, did a fantastic job of giving patients a voice, especially patients like me, to speak about my debilitating illness. Now, my area is actually on endometriosis. I don't know whether you've heard of it or not, so yes, I guess I could see some of you nodding your head. All right, so yes, well, frankly speaking, not many people know about this, and it's really a hard journey to explain what this condition is. Now, I am aware that I'm the last speaker, so I'll try to make this quick. And I've also made my slides a little bit vibrant, although it's on a gloomy topic. Okay, so I'm going to move on. Now, yes, can you see? All right, so before I move on and speak about what I have to tell you, I would like to highlight this. I'm actually part of the Asia Pacific Endometriosis Expert Panel meeting, which was held in Singapore last year. Now, the outcome of that meeting is a journal article published in the Journal of Gynecology and Obstetric. Now, I will cover some parts of that discussion, but of course, due to time constraint, okay, it's never easy to speak in 10 minutes. So I'll try to do as much as possible. Now, let's move on. Now, if you look at what I have for you here, now, like I mentioned just now, not many people know what is endometriosis. So I'm just going to give you a very basic definition. Now, endometriosis is a chronic systemic inflammatory disease characterized by the presence of endometrium-like tissue in the reproductive organ. Now, to make my talk clear, you can see the difference between a normal uterus and a uterus of a woman with endometriosis. There's definitely a difference, right? Of course, the image on the right does not represent the uterus of all endometriosis patients. We do have different degrees of severity. And as you all know, all right, I think some of you might know that when you talk about endometriosis, there are different types of endometriosis and there are different levels as well. So the different types would be endometriosis of the bowel, which I have endometriosis as well. I have adenomyosis, which is the endometriosis of the uterus wall. And I do have a member who has thoracic endometriosis, which is endometriosis of the lungs. So there are different types of endometriosis. Now, I'm going to move on, all right, about just quickly, just tell you a little bit about this. I know some of you might be wondering, is this common, all right? Well, globally, the prevalence of endometriosis is estimated at about 6 to 10% of all women in their reproductive age. Now, that's 6 to 10%. Relatively high rates of endometriosis have also been reported among women of Asian ethnicity. All right. Now, what do you think of that? Now, that is disturbing because we all know for a fact that the Asian region comprises approximately 60% of the world's population. All right, the disturbing trend is the diagnostic delay. All right, you wouldn't believe this. If I tell you this, there's a diagnostic delay of up to 6 to 8 years from the onset of the symptoms. And I myself was only diagnosed 9 years later. After repeatedly being dismissed by healthcare professionals, the society was not very kind. And of course, in this day and age, all right, we're still seeing the same outcome. Young girls are being dismissed. And I believe this is really unacceptable. Now, there could be multiple reasons why women and girls are being diagnosed late, all right? So I have a lot of reasons, but because of time constraint, I'm only going to talk about some of it, all right? So basically, when you talk about some of the reasons, that I would like to talk about is the subjectivity of endometriosis. Now, there's not many people around us who know the difference between normal period pain, dysmenorrhea, and not normal period pain. How do we know if we have reproductive issues or if we have endometriosis? So this is because we're not educating the women around us. We're not educating young girls in school. Now, in my country, in schools, girls are taught menstrual hygiene, but they are not taught about what is considered normal period pain. And this is very disturbing because endometriosis is a debilitating health condition. It gets progressive and it gets worse as the years go by. And when they do seek treatment, some of these patients, when they do seek treatment, it'll be too late. And by then they will have other issues as well. Now, the other possible problems would be some of the symptoms associated with endometriosis is associated with other disorders such as irritable bowel syndrome, sometimes constipation, diarrhea, gastric. So that complicates matters. And of course, the biggest problem, I think I've echoed some of the thoughts mentioned by our previous speakers. I think the biggest problem is the social norms associated with this period pain. Nobody wants to talk about periods. It's considered unclean in some cultures. It's a taboo topic to be discussed openly. And even women are not comfortable to talk about this openly with other women. All right, so conversation about menstruation is inhibited all the time. And this is again something we need to break. Okay, moving on. Now, talking about the stigma associated with endometriosis, and of course about chronic period pain, there is this assumption that chronic period pain is nothing compared to labor pain. That is why we get dismissed all the time. When we do go and see our healthcare professionals, they tend to say, oh, how are you going to handle labor pain then if you cannot handle period pain? So once again, it's a big, big hurdle because pain is synonymous to women. There's this perception that women should tolerate pain. And if we complain about period pain, it's a sign of weakness. And well, this is the problem that we face again and again. And the other thing that I would like to highlight, which I think you all should know, I've been accused of being mentally unstable, all right, at times when I talk about my period pain prior to being diagnosed. And I'm not the only one. There's so many of us who are called crazy, or we are seeking attention, or we're exaggerating our pain. So these are all damaging statements made on women like us who genuinely need care and treatment. All right, so before I talk further on the emotional pain that we experience, let's talk about the physical pain. I purposely made it vibrant, okay, as you can see. Now, the common symptoms of endometriosis is, of course, ovulation pain. So they do have pain before period, premenstrual pain, and during period, it will be severe menstrual cramps, heavy bleeding, irregular bleeding at times, and of course, it comes with diarrhea, constipation, fainting spells, pain during intercourse, and infertility. Now, if you want to know if you have this condition, the sign to look out is this. Some of us, patients like me, we do experience pain even after menstruation. All right, so when I'm, well, before I was diagnosed, I only have like in a month, 15 days of pain-free days. And that actually destroys my quality of life. Now, besides the physical pain, we do experience emotional pain. Now, I think we all know this, and I think I've echoed some of the thoughts mentioned earlier. Physical pain is just a small portion, but the biggest problem is the emotional pain that we go through. Wait, hold on. Yes, where am I? Okay, so some spouses, basically, as you can see, when you are in pain, if your spouse is not aware of endometriosis, they tend to believe that you're mentally unstable as well. So there are spouses who leave their wives when they are in pain every month. And of course, around 30 to 50% of women with fertility issues do have endometriosis. Well, we're all expected to conceive. Okay, so women's role in our society is reproduction. And in some societies, if we are unable to conceive, we are looked at in disdain, and we probably do not get the respect that we need. All right, so we are very harsh on women who cannot conceive, and that's what we face as well. Okay, now for single women, it's hard for them, all right, like what Chan has mentioned just now. How do you explain to your future partner that you have endometriosis if you're being diagnosed with endometriosis? How do you explain to them? How do you explain to your future partner that there's a possibility you might not be able to conceive? So that itself can cause a tremendous amount of emotional pain and anxiety to especially young single women. So what about the working environment? Now, if you look at the working environment, there's always the reason given by some employers that we spoke to, that they believe initially that employees who complain about period pain are lazy, or they're just simply avoiding work, and they tend to demote these patients, okay, without really understanding these patients' difficulty that they face. So definitely, even the working environment becomes very inhospitable to patients. And many of these patients tend to leave or they don't work. And we're losing a lot of these talented women in the workforce. Now, endometriosis is also associated with heavy economic burden, including direct cost of physician visit, surgery treatments, and of course, monitoring tests and hospitalization. Now, this is definitely difficult for girls who do not have insurance, or girls who are probably, or women or girls who are probably unable to finance their health issues. And of course, studies reported that women with endometriosis lose a mean of 11 hours of work per week due to absenteeism, while more than 6 hours per week were lost in reduced efficiency while working, presentism. Now, as expected, women with endometriosis are significantly more likely to experience mental health challenges affecting their quality of life. Now, look at surgery itself. Recovery from surgery will take 1 or 3 weeks. This is laparoscopic surgery, and laparotomy surgeries will take 1 or 2 months of recovery. And some of the fertility issues that they have to go through, some fertility treatments that they have to go through, such as IVF and IUI, can be detrimental to them, can be agonizing, can be difficult to explain. And this definitely will be the loss of quality of life that we always speak about. Okay, so what about medication? All right, coming back to medication, women like us, we do rely a lot on pain medication. Some of us, our pain medication does get stronger, and we do have hormonal medication that we take as well, including some oral contraceptive pills. Now, some of these pills do work for us, but there are pills and medication that have side effects, such as weight gain. All right, we all don't like to gain weight, do we? Right? So weight gain is an issue for women. Of course, some other side effects are gastric pain, drowsy, constipation, diarrhea. And we ever wonder if all this can actually give patients the quality of life they need. Now, moving on to the next one would be, I promise you, it won't be long, all right? So the next one is the myth on endometriosis. Now, the society, even healthcare professionals, still believe that there is a cure, okay? So currently, there's no definite cure. And we do see healthcare professionals who are probably misinformed. Some of them do tell patients that the solution is to get pregnant, okay? So sometimes we do have our members who are single who come to us and say, I don't have a spouse, how do I get pregnant? Okay, so yes, we do get advice from our healthcare professionals who probably don't know how to actually treat the patient, okay? So the other thing would be some HCPs do tell, healthcare professionals do tell patients that surgery is the solution as well. Well, it does work for some, but again, it does not work for many. All right, and I think a lot of healthcare professionals are not talking to patients about surgery, laparoscopic surgery, laparotomy surgeries, because surgeries such as this can be intrusive, and it does cause an impairment of the fertility or egg reserves, okay, which the patient might face challenges in future. All right, so the last point that I want to make would be hormonal medication. All right, of course, there's this perception that if you are on hormonal medication, you are fine and you're magically cured. That's not the case as well. So these are all endometriosis myths that we are trying to address, and we are trying to open and speak about openly to the society. So what can we do to help women with endometriosis? How can you help in your own country? Now, we can start by increasing awareness of endometriosis by educating our community as well as HCPs, which is healthcare professionals, because we fail to see things holistically. Now, we all know that women rely on our society, and society does make decisions for women, all right? A lot of times we don't make decisions on our own. We do speak about this to our spouse. We do speak about this to our family members, our mothers. So we need to educate as many people as possible, and that's what we're trying to do. We're trying to create awareness of endometriosis, and we are trying our very best to reduce the diagnostic delay by creating awareness to general practitioners as well. Now, general practitioners are the first, I would say, gatekeepers, and they are the ones who would recommend or give a reference letter to patients to see a gynecologist. And a lot of times in the past, just looking at my case, I've been dismissed many, many times by gynecologists. So we are also supposed to educate our gynecologists, and that's what I'm doing, and that's what our society is doing. We're trying to speak to healthcare professionals as well as to what patients like us go through. Okay, so, oh, I forgot, I didn't move to the next slide. So awareness campaign is important. And of course, reducing gender pain gap. I don't know if you know this. I think some of you might know this. Why is it that when men come in and complain about pain, they are taken seriously, but when women come in and complain about pain, they are not taken seriously? So there's this huge gender pain gap that we see, and there's a lot of studies done. I can go on and on about that, but I know time is a factor. All right, so finally, acknowledgement and empathy. All right, please try to understand when you see people around you talking about their menstruation or their menstrual pain, or even anything associated with period pain, please try to acknowledge their pain. And of course, practice empathic listening. Okay, that's important. That's the first line that we should do to support women, especially young girls. And lastly, of course, flexibility should be created in our society, flexibility at home for women who with chronic period pain. They should be given time to rest. A lot of them, they do not have time to rest. And a lot of women, they do multiple tasks at one time. And some of us, especially women with endometriosis, we fail miserably when we have to take care of our children, when we are in so much pain. And even at work, flexibility should be given. There should be work from home programs created, especially for women with chronic condition, all right? This is to avoid, again, to avoid women from leaving the workforce and to create that necessary retention. Okay, our society has been always pushing this through in our own country. And I know even in Malaysia, it's considered a regressive idea. Now, we are trying to push for menstrual leave. Now, for some people, menstrual leave is a backwards movement or it's a regressive idea, but it's not. It has been implemented in Taiwan. It has been implemented in Japan. It has been implemented in Spain. Menstrual leave, we believe, should be given to women with chronic period pain with the support of a letter from their gynecologist or specialist. And that should be done because we want to work. It's not that we don't want to work. And a lot of us are talented. And of course, a lot of us are educated. And we don't want to just give up our work just because we cannot perform. All right. So the other thing would be, we are trying to push this policy in place in our government. And of course, it's a long, long hurdle, as what I mentioned to Ranjit as well. It's a long hurdle. Actually, we're trying to push for companies to actually create that incentive for them to actually support women's health or women's reproductive health. And we want the companies to encourage normalizing talking about period pain as well. So these are some of the things that we're trying to push our government. And of course, you can actually suggest this in your own country. Now, please try to help us and of course, join us in our movement to end the silence on endometriosis. Do look us up. We do have a website in place. We're known as My Endosis. And of course, I'm happy to collaborate with anyone in order to decrease misinformation on endometriosis. Thank you very much.
Thank you. Just a couple of points. You mentioned about endometriosis being beyond the uterus. So you have bowel and, bladder endometriosis. And these patients sometimes don't go to a gynecologist. They go to a general surgeon, or they might go to a urologist who are not sensitized to endometriosis. And therefore, there is a delay in diagnosis. So in your opinion, do you think there should be a multi-specialty awareness and sensitization to endometriosis, especially fertility specialists? Because a lot of time, endometriosis is detected when infertility happens and they go for fertility treatment.
Very true. If I was given more time, I would actually talk about this. Actually, you see, in the healthcare industry, doctors are working in silo. Different departments are not connecting with each other. They're not talking to each other. And for women like us, it's a big problem because we do have other parts of our organs that are affected. And that is why we have women who are misdiagnosed. I was actually misdiagnosed for a very, very long time. I was told that I have irritable bowel syndrome. So I went to see a different doctor and nobody could actually connect the dots. So I agree with you. I think it's very important to get different departments, different speciality to work together, because what we see now in every hospitals, they're all working in silo, especially on reproductive health. And I think there should be a change in this.
Thank you. Any questions from the audience? Yes, Nidhi.
Yeah, I just have a comment. Yeah. Amazing work that you're doing.
Thank you.
Keep it up. The other thing I just wanted to share for everyone's benefit is I was attending the British Medical Journal conference, and an advocate had a video share that they have been working with Hillary Clinton on creating awareness around endometriosis. So an average of 10 specialists are consulted by many such young women, and it takes many years for diagnosis. So it's really important for many of us to be aware of such conditions and doctors to realize that there could be this underlying condition, like even Ratna mentioned, that there should be this cross
Definitely.
dialogue.
I agree with you.
Yeah.
And Dr.
So
Ratna, yes.
delayed diagnosis is such a trauma for women going through all these things. So thank you so much for sharing.
Thank you so much.
Yeah, it's not just the clinical specialties. A lot of times the sonologists miss the diagnosis because they have not been trained to read the scans, especially MRI or transvaginal ultrasound. And therefore the diagnosis is missed, and that is the reason where there is a diagnostic delay. So the gynecologist might suspect, but then because there is no definitive diagnosis except a laparoscopy, which in young women, it is not usually the first choice. They try to do an MRI. MRI will detect about 75 to 80%, provided the sonologist is trained to read those scans. So that's a big gap that is there.
Yeah, I would also call for more research in this area.
Definitely. I'm
right?
actually doing my PhD on endometriosis, especially on the challenges healthcare professionals face when they communicate with patients. So to get a better understanding on what are the things that they go through and from both perspectives as well. So I'm doing my study on that, and I've been doing a couple of studies. You can actually see and look up on some of my studies that I've done in the past. Thank you very much.
More power to you, and Ranjit wants to say something.
Yeah, I was wondering whether there's a possibility of doing a survey in schools among girls with a checklist of what problems do they face, if they have a list of possible issues like pain before periods, pain during periods, and where the pain is, or you feel like going to the toilet more often during periods, or your periods are very, overflow and things like that, heavy periods. I mean, if you have a checklist like that, at least they can do a self-reporting and then that can be taken to the next step to actually find out what really is wrong. And then that's where we can highlight that endometriosis could take place. And this is one way of doing a pre-checklist to find out, because we find that among schoolgirls who actually complain of severe period pain, they don't come to school, or young girls who are working and they start having problems, and you see a pattern of absentees from work or from school. And I think that's where we should pick up. School is the best place actually for teachers to pick up and actually take action on it.
Yes, coming to that, okay. I think Ranjit brought up a very important point as well, where we are trying our very best to also go into schools. We have started small initiatives, speaking to schools personally based on invitation. We've started with Methodist Girls School. And of course, last year, we actually spoke to teachers. Now, this is the reality. Sometimes teachers dismiss girls who complain about pain. And of course, some teachers can be very harsh. They do, they do break these little girls' hearts, So by telling them that, oh, if I can handle this, or how are you going to handle labor pain? Now, I think educating teachers would be the best thing for now, all right? We have a long way to go, and I hope our association, of course, we hope that we can actually collaborate with more people, and especially school teachers and even schools, to actually go into schools and universities to educate teachers and of course lecturers on what are the signs of endometriosis that they should look for.
And just on that topic, with the work that we do with PCOS, we are active in schools, but we have to be very careful because we do not want to there's already a stigma around women's health, menstrual cycle, and we don't want to put a further stigma where we are endorsing or advising people of PCOS, endometriosis, and when we input a fear in females. So we have to be very careful in terms of within what we can put within schools. We have said that in UK, there's a lot of, in UK, we do sex education, but we also should be advocating women's health and men's health. But again, just because I do it on the advisory board, just be careful in what information we give out in schools, because we do not want to fear the individual that just in case she's missed her period and that's it, she's put in fear.
Very rightly concluded, ladies and gentlemen. What better platform can we have when we have all the age groups here, power-packed women sitting here, from the young ladies to grandma to mother. And yes, we have promises and we can see that future holds good. Yes, ma'am, you want to say something?
Yeah, just a short question because everyone seems so tired, but this is very interesting. You put in the last section that to keep people staying, right? It's interesting, all of you, especially Chan and Surita, because it's quite new for me, this disease. And just we are talking that I don't think whether it's already in Thailand talking about this disease or not. But it's good that I learn from here, and then if we can have knowledge, we can carry back, and then we can just distribute, because now we are very interested and encouraging about patient educator. Actually, we were talking tomorrow about, we have one workshop about patient educator, but just by last time we concentrate in the heart disease, kidney disease, and diabetes, that is comorbidity. But this is something special, and it's also good to know. I'm just want to ask whether if you have some information or guidelines about this disease, in short, easy to understand, and then if it's possible to translate, or we can translate into Thai, or you translate in many languages, and you put in the website or distribute, then it's easier for us to just share and download, and then we can just distribute to or explain to other, especially like Ranjit, you said. I agree with you, totally agree. We should have some knowledge, educate in school, like the HIV/AIDS. We already have that in school, right? Thank you.
Just to add on that, as a charity, we provide our information in 9 different languages because we do not want a language to be a barrier. But also in terms of, I was actually in Mexico in deprived areas, and we done a workshop in terms of how to actually use women hygiene products, because some females don't actually know about what women hygiene products is, what sanitary pads, how to use it, how to keep themselves clean. So in terms of women's health, we are also actively encouraging females in terms of how to keep themselves, how to clean and protected. So yeah, definitely. And of course, translating in different languages is, is that accessibility in terms of women's health, because there shouldn't be a barrier to language, and information should be available in all languages. And actively, we do provide ethnic minority workshops. So we get like a community of Muslim females, a community of Chinese people, everybody together. And that allows us then, when we do policy making, decision making, to say, well, actually, the Chinese community raised this concerns, the Muslim community raised this, and how can we support these communities? So then we really get very niche data and how we can support PCOS within every community.
I guess, yes, you are right. She did save, best for the last. But yes, thank you, Chair and Moderator. It was a very power-packed session. We look forward to all the changes that, yes, society can bring. Ladies and gentlemen, what an incredible day it has been. We today mark a beginning to an era with a promise to continue to bring awareness on, yes, equitable healthcare with inclusion of patient voices and lived experiences. And to put your notice, we have already made an effect how Hotel Fraternity has just gifted us with an high tea because they got so inspired with our session. Please, ma'am, I would request you all can have a group photograph here to conclude our session. Yeah, do we have ma'am online with us?
Yes.
Thank you, ma'am. We hope you've had a wonderful time, made new connections, and taken away valuable insights and memories. Remember, the spirit of today's gathering doesn't end here. It will continue to inspire and connect us for a greater purpose. Once again, I take the opportunity to extend my heartfelt gratitude to the organizing committee, Ms. Karen, Ms. Aurojit, and Dr. Ratna Devi for dreaming of this day. As we say, if you dream it, you can achieve it. Please, a round of applause for this event. Yes, yes, please. As I said, yes, it's a high tea. You all are requested to join and make more memories together. So thanking you, ladies and gentlemen, respected dignitaries, honored guests, all our delegates for your august presence. And it is our honor to invite you all once again for the evening dinner here at the same Mahal Hall. Thank you, ladies and gentlemen. The dinner will, I guess, it'll be at 7:30, right? Thank you. Please.